the EOScope session today. For this session, I call upon Dr. Girish Harkut and Dr. Manoj Agrawal to be the chairpersons. Please occupy the first row. And Dr. Sorensen, sir. Yeah, we'll be starting with the first lecture. The first lecture is by Dr. Santosh S. from Bangalore. He will be speaking on journey from microscope to endoscopic ear surgery. Dr. Santosh S., please.
Done, sir. Now. Aya? Okay.
Good morning, everybody. I thank the organizers for giving me this opportunity. Can you hear me? Yeah. So I thank Dr. Sapna and Dr. Khan for giving me this opportunity. So I would like to take you on a short journey with respect to my experience with endoscopic sinus surgery. So the techniques and principles of ear surgery, whether it's microscopic or endoscopic, remains the same. There's no change. It's just the way you do it. And the most important is the incisions, the grafts, the dissection, graft placement. But most importantly is the person who's doing it. The surgeon has to be open for changes and he has to be dynamic. Successful outcome of the surgery depends on the versatility of the surgeon. It is not the same incision and the same graft for all the surgeries. You have to change according to the patient's need. That makes your success in your surgeries. So in 2006, I was doing my residency, and that's wherein the endoscopic surgery was being done with minor surgeries like grommet and intratympanic gentamicin or steroids. And then subsequently, I was doing it combined, microscopic and endoscopic, but you can see this. So in 2011, a patient was induced, and it was a case of cholesteatoma, and the ENT microscope had crashed. So I was using the neurosurgical microscope, and there was an emergency craniotomy, and the neurosurgeon pulled away my microscope. So, and I was stuck. Patient is intubated, I can't extubate. So that's when I ventured completely into endoscopic, and I successfully was able to do the surgery with an endoscopic surgery on the cholesteatoma. So sudden hearing loss. So I call this as intracochlear treatment. I do it a little differently. I give the cannulol incisions and no, it's playing. Sorry, it's not seen here. So I give the canal wall incision and instill any drug into the cochlea. The receptors get saturated and there's no role for multiple injections. So sudden hearing loss, I call it as a ear attack, like a heart attack or a stroke. And that's the only chance what you have to revive the ear, because once the hearing is lost, and that's the end. And that's the result. Usually have very good results with pre and post surgeries. So here you can see the various techniques of the tympanoplasty. I call this as the garland flap, which is my favorite. And that's the conventional, typical canal wall incisions. And that's the video showing grafting with various grafts. That's a cartilage with a slit for the malleus and placing the graft. And this is an interlay perichondrial grafting. And this is the classical underlay perichondrial grafting. So here you can see that no ear surgery has a single technique or a single graft. You have to design your surgery as per the pathology and as per the requirements of the disease to have a successful outcome. So here in this garland flap, I preserve the superior pedicle for the vascularity. So take a typical incision and take it all the way around. The beauty with the endoscope is that you have a 360-degree view of the ear canal, and then you lift the whole flap up, and then you can see that you have the whole middle ear exposed, and then you can do the grafting. The issues always is your anterior and the anterosuperior area, where you generally tend to have a drop down or a residual perforation. And in this technique, you can drape your graft onto the anticanal wall, and then you can do the outcome of the surgery is going to be very successful. Yeah. So grafts are various. So I usually prefer this composite graft, where you have a perichondrium with a rim of cartilage, gives a very nice anchoring to the graft onto the canal wall, and then you do the tympanometal flap. Thanks to Sapna and Dr. Khan for those beautiful innovative instruments, which makes your life easy. And that's the results of tympanoplasty. So you can see that the pre and post-operative outcomes have been very good in these patients. And that's the second case with a large central perforation and then the grafting. So mastoidectomy in an endoscope in the post-oral is a tricky situation, because our mind is so used to going with the microscope. So, but after coming to Dr. Khan, I got the just attached, and following which the post-oral mastoidectomy has been very comfortable. This is a case where there's a tegment defect, a reconstruction with the conchal cartilage. Stapes is a beautiful surgery. If you do it right, you have the best results. So this is a patient where patient had this one. So I do the conventional canal incisions, tympanometal flap elevation. Depending on the canal, you can determine your steps. If you have a wide canal, you can even do it without curating the posterior part of the bony canal. So here I had a very beautiful canal, so where I didn't have to curate, nor I had to, remove the chorda. I was beautifully able to visualize. I do the reverse stepidotomy, so I don't dislocate the incutostepedial joint. The soft clip is very beautiful for endoscopic stepidotomy, very easy for you to place your clip and you reposition. And I don't remove the stapes structure. I disconnect, make sure it's connected, and then I break the cartilage and then reposition it and leave it there. So, because you're going to remove it and throw it, you're not going to have any benefit. And that's the results. So drilling was a challenge, some little bit of, jugaad, put a cannula there and then try to prevent the canal injury. Thanks to Dr. Khan for his drill guard, which has made a difference. This is a small glomus tympanicum. I did it endoscopically, and of course, I don't have the video, but I use the coablation for this. It is fantastic. It makes your life even more easier. because you have suction, you have ablation and coagulation. Ergonomics of ear surgery. All of us are only looking at patient. We need to look at ourselves. So what really makes a difference? So I use the slave monitor. This is thanks to the surgical gastro. They have used this. So those who can afford, this is the striker system, and those who can't afford, you can just have a simple Dell monitor with a connection like this, and you can do that. Why? Because you can save your necks, because after long surgeries, you have your necks. So that's in a double hand. In a single handed, I sit on very comfortably. I support my elbow on the armchair, and then I do it very comfortably. So there's no movement. So because the movement is, so stabilizing endoscope is the key for the surgery. Something different, I use an Olympus nasal sinus endoscope, a pediatric STARS, and I use a laparoscopic pediatric endoscope. Why? It makes a huge difference. It gives you a huge length, gives you more working space. You can see the working space. This is with a sinus endoscope. My issues with endoscopic surgery has been mucosalization, which has always been a challenge. Thanks to endoscope during COVID, I was still able to operate. So with the just attach, makes a huge difference, makes you more comfortable with double-handed technique. The other uses of just attach, I do even microlaryngeal surgery with the endoscope. So to conclude, endoscopic surgery, minimally invasive alternative to traditional surgery, scarless, better visualization, can treat different pathologies, a steep learning curve. It's very important. So it's always imperative that you train the residents with microscope and then evolve them to an endoscope, so which makes them better. Thank you.
Thank you, Dr. Santosh. Your journey has really been remarkable. Now I call upon Dr. Dhruvo Roy, who will speak on internal carotid artery segments and classification for skull-based surgeon. Dr. Dhruvo Roy, please.
Yeah, monitor.
कैसे से
हाँ बस दबाना है
इसको
बस
अप डाउन
कुछ
Side up.
नहीं स्लाइडर के लिए इधर रखा ठीक कौन सा विच वन से
कैरोटिड इंटरनल कैरोटिड
ये वाला
अब याद नहीं आ रहा है सीओ लिखा नहीं है इतना सारा याद इसमें ठीक है वही होना चाहिए देखिए हाँ
कौन सा?
सीओ वाला
ये है ना
फुल स्लाइड अप डाउन कैसे हुआ
नेक्स्ट है ये प्रीवियस है
कौन सा
दिस इज द नेक्स्ट दिस इज द प्रीवियस ओके जस्ट कैन यू ट्राई meanwhile you can do and we'll do it Hey, give a caller mic.
For giving me this opportunity to have a small discussion on this very important thing of internal carotid artery. This comes across our fields of work, even in the ear, even in the temporal fossa, even for the endoscopic ear surgery, nasal surgery, even for the pituitary fossa, wherever you are in the sphenoid. So the idea of the artery, its nodes, its anatomy, and its classification is very important. So when I was going through my initial stages of studying about the anatomy and the classification, I had a lot of confusion. So I thought, why not have a small discussion and all of us can benefit from that. So I'll come across, we'll just go first with the anatomy, a small bit, and then the classification. As we know, the carotid artery at the level of around C3, C4, we have the ECA and the internal carotid artery, they bifurcate. And then from there, it goes up into the carotid canal at the level of C3 in the carotid canal and inside the petrous bone. It has three parts. We have the posterior genu, the vertical part and horizontal part. As we saw yesterday during the dissection of Dr. Jain, it is very closely related in that temporal bone with the carotid artery very closely, and sometimes also you must also remember the relation of the artery with the eustachian tube. Especially when you are doing something in the nasopharynx, the people who are doing endoscopic procedures through the nose, doing nasopharyngectomy and access to the eustachian tube, the cartilaginous tube and the bony tube, they have a very close relation with the carotid artery. So we must have an idea, like we are doing, say, a debrider assisted adenoidectomy. There's no scope of injuring the entire carotid artery. It's around 1 to 1.5 centimeter deep to the eustachian tube, fossa of Rosenmuller area. So now going ahead with the artery then again from coming out after the petrous bone, it immediately lies on the foramen lacerum. It doesn't, it's not a content of the foramen lacerum. It doesn't, it just goes above the foramen lacerum. It curves superiorly. And then its course is to the high up. It goes up from there to the petroclival ligament. Then it enters the cavernous sinus. From there, it goes anteriorly, has two bends. And as a carotid siphon, you can see when it enters into the dura, going medial to the anterior clinoid process. So that is in short. Now we have some sort of confusions here. What is the genu? What is the bend and all that? So there are two genus, the anterior genu and the posterior genu, and there are two bends. The bends are high up. And we have the clinoidal part there, the bends are there. The two bends are there. And two genus, the anterior genu and the posterior genu, down there near the foramen lacerum, and when it enters into the carotid canal. This is a big confusion out there. A lot of classifications, and everybody is defining the artery in their own way. Well, so there are two bends actually, C3, C4 bend, C4, C5 bend. That's what I was talking about. And when you are seeing the carotid artery, we are seeing ventrally, the endoscopic surgeon, and he thinks in his own way. The lateral skull surgeon thinks from the lateral aspect. So we have to combine both. The 360 view, as we all know, if you don't have the 360 view idea, we'll have confusions. So when you're doing the lateral skull base, it's a different attitude. When you're doing from inside the nose, it is a ventral. So even when you are doing some procedures, say parasagittally, like so you're working on the infratemporal fossa and all that, the idea of the carotid artery should be very clear. So this is in short what I was talking about. The genu. See, this is the genu, and then you have the anterior genu here when it comes out to the foramen lacerum, and it goes up to the clival. This is the paraclival. It's better seen in this. Now, this segmentation, that was what I was talking about. Everybody has their own classification. The Sinisati classification, the Bothelier classification. There are a lot of classifications. Even if we follow the Bothelier classification, so C1, C2, C3, C4, then the siphon, and then it goes interdural. So we have a small extradural component here over the foramen lacerum. This is again the same thing here. You can see the dural rings, proximal and the distal dural rings. These are very important because this is the clinoidal segment of the artery. It's very important. And the bends, you can see there are two bends, as I was talking about, C3, C4 and C4, C5, in short. Let's skip this. This was what I was talking about in the parapharyngeal area. When you are entering through the endoscope, this is the access to the carotid artery. See how deep it is. Between the two muscles are there, the tensor valerii palatii and the levator palatii. The tensor palatii vertical muscles, you dissect that and go to the eustachian tube, and the levator palatii is anterior to that. So this is the parapharyngeal access. And this is the entry of the carotid canal. I show these small areas where you are entering. This is the area where the carotid canal is seen after removal of the cartilaginous tube. When you remove the cartilaginous tube, you have the artery out there. And then here the endoscopic endonasal view, this is the posterior genu of the intercarotid artery beneath the bony eustachian tube. So the bony one is closely related to the ICA, and this is the posterior genu, not the anterior genu. This is again in the middle ear. We saw that yesterday when Dr. Jain was dissecting. The relation with the tensor palatii and the tensor muscles. I'll skip this. And in the ear, we saw this yesterday. This is inside the petrous bone, the arteries, so near to the cochlea as we saw yesterday. And the entire ISC is here. And we'll skip this. And these are all endoscopic views. So this is a very important chart which shows you the relation. the foramen lacerum, anterior genu, posterior genu, the bone eustachian tube. So this is the relation of the eustachian tube. In the ear, we are very accustomed with this, the people doing lateral skull base. This is the endoscopic view. And now inside the sphenoid, how it looks. This is important. These are the two things where we get confused. This slide is important because what is the maxillary strut and what is the optic strut? These are two important things which all the neurosurgeons talk about and the ENT surgeons talk about. This piece of bone out here, within the foramen rotundum and the superior orbital fissure, and that is the maxillary strut. And this is the pneumatized anterior clinoid process, the optic canal out here, and this is the optic strut. Here is the anterior clinoid process. These two things are we come across usually when you're doing procedures. This has to be very clear. These two pieces of bone, this and this. So this is how it looks inside the sella. So you have the clinoidal segment here. You have the MOCR, and this is the clivus. This is how it looks inside the sella. This is another view of this sella. Another, not this one. Yeah, this one. This is the panoramic view. Here, petrous, clival, sphenoidal, and this is the cavernous segment. So somebody says the cavernous is a combination of the paracranial and the paraclinoid. Some people say paraclinoid is different. So a lot of differential classifications are there. Like I came across one classification where they were telling that the paraclavian segment has an extra cavernous caudal segment and intercavernous trigeminal. They are naming this as a trigeminal portion. So there are different types of classifications. And this is how it looks from inside again. So when everything has been removed, this is the siphon. You have the nerves out here, V1, V2, V3 here. And this is the paraclavian segment, straight segment, and this is the foramen lacerum. So that is the bit of the small. Now, if you dissect the carotid, medial to it and lateral to it, we have tumors out here. We work in the pituitary area, in the sella. So this is how it looks inside. When you lateralize this, opening of the carotid protuberance and medialization of the carotid artery exposing the neurovascular structures, 3, 6, and V1, V2. So this is the bit of anatomy I wanted to talk. Now about the classification. Now let us come to see it. So these are the three main ones which I want to discuss with you. The rotons was the oldest. Then we have the bothelier. This is basically an angiographic classification for endovascular procedures. But we are using it, but it is of less importance to the lateral skull base surgeon. And this is the Kassam's endonasal classification. You see, all of them, there are 17 types of discussions here, 17 types of classification. So this is the main one, the bothelier one. You have the C1. This is what we are showing till now. C1, C2, C3, C4, C6, and then the communicating branches. This is the main one which we are following now. Now we will come to the lateral type. This is from Paul Castelnuovo. Again, he has so many segments: parapharyngeal, petrous, supralacerum, cavernous, supracavernous, which is again divided into clinoidal and cisternal. After a lot of confusion, if you follow everything, a lot of confusion. So I made a chart of the whole thing and then tried to compare. So if you see that they all agree on the C1 and the last segment, there's a lot of confusion in between. But there is some agreement here, out here. Basically, they are naming it in different ways, but it is basically the same. They are all discussing and giving different names. Like if you add this, it basically becomes the cavernous segment. See, there is similarity out here, but there is a lot of confusion because of this. So I had an opportunity to meet Dr. Ayub Cherian. He's a neurosurgeon. So he was proposing a lateral type of classification. You know, lateral for the lateral skull base surgery classification like this. He's making tubes and a series of tubes and suppliers. The tubes are the vertical ones, and the suppliers are the horizontal ones. And the horizontal ones are the ones which are giving the arterial branches. The vertical ones, they are not giving any branches. So that way we have two branches here, carotidotympanic branches and the VDN, you know that. And there are two branches out here. And that way it becomes more simplified. So if you note, if you put the areas out, put the things, arrange the things like this with the clivus out here and the ACP and the PCP out here, you have some sense, and the dural rings out here, it makes a sense for the lateral skull base surgeon. So now this is the comparative view. this is what he was proposing, Dr. Ipe's classification. From here, you can understand that the petrous goes anteriorly, cavernous goes anteriorly, and the internal goes posteriorly. You can understand that the petrous is lateral and the phalanx level is more medial. It makes sense. So if you superimpose on this, how it looks something like this. You can even make a schematic draw and then put your arteries and the nerves, like the third nerve. It is on the roof of the cavernous sinus. The content is only 6. 6 is the only content of the cavernous sinus. You can make some relation out here. You can understand what is where. You have a trigeminal here. You have the 3 V1, V2, V3 here. The cochlea is in relation to the genu, as I said. So it makes sense. So now, if you put the cavernous, superimpose that on the schematic system, it makes sense. Now you put the nerves and the cranial nerves. So you put the cranial nerves, you have an idea about what is where. Now there are some triangles which you come across when you study ENT and neurosurgery. 7 triangles are there. So if you superimpose the triangles, it becomes very easy for us to remember which is posteromedial, which is anteromedial. A lot of confusion out here. But if you put it in a schematic way, it looks very simple. So, and if you now add the parapharyngeal carotid also, the lower part on that diagram, it looks something like this. So it's a bit cloudy, but it makes sense. It's a bit crowded, but it makes sense. You have all the nerves out here, the cavernous sinus out here, the pons out here. You can understand that it's all there. Now, if you see the triangles, you have this is not a good picture. This is better. Okay. Now you superimpose the lateral classification of Dr. Ives. If you put it out here, you have all the triangles here. The name triangles, the common ones, posteromedial, Kawase, intracochlear Parkinsonism. Even this is actually the clinoid process out here. This is the clivus. So you can make sense. You can remember easily. And I'll show you the video which he had given me. Well, if it plays, I don't know. Will it play? It is me. So these are the tubes I was talking about and the supplies. So these are the tubes. And these are the supplies. See the even numbers and the odd numbers. The even numbers are the ones which are the suppliers. The PCB is out here, anterior clinoid process out here. You put all the nerves, the trigeminal, the GSPN, it hugs the artery, as we saw yesterday. The cochlea out here. So this genu out here, posterior genu, anterior genu, the bend, anterior bend, posterior bend. You can make out everything laterally. But see the numbering. The numbering C7 is lower and C2 up. Because he's a neurosurgeon, he has made C7, C1. So it's in reverse. But as a whole, it makes more sense. You have all the foramens out here, foramen rotundum, V2, V3. So this is what I was talking about. This is an attempt to classify the artery from the lateral aspect. And this can be very useful for us ENT people when you are actually doing endoscopic procedure through the nose also, and sometimes through the ear also. It becomes a jumble. It makes more systematic and the classification becomes more sensible. And that is what I wanted to present to you. And thanks to Dr. Ipe and other neurosurgeons who had fashioned this. I think I wanted to share with you this new thing which I learned. Thank you very much. Thank you.
Thank you, Dr. Dhruvo Roy, for an elaborate discussion on anatomy of carotid artery, which is so important for all of us. Now, I invite Dr. Jago Ori, who will be speaking on 200 interlay endoscopic tympanoplasty using just H. Dr. Jago Ori.
This one now. Next. Okay, good morning, everyone. I'm Dr. Jago Ori from Naharlagan. Greetings from the Arunachal Pradesh, the northeast part of the state in India. So today we are going to talk on two-handed endoscopic interlaid tympanoplasty. Like any other resident, I am also confused after my post-graduation regarding ear surgery, whether I should go with microscope or endoscope. So luckily, I landed up here in the same place, like today here at Telagaon, in the first international masterclass in endoscopic ear surgery workshop. So thanks to our Mubarak Khan sir and the Sapna ma'am. So from there onwards, I was doing a microscopic surgery just after post-graduation. Just before 100 cases, I switched on to the endoscopic ear surgery, but I was doing a single-handed. So there was a difficulties. So I started learning double-handed endoscopy with the help of our Mubarak sir. So have crossed more than 700 cases. So basically, endoscopic ear surgery is done by single-handed. The question is, why change is required in the already existing technique? So we do two-handed interlaid tympanoplasty, and we advocated the procedure. So our experience is with the justice, I was using ASM1, but it has some difficulty in fixing in the JS microscope. So then I started using Justice ASM2, which was gifted by Mubarak Khan sir. Thank you very much, sir. Then when you do the endoscopic surgery, ear surgery, we usually keep our Microtia ear in the canal only, here only in the scaphoid fossa, just to save the time. Let us just directly go into our video. So this is our technique. It's just like a microscope only. The first step is cleaning and infiltrations. We infiltrate with 2% Zyloc and with adrenaline in the 4-quadrant. So cleaning we do with the wrinkle lactate, with the Microtia soaked in the adrenaline. The pressing the margin we do, you can see the two-handed here. My suction is in the left side. When we plan for TAE, we don't do this step, but when we do it, we have to include the sufficient margin of the perforation just to include the epithelial in migrations. Then after that, denuding of this tip of malleus. This step we do in the early part of the surgery because of the stability of envelope malleus in this stage. So it is easier to do. Then next step is the incision. The incision we usually do with the circular knife as usual. 240-degree incision we usually give. Here it is very important to keep our knife in the 90-degree. Then we alleviate the tympanomeatal flap. You can see here suction. We don't put the suction in the flap. So this is the interlay elevations. This step I learned from our Satish Jain sir. Thank you very much, sir. We just have to engage our right angle hook there, engage and just feel it off. Just feel it off, it easily comes. This is the interlay elevations. So slowly we come from anterior to posterior. So this is the tympano, during our tympanoplasty, routine tympanoplasty, we usually do like this, the interlay elevations. Then we clear the posterior part with the handle of malleus. Since we have already done the tip part, it is easier for denuding. We do with the sickle knife. Then the next step is clearing the ventilative pathway. So it is very important to clear the ventilative pathway when we address the failure of the ventilations. So most of the perforation is done is due to failure in the ventilative pathway in the either of 3 pathway. So we just clear the anterior ventilative pathway from coque to the cochlear process. Just clean with the Microtia. Then the tympanic isthmus we clean from the cochlear process to the incrustapetal joint. Then to the posterior pathway from the equidistal joint to the pyramid. So we clean all three pathways like this. And then we flush the key area with the ringer lactate, just in case if there is any foreign body or any infected materials. Then we do the curettage in this area just to expose the incrustacepular joint. So it is mandatory in all tympanoplasty to expose the incrustacepular joint. So you can say it is a kind of a modified interlay because in this area we have already cleared the mucosa. Then after that, sometimes it is very difficult to clear the mucosa here in this tip. So there are some dedicated instruments for this also. People are using Cobra. We can do with the sickle knife also. Then we do the reverse elevations. Our elevation is all 360 degree, although we give the incision in 240. We give this area for the vascularization. Then we remove the edematous tissue. And then we do the TAE. We remove a total annulus excision. This I learned from Dr. Sudip Monjal, my senior. So we do with these two techniques. Here with the single-handed, it will be difficult. So with the iris scissor, we remove and the suction control in the left side. So then we remove then after that, we prepare the graft. So before harvesting the graft, we lower our metal flap in position and keep some marrow cell there. This makes the tympanometal flap easy to handle later on. Then we harvest the graft in the last part of the surgery. Bed-to-bed graft, temporalis fascia graft, we do wet grafting. So we spread the graft in the canal before going inside. It is easy to handle this type of graft. So slowly we push in between, behind the handle of Mealy's. So it is very important to adjust the graft in all around 360 degree, lying on the bone. This graft is going to get the nutrition from the two sources. One is from the Haversian system of the bone, which is open up, and other is from the skin that we have already give incision. So when we do the TAE, it's all the circular fiber vessels open up. So it is important to adjust the graft in all around 360 degrees. Then we put the air there, airtight. We don't put the gel foam there. Likewise, we have to put the air airtight. It's very important. Air is a natural content of middle ear. So the gel foam may act as a foreign body. So then we lower the flap. Lower our flap. So before lowering, we have to ensure that the graft rests in the bone properly. Then we lower our flap down. While lowering the flap, there may be displacement of the graft. So it is very important to recheck it again. In all 360 degrees, you have to lift up the flap again and recheck it. It's very mandatory. So you can check here, just after lifting out, the graft may displace here and there. So to make sure that the graft and the flap makes a good union, there should not be any air trap in between the graft and the flap. So likewise, then the last step is we start with the circular knife and ends with the circular knife. Just press all along the flap and the graft. So this is the last. Then we put the gel foam. So then coming back to the last slide. So to conclude, the two-handed endoscopic ear surgery is an amazing technique. Exclusive double-handed or the single-handed is a dogmatism. Mastering both technique has an advantage. Both middle ear and mustard can be dealt with the two-handed technique. interlate tympanoplasty is more physiological. In case of bleeding, countertractions, grafting, and drilling, two-handed gives more advantage. Long learning curve need patience. Beginners should start with two-handed endoscopic ear surgery. More exposure to the endoscopic technique to the residents and fellows. Prospective studies, instruments, development, training on endoscopic ear simulator, strengthening the endoscopic ear surgery organizations is mandatory. The more workshop on endoscopic surgery is needed in India and abroad to popularize the technique of endoscopic ear surgery. So our ultimate goal is to cure the disease, whether through microscope or single-handed or the double-handed. So always help each other to climb up. Thank you very much.
Thank you, Dr. Jago Ori, for an excellent presentation and the videos. Now I call upon Dr. Ashish Bhumkar from Thane, who will speak on some mysterious subject, Microtia. Let's see what he has to say.
It is Microtia. Sorry. Hello, everybody. Yeah, we'll take some time. It's Microtia repair. And I was just joking on the WhatsApp and they took me seriously. Well, in 10 minutes, I'll only show you the before and after. And my gold standard is still the rib cartilage reconstruction, although some newer developments have come. In the synthetic, there is this MedPore, but now there's a better version of MedPore where we actually get a three-dimensional framework from the company itself. And it's a real life looking model. We've done some cases. I'll share the videos with you, the photos with you. But still, either. Still the gold standard is still the rib cartilage. The most important message to be taken home is the selection criteria for the rib cartilage reconstruction. The ideal criteria is chest circumference should be 60 centimeters at the level of xiphisternum, which in Indian population translates to age 10. But more important than the age is really the, thanks, Dinesh, thank you. Dinesh is the champion who was there at the World Cup, if those who don't know. He's a very, very high profile audiovisual guy. And he's been with us for the last, God knows, 15 years or more. All the Jaipur drama we did was with him. Thank you, Dinesh. So Microtia repair. I'll not speak too much about atresia because we have just 10 minutes, but always you have to look at hearing improvement in some one form or the other. This is very important. These are the representative. They come in very many different types and forms, the microtias. So all kinds of microtias, but typically the surgery and the outcome is something like this. In one single stage, one can give a nearly normal or a normal looking ear, external ear. This is the destination, and we'll speak a little bit about path. Now, me and my anesthetist teamed up with me, and we are able to do this in less than 3 hours now. It's quite simplified and quite. So this is the deformity from the ribs. The framework is made like this. All the subunits of the framework are made, and the skin pocket is done, and a vacuum is applied to that. So these are some before and after photos. When planned properly, when there's a precision applied to the skin that is available to you, this surgery has now become very, very predictable in its outcomes. So more and more of this. This is something. So we do CT scan of the chest to assess the ossification of the status on the dimensions of the cartilage. Here I want to point out that a lot of cartilage is required. This framework is made from 4 different subunits: the base plate, the helix, antihelix, tragus, and antitragus. So it's like a jigsaw piece. So you need 6, 7, and 8. Therefore, the criteria of 60 centimeters is very important so that there is no donor site morbidity or no weakness in the chest, because that's something very important. And you get a good quality cartilage to do a good sculpting. So this is, I think, very important, age 10 or 60 centimeters and more. This is important. This is what I'm saying. The template is made by the design of the opposite ear. And then accordingly, you have to make this. This is the base plate. This is the helix, which comes from the 8th rib. And this is the antihelix with a part of the antitragus. and tragus, and all these are wired together with a 5-0 steel wire. And this is typically how a complete, some patients have the tragus present, so we make a partial framework. In trauma also, we make partial frameworks only fitting the jigsaw piece. There are different types of skin approaches depending upon the deformity, depending upon the Doppler study that tells us which way the vascularity is going. And accordingly, we have further simplified our skin approaches to make it more predictable and to keep the skin that drapes the framework uh, less scarred or no scar at all. So that's something which has started to happen. So the frameworks, like I said, the cartilage raw material is of different types. So the frameworks also tend to be. So the framework is made, all the deformed cartilage is removed, the subacute skin pocket is made, a vacuum drain is applied, and then this framework is slipped into the subacute skin pocket at an appropriate. These drawings and measurements are very, very important. And the learning curve is there. Then you apply, and in a moment, bingo, an ear is born in our operation theater. So this is what, yes, thank you. Thank you. This is one more, but just to show you, this skin approach was different because the deformity was different. So more and more of these. Some are, like I said, the framework, the tragus, anti-tragus is already present. So this was a much simpler. We needed much lesser of the cartilage to make only the remaining part. The skin incision is different. Now, after this, if you notice that these ears are stuck to the skull, there's a second stage to be done after 6 months where you take an incision post-oral and then put a skin graft. This is the elevation that you can get. This is 40 days after the second stage surgery. The elevation is about 11 or 12 millimeters off the skull, which is a very good elevation. There are 3 different techniques for elevation, but the most commonest one is simply to take the incision and put a skin graft. For others who need, we do have something where we can put a wedge and give a 20 to 20 millimeter elevation, depending upon the elevation of the opposite side. But a simpler thing to do is to bring the opposite, because the patient or beauty is in symmetry. So if the normal ear is projecting too much, it is better to take it back and bring the second stage equal to that side. There are some cases where you cannot use the simple technique that I showed you. There are low hairline cases. In these cases, we have to use a superficial temporal artery. We have to excise the hair-bearing skin. This is the hair-bearing skin which will go. A temporal fascia graft will be used. This is a secondary case. This was a case operated somewhere else, and the case has not gone well. All the cartilage has necrosed. But even in such cases, same, like excise the whole scar tissue, use the TP flap. This is a temporoparietal flap based on the superficial temporal artery. You harvest that and apply it over the framework. And again, a near normal ear in one single stage can be given. So secondary cases, burns cases, all this. There's Medpore. This is the synthetic material I spoke about. This comes in a standard model, 2 components. So you can only play with the length and the breadth. The middle structures remain the same. There's a big advance. So these results are also very good. But again, in these cases, you need to take the temporoparietal flap. That this framework has to be covered with a rich vascular flap. Only then the skin graft can take and remain for the rest of the life. This is the new model that we have just used. I think a week back we did our first case. This is the Supor. Now, instead of Medpore, this is Supor. And this comes in 25 standard designs. But in addition, if somebody wants to really have a precision, you can actually 3D scan the normal ear, send it to the company, and from the US, in about a month's time, they can give you a replica of the opposite ear. This is the same material as Medpore, so the surgical principles remain the same. This needs to be covered with a TP flap. It's very easy. Talking to an ENT audience, always we will look at the possibility to improve hearing, and more in the second stage when we are doing the elevation, because we have the post-oral area royally exposed, we go ahead and drill away the bony canal. We mobilize the ossicular chain, of course, on a CT scale. We only look at the presence of the ossicular chain with the presence of stapes, even if it is dysplastic, and presence of air. in the mastoid or in the middle ear. This is very important. Then we just drill this canal. We don't put any skin graft. This is closed. But for some reason, these patients get an improvement in the perception of sound. This is very important. This is after the first stage we have marked. This is stuck to the skull. And this is the incision taken. Before putting the skin graft, we have gone ahead and drilled the canal and then put the skin graft. This is a very simple way of doing this. The ossicles are mobilized. I don't need to, yeah. The ossicles tend to be fixed like a rock, and then you get this mobility. And it's very simple. It just takes 20 odd minutes. This is the case that I showed you after this thing first stage stuck to the skull, and now it's out. At a later point, after 3 months, we'll give her an ear piercing to this patient. And these canals, now 4 years after you drill, if you don't put the skin graft, the bony canal never stenosis. All the canal atresia surgery, the stenosis is at the soft tissue, and managing the soft tissue is really what we do. Hearing aidable canals for those who can't afford the bahas and the osseous, but that's a different story. But these cases where we drill, we do a repeat CT scan, the canals are as wide as we have drilled them. Of course, we use devices. We are big into ossea, and now very recently, for cost reasons, we are doing the baha, the bone bridge 602. So this is our journey into when you do a microtia repair or when you do an atresia or an implant, always make a drawing. At the age of 5, you can do an implant, baha. So make a drawing of the normal ear, be away from it, at least 2 centimeters away and far behind. And that's where you put the implant. Do not vitiate the skin that will eventually drape the new ear. This is what I think in 10 minutes I can convey. Thank you so much. Thanks.
Thank you, Dr. Ashish, for an excellent demonstration of the work which probably he is alone doing in Maharashtra. Now I call upon Dr. Ahila Sami. He will be speaking on innovations in endoscopic ear surgery. Dr. Ahila Sami.
Good morning, dear friends. I am going to talk on my innovations in endoscopic ear surgery. That is my innovation diathermy round knife, then scarless tympanoplasty mastectomies using not the tragal but homograft septal cartilage and micro chisel for endoscopic ear surgery instead of using drill, and I no more use xylocaine for infiltration. I use ropivacaine. Before I start, I thank Dr. Mubarak and Sapna for making me a faculty here. This is my biodata, everything. I live in Chennai, but I am originally from southernmost tip of India, a coastal village called Ganapathipuram. I work in these corporate hospitals. This small thing about this is my 122nd as faculty. These places, okay. This is my YouTube. Okay. This endoscopy when ear surgery, one of the important thing is you should have a good instrumentation, better visualization, and the illumination and clear bloodless field to have a very good quality.
For that, that's the hour of the need. For that, I need in this. Sometimes you may have nightmares like this on the single-handed technique. That's why some change to the two-handed techniques. When you elevate, there will be much bleeding from the tympanometer flap site. To avoid that, so of course you can use adrenaline cotton balls, but sometimes it may be a nightmare. So I innovated this diathermy knife, which is available with Sandoz Surgicals. This is just the Rosen knife, but insulated, but connected to a cautery. This is a diathermy cautery knife. The innovation came before. Initially, I was using the sheathed Rosen knife, and with the monopolar, I touch it. But then I innovated this instrument, and it is patented also. This is the central perforation, freshening the edges. This is a diathermy round knife. You will have hardly any bleeding. Of course, one disadvantage is you may have some skin loss because of the cautery effect. Post-operatively, you will have a little slow healing and granulation, which you can apply some steroid ointment over that area. Absolutely bloodless elevation. Sometimes there may be slight, but like the routine, it will not be there. So for the single-handed people, it is a very good tool. Of course, you can use this for many other purposes like glomus cases and small tumors in the ear canal and everything. There are papers of French, Italian surgeons using cautery in the ear. I have published this article in Indian Journal, and it has patented, and Sandoz Surgicals is making it, and you can buy it from them. This is another video. This is a cautery knife. Okay, for the lack of time, I cut short the thing. This is a wonderful instrument. This is the article which I have published. Take home message: a game changer in endoscopic ear surgery. That's for single-handed endoscopy ear surgeons. Clean incision, bloodless field, and easy to operate. So next is endoscopy scarless, totally scarless tympanoplasties. As yesterday you would have seen Dr. Mubarak showing tragal cartilage, slice it and put it. I preserve the cartilage, the septal cartilage in 70% alcohol. I'll show you. Oops. Yes. As Dr. Vijayendra or Mahadevya, they preserve septal spurs in 70% alcohol and use for osculoplasty. I preserve in 70% alcohol, the septal cartilage of previous septoplasty patients. And of course, I slice it with a blade or anything if the cartilage is thick and use it. Like any, just slicing. This is Mubarak's slicer. I'll play small video clips. It's lack of time. This again, I am using my diathermy knife. This is a cartilage. And placing the tympanoplasty flap. So totally scarless, it heals well. The results are similar to the tragal cartilage. I have more videos, but I am not using everything. This is a post-operative case, healed beautifully This is 3 weeks post-operatively. You can see there is some granulations, which I just removed some bloodstock area and crusts. Heals beautifully. Hearing is also good. This is a video clip post-operative. As I said, there will be slight delayed healing and crusting. I use steroid ointment. So scarless is very important because nowadays many people have this kind of hairstyles. And of course, tragal, some people use tragals for this purpose. So girls, you cannot sometimes damage their tragals also. And if you take tragal cartilage, you cannot use the ear pods. So I am not here to say that which is superior, the tragal cartilage or a homologous septal cartilage, but it's a definitely alternate under scarless. I have published this article again in Indian journal, Endoscopic Tympanoplasty using nasal septal cartilage allograft. I published this some 10 years ago. So next thing is for cholesteatoma, again, you drill and everything. I have videos to show. You can drill and remove the cholesteatoma. Then I put, instead of using the tragal cartilage and temporal fascia, I use it and reconstruct. This is a beautiful healing. This is another video. Lack of time, I am just going fast. After removing the cholesteatoma, reconstructing with that's a septal, homologous septal cartilage. And these two heals beautifully. So 3 innovations: diathermy knife, homograph septal cartilage, tympanoplasty, and mastectomy. So a lot of video clips, various pathologies of I can show. One more thing, single-handed or two-handed, I am not here to compete. This is Mubarak 200 thing. I am mainly a single-handed person, but suppose when I require 200, when it is a little bloody situation or drilling, I use my beautiful nurse as a just a touch. These are simple. We don't nowadays use these bandages. I do even bilateral with a small dressing. So the next innovation is chisel. I nowadays avoid most of for the stapes surgery as well as master. I avoid drilling where the dust flies and it is little time consuming. I use the chisel. That's 1 mm and 2 mm chisel, which is available with again Santosh Surgicals. You can buy it. It's a very faster way of bone removal. This is you can use curate, but it's a slow time consuming. It's a chisel, 1 mm chisel. I have another 5 minutes. Just tap it, but be gentle. Don't slip it. Very faster way of bone removal. Like that for mastectomies also, this glomus tympanicum, again, you can use the chisel for bone removal. I use this knife for elevation. See, bone removal for this bigger glomus tympanicum extending into the attic space. I use this chisel to remove bone. So drilling sometimes causes ear canal injury also because of the rotation of the burr. With the chisel, you can avoid those things. So you can make such a big cavity and everything with the drill very faster way. This is another case, mastectomy. for cholesteatoma. Using chisel to make it an MRM type of cavity. Very useful tool, 1 mm and 2 mm, very faster and no bone flying, everything. This is the next innovation. I have published this also as an article. So the last one is ropivacaine. I use 0.5% of ropivacaine for infiltration for the past 12 years for all ENT surgeries, that are ear surgeries. This is the thing, the night I do almost all the cases under local anesthesia, ear surgeries. This is a pre-medication, previous night alprazolam on the table, fentanyl and dexmedetomidine as IV, generally performed under moderate sedation. The same thing for sinus surgery also. This is a solution, 0.5% ropivacaine. The effect lasts with adrenaline, lasts for up to 6 to 7 hours. Believe me. I'm not talking about. So the final thing, I stole this slide from Dr. Mohan Reddy sir. All truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. Third, it is accepted as being self-evident. Okay, some youngsters, you can take a photo of this. I have nearly 453 YouTube videos, and you can, with the name Agilasamy, you can search me in the YouTube. And this is my WhatsApp number, and anything you can contact me. And any video link, anything, you can contact me. This is my website. This is my website, and this is my YouTube channel. And all the videos, various conditions are there. Thank you very much. Thank you. Years teach us more than books. Yes.
Thank you very much, Dr. Agilasamy, for your excellent presentation. Thank you very much. Now I call upon Dr. M.K. Taneja, sir, from New Delhi. He will be speaking on rejuvenating therapies in otology. Dr. M.K. Taneja, please.
Meanwhile, yeah.
Good morning. It's an opportunity, and I thank Dr. Mubarak Khan, Dr. Sapna, and Khan Foundation. I'll be speaking on rejuvenating therapies in terms of platelet-rich plasma and bone marrow aspiration, mainly on the platelet-rich plasma. What is more important and how we can prepare the platelet-rich plasma. It's just preparing a PRP is not that important. Important is how you prepare it and how you preserve it. Now, most of the ENT surgeons, especially otologists, are doing wonderful tympanoplasty. In spite of that, they are not having 100% success results, or they are having secondary perforation. How to deal with them? It's not my laptop. You can take from pen drive also. So, before I start proper presentation, I'd like to highlight certain points what we are lacking, usually lacking. in preparation the yeah. Thank you. Thank you very much. Progress is impossible without change, and change makes us grow. So that was my motto, how to achieve 100% results. What Dr. Hilasami is doing, what Dr. Bhomkar is doing, is just you enhance the blood supply of that area. And if you we have passed an era of catastrophic surgeries like modified radical mastoidectomy or Young's operation in atrophic rhinitis or geriatric rhinitis. In era of regenerative medicine, we can add platelet-rich plasma to all these surgeries. The advantage is it's a patient's own blood, no legal hurdles, and no, practically no side effects. And apart from that, it is antibacterial, antifungal, so the need of antibiotic and antifungal is not there. Over the time, the scientists developed a technique how to condense platelet-rich plasma. What is platelet-rich plasma? It's a volume of autologous plasma which is multifold, rich in platelets and growth factors. Here, I would like to highlight multiple times. I would like to highlight it's not only the platelet; it's the growth factors. How to get maximum growth factors, and that should reach. I'll not be talking in details about multiple growth factors, but the platelet derived growth factor is one of the important which helps and controls cell growth and its division, especially capillary blood vessels. So new vascularization is enhanced, and that leads to enhanced oxygenation and blood supply to the wound or surgical area, resulting in early and better healing. These growth factors have fundamental role in homeostasis, tissue repair, and healing. Four types of are conventionally available: leukocyte-rich platelet-rich plasma, leukocyte-reduced platelet-rich plasma, leukocyte platelet-rich fibrin, pure platelet-rich fibrin. There are different methodologies, but one thing is extremely common, that is differential centrifugation. With different centrifugal rate, you can have a different type of platelet-rich plasma. And apart from that, time, how much time you centrifuge it, the temperature of the centrifugal apparatus means 21 to 24 degrees centigrade, and the speed, at what speed you centrifuge is important. In the technique, you withdraw the blood from the antecubital vein by using a 16 to 18 scalp vein, centrifuge it at a different speed, and you get three portions, usually conventionally, the plasma, buffy coat, and the erythrocytes. Here it is important to know. Conventionally, what is available commercially in the market, that contains a activator for the hairs, biotin also, and that provides you approximately 40% of the PRP. It divides in erythrocyte is there, and that is not important in otology practice. In otology practice, we need more concentration. I'll be coming to that. How I do it, how I prepare it. The blood is obtained from the antecubital vein. 1 ml of anticoagulant sodium citrate is added, and then 9 ml of blood. It becomes, I take it in 18 ml, so 2 vials tubes are there, and I put it on 1500 RPM for 15 minutes. This results in 2 layers, not the 3 layers. There is no buffy coat. So in 2 layers, you have got it. I was told 15 minutes. I have to condense it. So I had to, in 2 layers, and again, you had to centrifuge it, collect the platelet-rich plasma in from both the vials, centrifuge it at 3000 RPM for 15 minutes. This leads to a pellet. A pellet is downstairs at the bottom of the tube, which is extremely important. Now, discard the upper portion, and depending upon the use, as you are using in atrophic rhinitis or in a cavity or in simple tympanoplasty, in simple tympanoplasty, you can keep the pellet itself on the round window and in the middle ear. Otherwise, you can the volume of the middle ear is approximately 0.3 ml. So dissolve it in 0.3 ml and leave it there after activation. Activation is important. Activation leads to degranulation and growth factors are there. And once the growth factors are there, they work there and it forms a gel. Forming a gel is by activator. For activator, thrombin, calcium chloride, collagen is there, but apart from calcium, you can use a liquid nitrogen. Mechanical trauma dislodges the activator granules, and I final PRP solution to get the best result is 10 to 15% of the total blood. If your blood is 10 ml, so it should not be more than 1.5 ml, and after activation, 70% growth factors are available in 10 minutes time, almost 100% in 1 hour time. Regenerative potential depends upon the release of growth hormone. What else we can do? That is important. Bioactive agents, serotonin, dopamine, antioxidant, all makes the difference in what state of mind you have taken the blood from the patients, in what state he was. So in preoperative instruction, drink plenty of water, which assists to draw adequate quantity of blood, 15 to 25 minutes brisk walk, if possible, increases the growth factors, sun exposure. Important is stop anti-inflammatory drugs and withdraw blood thinners. Bromelain from the pineapple, as I said, dopamine, serotonin, and the important part is if you go into Vahikumbha in a pranayam with the extended exhalation, whether chanting of Om or whether just humming anything which releases nitric oxide, your growth hormone increases, adding fish oil, turmeric, glory, pyrophytics helps you. These are the different indications. I'll not be talking about storage of PRP. Multiple clinical trials have been done and successful. This is one of the publication with 15 citations, role of platelet-rich plasma in tympanoplasty. I'm an average ENT surgeon, but I have been extremely lucky. After using platelet-rich plasma in last 7 years, there has not been any failure. And if there is just a secondary perforation, what you can do, just make another PRP and freshen the margins and put a platelet over it and it heals well. And one more advantage of pellet putting on the round window, that is what sometimes by ototoxic drugs, sometimes by ototoxic ear drops, you get some degree of sensorineural hearing loss. By the permeability of the round window, that is a chance to get recovered also. Multiple trials have been done by various authors. It's anti-inflammatory. You can check in atrophic rhinitis cases by nasal mucociliary clearance test. And you can find yourself in an 80 years old man who gets dribbling at the dining table. It gives wonderful results. Our future goal is bone marrow aspiration. PRP in sensorineural deafness is claimed to be having good role. I'm not getting very, very good results, but some results are there, and I cannot guarantee whether it's better than dexamethasone or other things. So we can use platelet-rich plasma in deafness case. Say, my message is that easy procedure from the old blood, no complication. Tying with the liquid nitrogen is better than calcium. It costs less than 200 rupees, hence may be added to various surgical procedures for better results along with early healing. So success is in your blood. Thank you. Thank you very much.
Thank you, sir, for your nice lecture. Please wait, sir. Now I call upon all the speakers on the dais for felicitation. Dr. Santosh S. from Bangalore, Dr. Dhruvo Roy, Dr. Ahila Sami, Dr. Jego Ori, Dr. Ashish Bhunkar, and Dr. Tanejas. To felicitate them, I call upon the chairpersons, Dr. Girish Harkut, Dr. Manoj Agrawal, and Dr. Sarensen, sir. त्यांच्या हातात द्या पुस्तिकेमध्ये. Please come. Please.
Yes. I can see.
I like
और भी हैं, और भी चाहिए?
और moderator, sir. I call upon Dr. Mohan Jagde to felicitate the chairmen, Dr. Girish Harkut, Dr. Manoj Agrawal, and Dr. Sorensen. तीन chair moderator चे. Okay, thank you all. Now we'll start with
Thank you. Thank you so much.
thanks all. Now we'll be starting with the late Sayyid Nur Badshah Sheikh oration, that is SBS Memorial Oration. It is in the memory of Dr. Mubarak's father-in-law. To explain about the oration, I call upon Dr. Sapna Parab and Dr. Mrs. Khan.
SBS oration is started in the memory of late Syed Noor Sheikh, who's the father of Shireen ma'am and father-in-law of Dr. Mubarak Khan, sir. He was born on 15th of June in 1938 in Tasgam village, Sangli. He went on to join the Air Force only at the age of 21. He was married to Mrs. Saida. Madam has come today over here. He served in the Air Force for about 2 decades and was posted all across India during this time. He was a scholar in economics, and after this time with the Air Force, he went on to join Telco as a floor manager, after which he assisted his son as a vendor for Tata Motors. A very peace-loving person and a patient man, he was the epitome of a gentleman. He was a strong follower of Vipassana and practiced meditation daily. He was a very disciplined man and followed his daily routine till the death. He battled 3 heart attacks and 3 heart surgeries and came out of it. He was a complete family man and showered his family with abundant adoration. Unfortunately, he passed away on 24th of June 2022 while recovering from a leg surgery. He managed to leave a final permanent mark on our lives as he donated his body to the Armed Force Medical College, Pune. He lived for and died for his loved ones. We miss him and hope he is watching us and blessing us all. I call upon Shireen ma'am to put the medal onto Satish Jain sir and start with the oration. And I call upon Satish Jain sir to give the oration.
Center में. I call upon Dr. Jeevan Vedi, Dr. Devi Prasad D, and Dr. Amol Khare to chair this session. Dr. Satish Jain sir will be speaking on role of subtotal petrosectomy in cochlear implantation, expanding indication of CI. Dr. Satish Jain sir.
Morning, everyone. Big thanks to the Mubarak Khan, Sapna, and everybody, the entire organizing team for giving this opportunity to deliver this prestigious oration in the memory of his father-in-law, who has done wonders for us. Thank you so much. And I've been enjoying this course for since yesterday. We had a great time in dissection and live surgery, and all the hospitality they extended. It's been so wonderful. Thank you once again. And time is for, I know we are running behind the schedule, so I'll just touch upon some important issues, then we'll follow with the same surgery. So this is something about cochlear implantation. We all know cochlear implantation is the preferred approach to rehabilitate profound deaf patients. Age is no bar. Started with limited indication in 70s, and now we all know with the success of the results, better understanding of anatomy, radiology, and so on, the indications have expanded. And this technique is like savior for most challenging situations. We had a cochlear implant yesterday, and it's not always the same, scenario. There are a lot of challenges associated with the implantation and indications as well. Particularly when the returning infection gives you a challenge. You implant on a patient and then infection sets in the middle ear or temporal bone anywhere with a foreign body in place is most difficult for the surgeon as well as patient. And this technique is something which should be in the armamentarium of every CI surgeon for all those difficult situations. So what exactly the subtotal petrosectomy is, I'm not going in the surgical details. I'm skipping the video as well as we'll follow the case after this. So this technique involves exenteration of all cellular tracts from the temporal bone along with the skin everywhere in the tympanic membrane, axon artery canal, everywhere, wherever in the temporal bone, with blocking all incoming sources of infection to the temporal bone by means of obliterating the eustachian tube, by means of obliterating or cul-de-sac closure of the axon artery canal, and then giving a sterile zone which we can obliterate with fat or flap or whatever. So it gives you a sterile zone in that area to prevent infection coming back. And this can do wonders in the setting of certain situations of cochlear implantation as well. So what does subtotal petrosectomy provide? It gives you a biggest of the exposure than you expect from any other technique. Like when you do a canal down mastectomy, it gives much beyond exposure than canal down mastectomy because it removes everything, every part of the cell tract and the skin and canal and everything, leaving behind the labyrinth and critical structures like carotid artery, jugular bulb, sigmoid, sinus, facial nerve. All those critical structures are left behind. Rest everything is removed from the temporal bone. So it gives amazing access and you can reach out to every nook and corner of the temporal bone to remove the disease, to ensure the disease is removed from everywhere. And then at the same time, you can implant the patient as well. Obviously, it has a big role in eliminating future infections, as I said. And once it comes to CSF leak closure, like we discussed yesterday, this is one of the best way to ensure the CSF leak is no more in the future. You can close the CSF leak at the level of the cochleostomy or round window, whatever level. But after that, obliterating the cavity further is something ensure that the leak is not going to come back. So this is the best way, or I would say the most efficient way to control the CSF leak once there is a challenge of CSF leak. And once you are doing implant in most difficult situation, we'll share some of the slides with you that it prevents the electrode array, disturbance or the mobilization because we obliterate the entire cavity. Everything is submerged. The electrode array is submerged inside the obliteration tissue. So the extrusion chances are very, very less. So there are n number of indications and indications are expanding. To me, for implantation, anybody, age is no bar, from 6 months to 100 years, anybody having profound loss, having or not being benefited with a hearing aid is a candidate for cochlear implant. But in difficult situation, anybody having CSOM, having tumor, malformation, ossificans, whatsoever is the challenge, you can, still rehabilitate using this technique of subtotal petrosectomy. So there are n number of indications. We'll discuss one by one quickly. This, insight to our, practice came from this publication from Professor Mario Sana, who probably has the biggest series in the world, if I'm right, Manoj, who has witnessed him doing this technique a couple of times, who has the biggest series in the world of, subtotal petrosectomy implantation. And this publication started us, forced us to work on this. And till then, we have done over 100 cases with varying, those indications which we would otherwise not be able to do without this technique. So this is something like a savior for the cochlear implant patients who need rehabilitation but having certain challenges which stops us from doing a regular cochlear implant surgery. So what are the concerns in regular cochlear implantation which makes us think of this kind of a technique? The biggest, as I said, is the returning infection. You implant on a patient, an infection comes back in the temporal bone. Is there something nobody would like? Even the surgeon would never, it would be a nightmare to the surgeon as well as patient. And revision surgery in the presence of the CI is another challenge we can think of. And biggest, the commonest pathology in our country, as far as the otolaryngologists face, is the CSOM. Many of the patients who have CSOM, who have developed profound sensory hearing loss, how to rehabilitate them with a cochlear implant. In a regular situation, CSOM has no control. We all know, in spite of the best of the available treatment, CSOM can come back. You cannot control the physiology to the 100% level. But yes, once implant in place and infection come back, it's a challenge. So for all CSOM situation, we have been doing now subtotal petrosectomy implantation at the same stage, even in the cholesteatomas bearing active infection. So you have to control the active infection, and then you do the same thing simultaneously. For example, let us see one by one situation. Central perforation. We all know surgery for the central perforation is simplest of all. You can do a tympanoplasty, meringoplasty, but what are the long-term results? In the best of the series published in literature, the initial results are encouraging over 95%. Some of the series even published over 98%. But what about the long-term results? Results 10 years down the line, 20 years down the line, no series is published in the world over 80% because you can't control the CSOM coming back, nasal issues, eustachian and tube issues, fall off. So many issues are there, then CSOM can come back. In a perforation, we have option. Perforation with profound loss, you can do a tympanoplasty, and at a stage after 6 months, 12 months, when the ear is dry, you can do a CI. What if the infection comes back? Who guarantees that the infection is not going to come, not going to participate in the hearing once you put a CI? So the best way to ensure infection, even in this simplest of the pathology, our philosophy is to go by a subtotal petrosectomy implantation. The first stage, obliterating cavity, eliminating all sources of infection, because the middle ear is anyway not going to participate in the hearing after the CI. But what you ensure is the infection is not going to come back. Similarly, in atelectasis is because of eustachian tube issues, nasal issues, whatsoever, but you can't control that for long term. In spite of cartilage reinforcing this, that technique, whatever, it can come back. You can't control the pathology which is driving the atelectasis. And if you are needing CI in such patients, it is best to do a subtotal petrosectomy once for all. The idea is to prevent, facing the situation of infection after the CI. Cholesteatoma. You can do best of the canal wall up, canal wall down, whatsoever surgery, wait for 6 months, 12 months, and you can do a CI later on, preserving the middle ear and all. But what for? Who can guarantee that the cholesteatoma cannot come back? Whatsoever technique, even with a canal down method, even if you do a canal down mastectomy, how will you put a CI? If you have a cavity there behind, how will you put a CI with the cavity might be well healed, well epithelialized cavity. You can elevate the epithelium, put a CI underneath, but who can ensure that the cavity is not going to be infected in future? We all know cavity infection is so common. In spite of the partial obliteration, covering the area with everything, still the infection can come back. And the best way, again, there is no other way better you can think of than doing a subtotal petrosectomy CI, because you eliminate all incoming sources of infection to the temporal bone. That's why this technique has a big role in this situation. OME. Yesterday, somebody asked about the grommet and all that. OME is something pretty common in children, and children are the, commonest CI recipient. OME can lead to otitis media. Further, it can lead to CSOM. It can lead to further complication, cholesteatoma, whatsoever. And the reason behind OME is sometimes beyond control. In children, particularly eustachian tube, adenoid, CRS, allergy, and so on, which you don't have any control over these pathologies. Once you do a CI, if OME develops, you can put a grommet. You can put grommet simultaneously. But who can ensure the infection is not going to come back in future? And since only reason behind is, since middle ear is not going to participate in the hearing, why not to do a subtotal petrosectomy, get rid of all the issues in the future more, or I would say most confidently. So there are situations where you have to think of this technique to prevent future problems. There are certain situations where you have to think strongly, otherwise the problems are imminent, like inner ear malformation. There are certain malformation I mentioned yesterday as well, which are likely to give CSF leak because of that, ongoing malformation. IP1, which has a direct communication of the CSF space with the cochlea. Similarly, common cavity, IP3. Though In those situations, CSF leak is imminent. Even if you control the CSF leak by best of your approach, still leak can happen and there is a possibility of ascending meningitis. The best way is to obliterate the cavity along with closure of the CSF leak to ensure in future no source of infection can come back to the temporal bone as we obliterate the Eustachian tube, exonotory canal, and completely obliterate the cavity to reinforce the leak what we have sealed at the level of the round window. IP1 in particular, we have a couple of patients of IP1. IP1 has an additional abnormality at the level of the foot plate. It has a foot plate developmental defect as well. In spite of doing a regular CI on IP1, sealing the cochleostomy, you don't treat the pathology at the level of the foot plate. Even if you don't implant, those are the patients. That's the only anomaly I would say, which is the highest chances of ascending infection, meningitis in the future, even in the untreated patient because of the foot plate. There is a defect at the foot plate where the inner ear fluid can come out any point of time. Even a single incidence of otitis media can lead to meningitis in those patients. And this technique is like a, life-saving technique for those patients if you do once for all. You never have to look back for the possibility of ascending infections in the future. Obliterated cochlea, labyrinthine ossificans is one of the most challenging situations a CI surgeon can face. We saw in the dissection yesterday, in labyrinthine ossification, still you can rehabilitate with a cochlear implant, depending upon the grading of ossification, which involve the scala tympani, it is involved both scala, it is involved the entire cochlea, middle tongue, whatsoever it is. Still you can rehabilitate and it requires a lot of drill out. We all know there are tigers around the cochlea, the carotid artery, sometimes jugular bulb, this, that, in the closest vicinity. And doing a drill out through the narrow approach of posterior tympanotomy is something hazardous and can invite fatal problems. For such extensive drill outs, the best of the approach or the best of the exposure is afforded by subtotal petrosectomy, where you can control all surrounding vascular structure in the best of the way to prevent all those fatality. So this is the best way to control those infections or the complication in those situations. There are certain other indications which may not be very common indication for CI, but yet once required, one has to be very careful doing a regular CI. Temporal bone fractures. Fractures of the temporal bone, unlike other fractures in the body, do not heal with the bone. They heal with fibrosis. And in spite of the best of the healing, the temporal bone infection can still ascend to the subarachnoid space. In spite of the best fibrosis and healing, and in those situations, if CI is needed, it is best to do a subtotal petrosectomy. Obliteration that rules out the possibility of ascending infection because you block off all incoming sources of infection to the temporal bone. Osteoradionecrosis of temporal bone, it looks uncommon, but believe me, in our practice, it's quite common. Cancer is quite common. Radiation therapy is so common, for the cancers. Beside the surgery, the adjuvant therapy as a part of sole radiotherapy, or many ways, the radiotherapy is so commonly administered nowadays for cancers. And this radiotherapy can lead to osteoradionecrosis and further sensorineural hearing loss. And those patients where the bone itself has become avascular, brittle, and doing a CI is inviting problem. As a regular CI, if you do, inviting problem, if infection sets in, nobody can save. The best way to remove all those brittle bone and then do a CI and obliterate with a vascularized flap. It's the only situation where we recommend a vascularized flap to obliterate. Otherwise, we always recommend, fat for the obliteration. The reason being, fat you can follow, future for the recurrence of cholesteatoma or anything with the fat in, because you can do a fat suppress MRI imaging. But once flap is there, you cannot follow the recurrence so easily because the variable intensity that flap gives on any of the scanning you get done in the future. So fat is the best material, but in this situation, we have to think of vascularized flap because the bone needs vascularity. The entire area needs vascularity, which is compromised by the radiation therapy. Revision surgeries, regions for any anatomical abnormality like we yesterday discussed, any highest jugular bulb, any abnormal, inner ear anatomy, abnormal facial nerve anatomy, abnormal contracted mastoid, abnormal, cochlear rotated, whatever it is, in any given situation, since this gives the best of the exposure, you can deal with any of such situation in the easiest way rather than complicating your life with a regular surgery where you can't approach so easily the round window, or otherwise you can, you're likely to give complication while dealing with a regular way. So there are many situations where you can use this technique as a savior in those patients who require CI for rehabilitation for their profound hearing loss. So advantages are obvious, like we discussed. Contraindication, like for any surgery, this surgery is also certain contraindication. As I said, ascending infection is biggest, the active infection is the biggest contraindication. So you can control the infection and then do at the same stage, even within the CSOM patients. We have done more than 50 cases of CSOM with CI at the same stage, many of them having cholesteatoma at the same stage, after bringing the infection into control. Secondly, the electroacoustic emission is one of the way to rehabilitate, by electric and acoustic both methods to give better hearing. When the lower frequency is preserved, you can do acoustic stimulation along with the electric stimulation of the CI. Here, because we do a cul-de-sac closure of the canal, external artery canal, the possibility of ESC is completely ruled out. So whenever you think of ESC, this technique cannot work. There is always a question, how can you do in the presence of cholesteatoma? Who can ensure the cholesteatoma is not going to come back? Yes, practically, theoretically, yes, cholesteatoma can come back. But you know how you deal with the cholesteatoma. With a canal down mastectomy, you can remove cholesteatoma easily from everywhere. This technique gives 100 times better exposure than a canal down mastectomy because you excentrate each and every bit of mucosa and epithelium from the temporal bone. Leaving or chances of leaving the cholesteatoma behind are always remote. Then the chances of leaving the mucosa behind. Leaving the mucosa behind is a bigger challenge than leaving the epithelium behind. So cholesteatoma is lesser a challenge. Leaving the skin behind or recurrence of the cholesteatoma is less a challenge than leaving the mucosa behind. So we have to drill out, like yesterday in temporal bone, I demonstrated at places how to, excentrate each and every cell bit from the temporal bone. This you have to look at the HRCT scan and then look at the cellular tracts, how they are, related to the Peters apex and surrounding the labyrinth, and you have to excentrate each and everything guided by the CT scan. So leaving the skin behind or a cholesteatoma is a less challenge than leaving the mucosa behind. Risk and complications are there with like any other surgery. You obliterate with the fat can get infected. And to prevent that, we soak in the rifampicin because it prevents airborne infection. You have to administer antibiotics as well as you use a free tissue. Blind sac can give way. You have to reinforce with other layer, like with the cartilage. You can suture the tragal with the conchal cartilage as a second layer for reinforcement, or you can use a surrounding flap. Today, we have a case, Dr. Hetal told me, which are multiple revision mastoids done at a huge meatoplasty, and there is a challenge for the blind sac closure, and we'll show how we can use the surrounding flap, any of the flap. There are n number of flaps around the temporal bone. You can reinforce your canal closure with any of the flap to ensure that it doesn't give way. So cul-de-sac blind sac closure is a very important part. If it gives way, it can allow the epithelium to ingrow, and everything, entire purpose is defeated, and it has to be carried out in a very, very proper manner. So these are the challenges. Disadvantage, obviously, there is always a fear of leaving the mucosa or epithelium behind. So it mandates a long-term follow-up. Our protocol and the biggest challenge in the follow-up is the MRI, because with the CI in place, though majority of the CI nowadays are MR compatible, but the problem is the artifact. And it's so difficult to, follow stringently with the MRI so confidently that if anything is going behind, you cannot pick up MRI because of the artifact may not give you adequate actual picture. And in those situations, we follow with the CT scan many a time. If there is a cholesteatoma, still you can follow with the CT scan. The CT scan, a contrast CT scan, the cholesteatoma will not enhance, and a serial contrast CT scan can actually pick up if something is growing in the in the submerged fat, if cholesterol or something, and that can mandate your re-exploration or anything. So these are certain challenges you can follow up like this. So to conclude, this technique must be in the armamentarium of every CI surgeon to rehabilitate patients with various challenges like we discussed. And this is one of the best way to, prevent ascending infection in the future, those patients who are implanted. And third is we should assess more and more before implanting young children. We have number of patients, number game is so big in the CI surgery, and every now and then so many CI surgeries being done. Maybe some of them without adequate workup. So workup from infection point of view is very, very important. Like I mentioned yesterday, any patient with a cleft palate having normal eardrum, no incidence of otitis media, no incidence of allergy or anything, can develop otitis media in the future because of malfunction of the Eustacher tube. And we have to think twice before doing a regular CI in those situations. So we have to be very careful in case selection, and those patients who are high likelihood of developing future infection must be rehabilitated with a subtotal petrosectomy CI to stay on the safer side. Thank you so much for your attention.
Thank you, sir.
Thank you. Can take questions if anybody is.
Sir is a great teacher, great demonstrator all over India. He conducts workshops and he is there with us today. It is our honor to felicitate Dr. Satish Jain, sir. Please sit down, sir. Certificate. I call upon Dr. Ashish Bhumkar to do the honor. Okay. Puneri Pagdi is a symbol of knowledge and intelligence. So Dr. Satish Jain is the most apt person to receive it. So we are really honored to have him here. Yeah. I request Dr. Prasad Kelkar to felicitate our moderators, Dr. Jivan Vedi, Dr. Devi Prasad D, and Dr. Amol Khare. Moderators. Moderator. Right. They were serving money.
सर आप सेंटर में
Thank you very much. Yeah, just see whether they're ready. Okay, till the OT is getting ready, we'll start with the auto shield session. For this session, I call upon Dr. Atul Awad, Dr. Rajesh Bodepalli, Dr. Vipin Ekhar, and Dr. Manoj Deshmukh to be the moderators. The first lecture in this series will be by Dr. Shailen Modi. He will be speaking on single-handed endoscopic tympanoplasty, open book inside-out technique. Dr. Shailen Modi, please.
Yeah.
Okay, no worry, no worry. Sir, can you see? No, sir, can you see that? Which one?
Dr. Shailen, inside out technique.
Inside. ये नहीं है ना आपको?
नहीं, single ended.
भेजा मैडम आपने? नहीं, just you forwarded? मेल किया व्हाट्सएप की?
मेल किया।
हाँ, एक्सेस नहीं है। Meanwhile, you can talk, sir. I'm just saying.
पहले ओपन का तो बाद में देखता हूँ।
Sir, permission access is not. Or do you have your on an email address? Just
sir, 38.
just log in, sir. Just log in. Please. Sir, just one.
I call upon Dr. Ellen Namdev. He will be speaking on control of deafness in India and role of endoscope. Dr. Ellen Namdev from Delhi.
Thank you.
इनका दिया हुआ सर।
हाँ, ठीक।
और ये दिया हुआ। ये यहाँ से।
ये हेलो।
ये next। नहीं, ऊपर नीचे का ये भी तो भी चलेगा।
Good morning to all.
Sir, sir, एक-
I thank Dr. Mubarak Khan and Dr. Sapna Parab for giving me opportunity for speaking on this topic. Out of 5 senses in humans, hearing is very important for development of speech, which is crucial for verbal communication and personality development. Hearing loss and deafness is second most common form of disability after locomotor disability in India. Disabling hearing loss is defined as loss of hearing more than 40 decibel in better ear in a person above 15 years of age and hearing loss greater than 30 decibel in an individual below 14 years of age. Grading of deafness, mild hearing loss ranges from 26 to 40 decibel, where person is able to hear and repeat words spoken from a distance of 1 meter. Then moderate hearing loss ranges from 41 to 60 decibel, where person may hear and repeat words using raised voice at 1 meter distance. Severe hearing loss 61 to 80 decibel, where person may hear some words when spoken in a shouted voice into the better ear. And profound hearing loss is total hearing loss is above 80 decibel, and when person is unable to hear any words even shouted. As per WHO estimates, 466 million individuals present with disabling hearing loss in 2018, out of which 91% are adults and 9% are children. It is projected to rise 630 millions by 2030. Nearly 80% of people with this disability live in low and middle income group of countries. An average of 6.3% Indian population is suffering from disabling hearing loss. Out of this 6.3% population, 4% live in urban areas, while rest of it in rural and slum areas. Causes of hearing loss, we don't want to go in detail, but I want to enumerate prenatal causes are there. Important of it is genetic, which includes heredity and non-hereditary. And also along with this, infections in pregnancy. For that, we are giving immunizations. Then perinatal, which includes birth asphyxia, severe hyperbilirubinemia, premature low weight babies, and others.
The most important is childhood and adolescence group. In this group, the highest population suffers from the hearing loss, and causes are there: ear trauma, foreign body, wax infection, chronic ear infections. The most important of this is chronic suppurative otitis media and chronic non-suppurative otitis media, that is fluid inside the middle ear or glue ear. Then meningitis and other infections. And fourth group, adulthood and elderly. Here again, the same trauma to the ear, wax infection, infections, and then smoking, exposure to loud noise, hard impacted wax, ototoxic drugs, ototoxic medicines. Nowadays, most of the medicines which are toxic to ears are used maximum, like for cardiac patients and for the prophylaxis of the cardiac diseases. People go on taking aspirin in the low dose, even that is toxic to the ears. Then all anti-tubercular, most of the anti-tubercular drugs, they are toxic and cause hearing loss of varying degrees. Then antibiotics, which are mostly used. Then impact of hearing loss. As we all know that it acts as a barrier of communication and speech, which is very crucial for personality development. Then perception problems, social isolation, loss of productivity, and economic loss to the society. So early and accurate identification of birth asphyxia, hyperbilirubinemia, auditory neuropathy, and most important is the presbycusis. Nowadays, as the average lifespan has increased from 28 to 58 and above, the number of cases of presbycusis are increasing more and more. Then smoking has been very much increased, and exposure to loud noise. Means you will see each and every person is using mobile along with a headphone in a loud intensity. Even everybody has heard about Alka Yagnik, who developed suddenly hearing loss. That is also because of this all exposure to loud noise. Chewing tobacco. So these are the important causes of deafness. We, being ENT surgeons, our intervention is must to decrease deafness from the society. For prevention of hearing loss and its management, we dispense hearing aids, which are of 4 kinds. Number 1, pure external hearing aid. Then the hearing aid which is hidden in the ear canal. Third is Baha, means bone anchored hearing aid. And lastly, and most important, is cochlear implantation. Yesterday, we heard in a lecture that cochlear implant is not only for the children, it is helpful in any kind of, in any age, for sensorineural hearing loss. And in future, we may see that government may promote and supply cochlear implants for the presbycusis persons. But foremost important from our point of view is the chronic infections, that is chronic suppurative otitis media and non-suppurative otitis media. And in this way, the curing the discharging ear. One more thing that government has started and launched the National Program of Prevention and Control of Deafness in India in the year 2007. But most of us know that it is only on the papers. Nothing has been done positive to promote this program. Although objectives of this program were to prevent avoidable hearing loss, early identification of hearing loss by screening of newborn babies, preschool children, school-going children, and adults. Early diagnosis and treatment of hearing loss, provision of hearing aids like cochlear implant, external hearing aids, bone anchored hearing aids for rehabilitation. Most important aim of this program is capacity building. Means the institutes must be built capable in all respects, like equipments, logistics, trained staff, etc. Which means from medical college to district hospitals, then to the community health centers and primary health centers. The program which has been launched from 2007, even the district hospitals, they don't have the microscope. More than 50% district hospitals. And then education means making aware, producing awareness in population. Due to unawareness, the most of the population is unable to avail timely the services of this national program. Something about the history. Notable ear surgery has started in 1878 by Berthold, who first performed true tympanoplasty using deepethylized tympanic membrane. In the beginning, the stalwarts were doing ear surgeries with the help of goose and hammer for mastoidectomy. Even when I was doing MS in the year 1982, our professors used to promote goose and hammer, and sometimes they were using these with and the microscope was not available in every OT. So sometimes loop was used for the mastoidectomy and tympanoplasty. The new era of ear surgery, modern tympanoplasty began with the advent of operating microscope in the 1950 in India. But in spite of starting it many decades ago, these kinds of surgeries are limited to only tertiary care centers. Now I'm just for 1 minute talking about the endoscope. As everybody has told us what is the use of an endoscope and difference between microscope and endoscope. With endoscope, we can see every corner of middle ear, any research, sinus tympani, epitympanum, retrotympanum, pursax space, and everywhere, every corner can be cleaned. And in the same way, every corner of India can reach this endoscope with our ENT surgeon. Even microscope has not been supplied so far. It requires one endoscope and monitor for doing tympanoplasty. If all ENT surgeons are trained like Dr. Mubarak Khan and Dr. Sapna Parab, they are doing very noble job for training the residents and juniors. They have started fellowship. I recommend every resident that they must they must do this fellowship and train themselves, and government should also help them. Thank you very much. I thank again Dr. Khan and Dr. Sapna Parab, and I will request to stakeholders that they must suitably award these persons and Khan Foundation. Thank you very much. Thank you to all.
Thank you, sir, for your thought-provoking lecture. I request the moderators, Dr. Atul Awad, Dr. Rajesh Bodepalli, Dr. Vipin Ekar, and Dr. Manoj Deshmukh to come on the stage and felicitate and give the certificate to Dr. Namdev. Speaker, sir. I call upon Dr. Shailin Modi to felicitate the moderators.
हेलो हेलो आ रहा है
Hello. Good morning, everyone. Mubarak Khan sir has started with the left endoscopic T-plasty, giving you the brief history of the patient. She is 32-year-old female, complaining of left side ear discharge since 3 months. On examination, left side there is a small perforation in anterior quadrant.
Thank you.
Cuneiform test
Okay.
shows 512 negative on left side, and Weber's is lateralized to left. PTA shows left side mild to moderate mixed hearing loss, and X-ray mastoid showing bilateral sclerosomastoid. The plan of the surgery is left endoscopic tympanoplasty with total annular excision. Thank you.
I call upon Dr. Vandana Joshi and Dr. Dhubo Roy to take the place for moderators. Please come in the first row. Dr. Vandana Joshi and Dr. Dhubo Roy. This is type 1 tympanoplasty going on. Tragal cartilage has been harvested. Dr. Vandana Joshi to come as moderator in the first row, please.
Briefed? Huh? Yeah. Hello. Hello.
Hello.
Hello, Kulkarni sir.
Yeah. Good morning. Good morning. Yeah.
Good morning, sir.
Yeah.
I have already already harvested the cartilage.
Okay.
Yeah. Good morning, Dr. Dhruvo, Dr. Joshi.
Yeah.
Good morning, good morning.
So this is a simple, I will do a simple type 1 tympanoplasty, mostly underlay. If there is a mucosalization, I try to do the TAE, but here it's a, I think I will show classical type 1 underlay tympanoplasty by transcanal approach. Yeah. You can see here the ear is pierced little bit too medially. You can see this. So that's why I have gone beyond that and my incision is little bit down and I harvested the cartilage of around 10 millimeter by 8 millimeter. Today again, we are using the Olympus 4K system with 2.7 HD endoscope of Olympus. So this stitch need not to be taken out because it's a Vicryl 5O. So we'll start. The classical plan is to take a stay suture, the first defined by Muaz. Unfortunately, he has to leave early due to his mother's illness. And Dr. Parab has modified that therapy stitch by taking two, the one in the posterior superior and other in the posterior inferior. That stay suture gives you around 2 millimeter of suction, please. 2 millimeter of extra space where you can manipulate the instrumentation. Do the instrumentation is quite good. So depending upon the type of work transcanally, we modify, either take a single stay suture, it's called therapies stitch, or otherwise we take two stitches, that is designed by Dr. Sapna. So we call it modified Tarabishi. With the endoscope, life has become easy. A lot of work can be done transcanally. You can address many otological problems transcanally. And yesterday you have seen extensive cholesteatoma I have managed with the mini end oral incision. So need not to go for the post-oral. And with a mini end oral incision, no need of myatoplasty and all, and healing is too fast. So many advantages which we can discuss. And one of the most important advantage of endoscope is having the panorama. Everything is in one picture, like a eagle's eye. So when the eagle is there, in the sky and he is looking for his spray down on the earth. So the whole panorama is in his eyes. The same thing is with the endoscope. So first I will do the endoscopy. So they have infiltrated already. Can you see the perforation?
Yes.
Yeah. Large central perforation anteriorly it is going, so will make little bit overhang is there, but with the endoscope we can manage that. So first little bit anatomy for the juniors. Give me the ballpoint. Wheat is not properly applied 1 day prior, so those hairs are there. We prepare our patient 1 day prior. Our staff applies the wheat cream, the hair removal cream 1 day prior, and we take out this all hair. So it's very important. This doesn't touch us to the endoscope and spoils the lens. Anterior wall, posterior wall, superior wall, inferior wall. So if we'll go inside, my incision will be around.
I don't think the sound is going good. Is it going?
Hello?
From 6 o'clock to I will extend up to 3. Yes, hello?
Dr. Khan, can you hear me? You have some of the delegates here, they want to see your suture, Tarabichi suture. Okay.
Yeah, I'm going to show that because
And one modification done by Dr. Parab also, you would like to see that also. Okay.
Yeah,
And I had one question for you, Dr. Khan. If you have
Yes.
a moist ear, not a discharging ear, but a moist ear, say a serious watery discharge, and would you go ahead and do the operation, or do you like to wait for that?
Absolutely. Absolutely. Wet ear is not as an contraindication for me. But if the pus is there, if traces of pus is there, I will not operate. If
Right.
it's a wet ear, but it's a mucoid discharge and it is not getting subsided because there is some ventilation block inside. So you have to open it, clear it, and go ahead with that. But if the pus is there, there's a little bit of sort of suspicion of infection, I will not operate.
Fine.
So you will see, we'll go a little bit near and you can see that bleb is due to the infiltration. So it's quite anteriorly placed perforation, but you can deal it nicely with the endoscope. It's near the narrow canal due to that overhang. So let's come out. And we are here. Tragus anteriorly, incisura terminalis, posterior canal wall skin. So my Tarabishi stitch will be exactly between the between the cartilage and bony junction here. So if you take it perfectly at the midpoint, this is 12 o'clock, this is 6 o'clock. If you take it at the 3 o'clock, you go through this and come out postorally and pull it. That's a simple Tarabishi stitch. If you go here in between the 3 and 12 o'clock, that is at the 2 o'clock, take one stitch here and another down and you pull it. I will show you. Simple. You can use 2O or 1O silk or simple linen, which you use for the tonsil, but you need a cutting big needle. Look at this, okay? Use a cutting needle. Round doesn't work and you traumatize many things in the skin. So let's go. Are you getting a good picture there?
Yeah, we are getting. Yeah.
Yeah, see this. At the junction, exactly at the 3, this is a Tarabishi, okay?
Yeah.
I'm going. You need to have a big needle and then come out from here.
Are there any specific criteria when you want all the people to put in such a stitch, or only if the canal is too protruding, posterior canal wall?
No, for every case for
As group.
transcanally, you
Okay.
use this stitch. It's
Okay.
like as in pulling your pinna outward and backward when you are
Okay.
trying to look into the EAC in OPD. The same thing. So now see, it's in situ, and when you pull,
That's indeed a good idea.
can you see that?
Yes,
Yeah.
very
Can you
much.
see that?
Yes.
Yeah, so it's 2 mm, and this 2 mm matters a lot transcanally. Okay. So
Mhm.
now this is originally described by Professor Moaz, and we have published that the first time. Moaz has not published, but we have published in American Journal the same stay suture, and we gave a credit to Moaz. Give me the God's piece. Even he was not aware. He was I was not knowing this. Okay. So now, what is the modification by Swapna? So you just pull like this. Can you see that?
Yes.
Upwards.
Posterior superior one,
Hmm.
and other will be here. I am not going to traumatize that, but here I don't need here. So other is here. Give me the needle. I will just show you. Just needle दाखव मला फक्त तिकडे. So other will go from down, that is in posterior inferior quadrant, and then you pull the lower part. Got it?
Yeah.
Hello?
Yeah,
Yes,
we
very
understood.
much.
Yeah.
Yeah. So let's go now. Some flush. See the overhang, okay? You are not able to see the perforation when I am putting the endoscope in outer canal.
Dr.
It's a
Khan, sir,
transverse
will you
canal.
like to put a gel foam with adrenaline at the perforation site prior?
Perforation site is in anterior-inferior quadrant. Anterior-inferior.
Would you like to keep a gel foam soaked with
Posterior-inferior quadrant.
adrenaline there?
Yes, madam. Come again.
Would you like to put a gel foam with adrenaline in every case at the beginning of the case?
Yes, yes, it is better. It's a good idea because you decongest that area because whatever small inflammation is there, you'll get a good feel. So I use Ivilon pack soaked with the xylocaine with adrenaline. So can you give that? When we are taking the incision, till that time it will get decongested.
Yes.
After going little bit in. First we will freshen the margins and then we will put the cecal. पाठीमागचं काही लाईट आहे का मला त्या स्क्रीनवर मला दिसतोय कॅन वी क्लोज दिस लाईट नो दिस और रिमूव या रिमूव दिस यस बेटर हाँ अगर वो टॉप लाइट ऑफ करे तो अच्छा रहेगा so now it has got the zooming so let's see we can अरे मत लाइट नहीं चाहिए so this is a zooming look at this and then focus. Is the picture good?
It is not very sharp.
Focus.
It is
Need
not
to
very
focus,
sharp.
yeah.
You need to focus. Yeah.
Just let me do. अरे मला पाठीमागून लाईट नको काय लाईट आहे थोडासा फक्त एक लाईट त्याला द्या तिकडे मला इथं See, this is a 2.7 mm of endoscope. We actually prefer a 3 mm endoscope. 2.7 doesn't give that much of good sharp image. That's why it's a little bit of problem because they don't have a 3 mm endoscope here. But 3 mm endoscope gives you a very crispy image. And when you do the zooming, again, some pixelation is there. So better to use a 3 millimeter. So keep your suction in the left hand, that take care of fogging of the endoscope, as well as it cools the endoscope.
Good idea.
So you should try avoiding these blebs. But it's okay. Okay. The beauty of endoscope is that you can see everything in one quick go, and you will not miss the thing. Serious. Huh? But the criteria is that you need to have high-end cameras, 3 cheap cameras minimum, and high definition cameras. Don't try it with these single chip cameras. Never try endoscopic your surgery with the single chip camera. That's a compromise. Because you are looking at the monitor and you need to have that good crispy image. Yes. Now we'll put xylocaine with adrenaline pack. And I think for the younger generation, it's very easy to learn. Obviously, there is a learning curve, but I think it is little bit more easier than the microscope to learn with the endoscope. Because you are seeing everything, what is happening there in front of you. And that with the panorama. And obviously, 2 hands are must, because you can do everything with that. So now let's go for the incision. I will little bit to make a crispy.
Can you focus a bit more, please?
Yeah.
2.7 is. नहीं दिखेगा, इससे अच्छा नहीं, इससे अच्छा नहीं दिखेगा। 2.7 में ऐसा ही है, हम तो 4 से करते हैं।
So I will create a flap first. So here is the annulus. So let's go for this. If you take little bit away, that's at the junction, it's quite difficult to elevate. But depending upon the perforation, you need to make the incision. So here it's an anterior, so I will go here. These flaps are very important because to survive, for your graft survival, you need to keep this graft intact. Very thin skin, take a time to elevate, no hurry. Now see the ease of doing this with the 2 hands. I'm hardly taking out the endoscope in and out. Whenever I want to go near, then I will go near with the fine focusing system of my endo holder. Let it be a small bleeding and all. You can easily tackle with the suction. Obviously, little bit of learning curve is again needed, but we have developed that sheep head model. So anybody can do the dissection in their OR. And sheep head costs hardly a 300 or 400 rupees. because we work in private and we don't get a temporal bone, so it's not allowed. So, but learning should not stop. And the ear is similar, almost similar in the goat. Even you can train the nose surgeries on the sheep. And our all fellows who visit us in Thalegaon, they do extensive sheep head dissections during our fellowships. Till they are trained with using the two hands and the endoscope. That's called two-hand eye monitor coordination. And that is what is required for the training. So I will go a little bit near. Now compare this with the transcameral microscopy. Definitely you can do it. But the ease with which you can do with the endoscope and the two hands, it's unmatchable for the, at least for the younger generation, what I have saw. They immediately grasp this and carry out. The learning curve becomes a fast.
They use that eyelash.
So there is no fight, what
If it's
microscope, endoscope, no fight.
I'm using
But
that.
which tool is good? Which tool is good that you
We
decide with your expertise?
We don't use it. We don't use it.
Is there any contraindication?
That's why we don't use it. Vascularity of the flap. We'd like you
So
to.
now
Actually, don't like
use proper suctions. A bigger suction can damage your flap. Control the suction.
No, not purpose.
Pressure or use a proper size suction piece.
Just making it.
Let's go near. Whenever I want to go near, I go.
After the success of that eyelash, yesterday I asked him, saying I am inventing more and more instruments like that. Of course, bleeding will be definitely less, but as you said,
Yes, Ayla is there. He has this circular with I think cautery, huh?
Sir, good morning. Dr. Maya.
Good. Dr. Bhaiya, yes.
Swami's cautery, we were discussing about the same right now with Dhruv sir and madam
Yeah,
here. Is it contraindicated or is it?
Ayla is there? Ayla is there?
I'm searching, sir. No, my question to you is it vascularization is going to get affected because of the cautery or is it okay to use it?
This is a debatable question because actually my personal opinion is that you should not use the cautery on the skin in the external auditory canal because this is a very the skin is very precise one and functioning skin because there is a migration. This is a migratory epithelium in the external auditory canal, and whenever this burning is there on the skin, many of the time I think these granulomas are formed. So this bleeding is not that much, for that. So I don't think it's but for
Yes.
the bleeding and all, it's good.
We
Controlling the
take
things.
it regularly. That is the reason. But is it debatable or that's the reason we wanted to ask you, sir? Thank you.
Yes, yeah. So take a time to elevate this, very important.
What will take care?
So we have reached.
We want to use.
Let's go now a little bit near.
The radio frequency which is available, that will give you less.
I agree with you. I agree with you.
So this is the one which we did.
I agree with you 100%.
The most important is infiltration. You know how to infiltrate.
It doesn't work.
Wait for 10
So when I
minutes.
reach at the 6 o'clock, then I will go under the skin. I will not go 360-degree incision, but I will elevate 360-degree.
Right. That's most important.
I'm doing this in classical underlay because those things has been taught. So I want to give a crystal clear idea because this one procedure is taught in during the curriculum. And this time we had a great response from the all postgraduates. I think more than 50 postgraduates are there, 23 or 25 plus PG papers, then there for the cadaveric dissection, and then there is a e-posters from 30 people. So I want to give some classical approach to learn. Personally, in my all private cases, I would like to mention the name of Suri because he gave the idea of that TAE, that is called total annular excision, and it really increases your success rate by 1 to 2%. But I individualize those things. Whenever I think that little bit of mucosalization is there, means the mucosa is grown over the squamous epithelium through the perforation, you can see that. So in such situations, I decide to do the TAE. If it's a classical dry central perforation, I do underlay. But maximally, give me the irrigation. But many of the time, our patients are suffering for the chronically for many years, and always there is a mucosalization. Mucosalization means what's the red tympanic membrane around that perforation. So better to take it out annulus, and it hardly makes a difference. There is no problem, and with endoscopically we can do it very beautifully. Yesterday I shown that. Now cecal, we will take that out. Forceps.
ये decision. You have to see दिया है. थोड़ा सा सामने गया है. थोड़ा सामने गया है. थोड़ा सामने गया है. 1 o'clock.
So now it's nice perforation, and that was a good idea to keep that adrenaline soaked gel foam or Ivilon pack, Merosil pack. Suction थोड़ा छोटा मिलेगा. Can you see that immediately the first thing which will come is incudostapedial joint? Can you see that?
Yes,
It is
yes.
coming in your bed. Yeah.
Audience, if you have any questions, do let us know.
This is a classical elevation of the underlay. You can see the mucosal layer here. Now cecal again. I will direct here towards superiorly. Can you notice this? The black marks on the suction tip?
Yes, yes.
So that is for to know where I am, to overcome that little bit of depth perception problem. Simple innovations which makes your life easy. That's every mark is a 1 millimeter mark.
Good.
So this is the Prusak space, lateral process of malleus.
Mhm.
I'm dissecting. And then you should dissect the chorda. I keep always the graft over the malleus, so I need to denude it nicely. So that's my incision. Can you see that?
Yes, very much.
See this?
Very
I
nice.
incise that. No extra forces. Yesterday I told you, don't use your shoulders, only wrist and your fingers, like the artist. And you need to practice that. So I always tell to my fellows, whenever they two instruments you have to hold and wait for 15 minutes every day. For the balancing your two hands. So now we'll go from here. I'll support. Or many of the time you can just peel it off, but it is better to have a sharp dissection. Suction, please. Can you see the canal for the tensor?
Yes.
This one, down one, okay? Now some forceps to peel those off. Whenever you are using these instruments, the crux is use the canal wall as your fulcrum. So there will not be a much movement, okay? I am using those as a fulcrum. Otherwise, if your hands are hanging, so the vibrations will be there like this, okay? Better. No extra forces. Force मला चांगलं देतेस का काही? These are fibrous layer, but try to take it out. But no undue movement.
Nice.
Yeah. Support your instruments with the canal, and then yes, better. Even with these, you can peel it off. See this like this. No extra pressures. Now my angled flag knife. Look at this angle. Your routine flag will not work here with the endoscope and two hands. So that's why you need to bend those instruments. And I told you we have bent around 9 instruments and created those complete set for two-handed endoscopic ear surgery. Now it's better. You can see the eustachian tube now.
Very much.
Yeah. Colia, near, and then you will see everything. See this? I can see the very nice tensor canal, eustachian tube, and then the supratubal space, anterior isthmus. I will show that later on, okay? First, we will elevate this from the down. So almost I have elevated 360, see this, but the incision is, I have kept parked here. So the from under the flap, I elevate.
You have not taken any
That's better.
incisions superiorly or inferiorly. Only the 12
Yeah, so
12 o'clock
I
to
go under
6
the flap and then elevate. Yeah.
Correct.
Normal salah. So classically, the type 1 should end with inspecting the middle ear, looking at the anterior isthmus. If there is a flush, I usually flush, make a dexamethasone. I will show you how to flush the anterior isthmus and remove the blocks if at all. I meticulously do that, but here, look at the mucosa of the promontory. If that's an edematous, if there is some small polyp over that, always suspect there is selective dysventilation. So I open the tensor fold in those cases and then anterior isthmus also. But here I will show you for the demonstration. Here it's a nice mucosa over the promontory. It's not much hypertrophied or allergic, and even the condition of the mucosa, if you note on the tensor canal, that's a very nice. So that's a ventilated area. So just open a tensor fold and then additional ventilation will be there. I will show you that. Forceps. Even I will show you how to use that curate, angled curate. Give me the curate. Here there is no need for the type 1, but I just for the demonstration, I need not to touch the chorda also because it's nice. So look at the angle again. These are the house curate which are bent at the around 45 degree. So with this, the efficiency increases and you need not to exert much pressure. Just engage it and rotate. That's all. Nothing, no extra pressure, nothing. Engage and tuck. That's all. मतलब मोठं थोडंसं section. This is just for the sake of demonstration. Lot of work can be done with the good curates, and if you have these bent curates, nothing like it.
Dr. Khan, could you just
Again, one point, I personally sharpen all my instruments after every 10 surgeries. So if you want to see that, how I do it, how I use that diamond burr, the video is there on my YouTube channel. You can see how to sharpen those instruments. Because after 10 surgeries, those become blunt.
Dr. Mubarak, can you elaborate on using external canal as fulcrum while using the instruments? Can you just demonstrate from a distance of what do you mean by that?
Okay, that's good. Yeah, see, here is the from here I will show you when you are using the two instruments. Suction, give me one ball point. These two instruments are here. So use this canal like this, okay? And suction here. So I am using this as an fulcrum. So the instruments goes like this slowly. So there will not be movement because you are getting the support of this, and then you can do the movements like this, right?
Okay, that's nice.
If your instruments are hanging, so there will be like this chopstick effect and also some tremors. Got it? After certain time, after for 15 minutes. Got the idea?
Yes.
Hello? Yeah.
Yes.
So just see, and even you can give pressure as much as possible, no problem. The Muaz gives the uses this as in for the single-handed endoscopy. So he pressurize so much that he create a space, okay, with the endoscope with a single hand. So the same thing with the two hands, you can use this as a fulcrum and then carry out the work. Okay. Yes, I hope you understood this.
Thank you for
And
explaining.
very important. Yeah, it's very important. And efficiency increases for your surgeries.
Yeah, because I myself thought of this what you're explaining.
Yes.
But I thought you were talking about keeping your little finger externally near the pinna somewhere for support. So
Even you can do that by supporting the with a little finger, you know, over the head, and then
doesn't get pushed.
somewhere the support has to be there.
But this is a nice idea. Good.
Okay. Little bit of cure it. For this curate, you can use a 1 millimeter diamond burr for sharpening, okay? At a very low speeds, at around 1000 speed of your drill, typical your routine drill.
In this case, are you doing the curating purposely or just for demonstration?
Purposely, just to show you, okay? That's all. So this is how efficiently you can do with this angle. If it's a straight one, you will apply more pressures, okay? These are small tricks, tips and tricks for your fast surgeries, okay? Let's go and open that I do here. That's called tensor fold opening. So again, my angled peak.
Dr. Khan, we want a little bit more clarity. The focus has to be a little bit more.
What you said, focus.
Focus has to be a little bit more.
Okay, you're not seeing because I have a very good picture here. I think because this is a 4K system, there might be some transmission problem because I have a very beautiful picture here. Let's try and see again.
Probably, I think because of the smaller size of endoscope, smaller diameter endoscope.
Exactly, that is one thing, but I'm having a good picture here on this 4K monitor.
It is better.
3 millimeter endoscope gives a fantastic view. 2.7 has got some little bit of problem. So I don't prefer 2.7, but they don't have here.
We would like to see the tensor fold.
Yes, because that is what I'm opening for.
Yeah, the disposition of the tensor fold, horizontal or vertical. We would like to see that. If you can show,
Yes.
please.
So look at these two angles, okay? This is your peak. So again, by just a simple rotation, you can open. This is the area, okay? The fold is here, see this?
Yes.
Okay, the malice is moving, right? So this, in 25% cases, some small opening is there and its anterior tympanum is ventilated, but 75% case it is blocked. Blocked means it's there, which is not, it's complete tensor fold, okay? So in such situation, if you open it, the additional ventilation will go from the supratubal races to anterior tympanum area. So nothing to be done, just put inside and small series and rotate outside. That's all. Any of the time I have seen the polyps are there. Look at this. Got it? But here, nicely I can. It's actually very slowly you have to do, otherwise you can take out the malleus. Look at this. Got it?
Yes.
Now I will go very near. See this. See this. Okay?
Yeah.
Very
Yeah.
good.
Can you see?
Yeah.
Yeah. Now anterior isthmus, but I will flush that. I will show now the flush. After doing the flush, from here you will see the flush coming from the tensor fold. This is the anterior isthmus. So it's open. Here, see this. Many of the time there are polyps, there's glue which is coming. In such situation, I take out little bit more bone, go behind and peep inside the mastoid, mastoid antrum. So actually we are designing that small irrigator, but now here I have bent it 26 number needle. Look at this, okay? So they have the DCR cannula. The similar thing, it has to be here. Again, you have to do it very slowly because one movement can take out all the ossicles. So this cannula need to be very curved and only nicely entering with a blunt tip. So this is not a blunt tip now. It's a smooth tip you need. Okay?
Yes, yes.
I'm just putting inside. And note now, very stably you have to do it. Keep your eyes in the tensor fold area. It's still not. So I will put here. Can you see that now?
Yes, yes. Free
Hello?
flow. Yeah, we can see.
See this flow from the anterior stomach. See that?
Yeah.
Yes. So that's you have to do it, but very gently. See that flow?
Yes.
Okay. This is just for the again demonstration, but it was not needed here. But almost more than 50% cases you get this block. That's called selective disventilation. It's nothing but like as in your maxillary sinus ostium. You widen it, you open it. So anterior isthmus here is my maxillary sinus ostium. The whole 80% ventilation goes from here to the mastoid antrum and then the whole mastoid. And 20% is here. That is posterior isthmus. Let's go now. So this is the posterior isthmus.
Beautiful. Now the clarity.
This area is a posterior isthmus. Okay.
Now be clarity actually.
Yes.
Okay.
See now. We can see
Okay,
better now.
good.
Yeah.
Yes. Look at this. Yeah. Look at in the tensor fold area and look at in the anterior isthmus area too. Yes. So let's prepare the graft. Give me some normal saline. I prefer actually ringer lactate. So that the ringer lactate is more physiological. We were doing those study, but now
I do.
it's incomplete, but we will prove that using the normal saline and the ringer lactate. What's the difference on the cells? Huh? So I think, Mira, you have taken ringer lactate. Yeah. So it's more physiological because the normal saline means there is some problem. That's our hypothesis. We have to prove it.
You're talking about the process space.
So I will
He's not going to open it up.
Process space need not be open.
go for the cartilage preparation. Here I am not going to slice it, but create a nice shield graft and island graft because this is a lady and cartilage is around 0.8. Now we know that because the paper is there. With the age and with the gender,
Who's different?
there is a specific thickness of the cartilage in Indian population. That study we have done and it published in JLO.
We have a question.
Now that's a
Dr.
very
Khan.
highlighted paper.
Dr. Khan.
Yes.
Would you like to open the project space in all cases?
Yeah, need not to be. Huh?
Need not.
See, now here also, need not because it's a mucosa. But whenever there is an hypertrophied mucosa, allergic mucosa, now I have started keeping those PRF sheets there because that is taking care of a lot of things. Otherwise, you open it. No, for the clean case, it's not needed. Huh?
And would you like to clean the station tube area?
Eustachian tube area?
Do you flush there? Or do you do something about that? In all cases, do you do something there?
I just peep inside, nothing more than that. Huh?
Right. And there was another issue regarding the anterior segment. I mean, the
12 o'clock to beyond, that is the anterior self area, do you make that area raw from below? How do you assess that area? Because your graft will go there, you'll be tucking it in front. So do you do something there?
Normal saline, huh? Okay. Come again, I didn't understood the question.
Elevation of the flap has been done already. Now,
Just 1 minute, because there is so much of noise here. I can't hear. Just play thoda shanti. Yes, please. Go ahead, sir.
May we request the audience also to
Sir,
keep.
we are talking about the graft. You will be putting the graft now. You have already elevated the tympanometer flap. What about the anterior area? Do you make the area raw in front?
Anterior area.
Yeah.
Uh-huh.
What do you do about that?
We will. I will show you that, because here I purposefully say, look at this. We can go and see there. There is no problem for that.
No, but
so let's go and see. That's all about endoscope. You can peep inside anywhere. And I'm still using the only 0-degree endoscope, not angled. Give me the flat knife.
Will you like to elevate the flap anteriorly as well for the graft bed?
Yes. Absolutely. That I have done, because you're not see this.
Antibiotics.
My incisions are here only, but I have elevated completely under the flap.
Now we have not seen that elevation part anteriorly, where you would be placing.
Yes. See this. I will show you. Look at this. Look at this.
Yes.
Now I have reached up to 9 o'clock. Look at this. I will go inside. Can you see this now?
Yes.
Now, yes. Convinced?
Yes.
So again here, see this. So that is the beauty of the endoscope. You can go and I undermine like this. Okay, I am keeping that flap there, so you get a good blood supply. So 360-degree, there will not be a problem. Got it? So from here to here.
But he's doing.
So it's a triangular flap. See this. And from here I will see the eustachian tube.
Right. Thank you so much.
Yes. Thank you.
Relations in the.
So let's go and see eustachian tube. There is some collection.
You have to open it.
There.
You have to create and open it, and then you have to give a cartilage graft there to close it. Yes.
Yeah. So this extreme anterior part.
Is he doing sometimes?
Can you see that eustachian tube?
Yes, very much.
Canal antroscope.
Yeah.
So this anteriorly, say 8 o'clock to 11 o'clock of anterior flap, we had not seen the elevation earlier. So I asked you. Thank you.
You open it totally. You have to open it.
I have kept the incision here only. I have elevated completely there.
Yes.
There's the disease in that. You have to open it. Open it. Do a master.
Open it.
Yes. Thank you.
Angled circular. Again, for this, the angle, look at the small angle. If you have not done this, so you need to do this. Take an incision.
He does the same thing.
I already elevated, but just for the demonstration, if you have not. And then
This is what is
go underneath and just do this. Okay.
Yes, sir.
Again, you need those bait. Yes, got it?
Yeah,
Yes.
you're done. Yeah.
So let's go and do the graft preparation. So I will be taking out the perichondrium on the side, creating the shield graft, and then give me the ballpoint again. This is a classical underlay, but in my or I do many of the things. Here it is needed. We can go confidently with the underlay. That's why I have demonstrated this underlay. Okay. If there would have been yesterday, there was a case with a lot of mucosalization. I have done TAE in that case. And beauty of TAE in those cases is that the vascularization of the graft happens in the next 15 days. Beautiful, even for the cartilage. Now see, it's nice, complete exposure. Look at this.
Yes, sir.
Yes. Give me the other cases induced. Satish, हाँ देखो और हाँ दूसरा So I think now a debatable question. The all medical schools must include this simple transcanal endoscopic T-plasty. Obviously, I will be biased. Need to be a two-handed. Because we are using this endoscope holder not for the ear. Tomorrow, Dr. Sapna will be demonstrating you the fantastic septoplasty, how she does it. And then even for the tonsillectomy, how you use it. We are applying this endoscope holder for the all oropharyngeal surgeries, laryngeal surgeries. Okay. So when the tool is there, why not to exploit it and make it simple techniques? And I'm happy our fellows who are using this all endoscope holder, they are doing fantastic job and coming up with some different variations. So this is how the science grows. Perichondrium काढलं नाही ना? See, it's a thin cartilage. So what I will be doing, I will be just taking out the perichondrium and then creating the island. Okay. Look at this. The cartilage sandwich between the two perichondrium.
You don't need a cartilage for such a small purpose. You need not.
Come again?
You need not even harvest this. Actually, just a harvesting of the perichondrium would have been sufficient.
True, I agree.
It's better and easier. We do a lot of sutureless techniques. We don't suture the, and there is
So
no.
now again, even if you want to use a full thickness graft, but take out the perichondrium on one side. Over the period, now we are doing it for the last 2 decades, exclusive, our graft of choice is cartilage. If you take out the perichondrium on one side and you keep the perichondrium on other side and put the graft with perichondrium facing laterally, over the period of the time we have seen this cartilage becomes very thin because a lot of the chondrocytes are lost where the perichondrium is not there. If you put full thickness graft, the cartilage is there forever. And there is some problem with the tinnitus and the heaviness in the patient. So that's why it's simple thing. Take out the perichondrium on one side and use this graft, even if you don't want to slice. But for the adult patients, in at least adult male, the Indian scenario, it is 1 to 1.2 millimeter thick. In such situation, you need to slice it.
Actually,
opaque ho jata hai, it becomes opaque. Opaque, it becomes opaque. You can't see anything inside.
yeah, it's all opaque, and we don't know. AB gap kitna band hota hai uske sath? वो भी तो देखना.
I don't use this. I use petrolized solution. I don't use cartilage. So I have no experience. No experience. I have no experience. I don't use this cartilage. I use only petrolized solution. Temporal solution.
What?
Temporal solution.
Just hold on. Blade?
That is sufficient. You don't need less than. Just
Okay, sir.
thing and clean it up. That will take it.
So you can create those islands with this nicely. So this is around 9 millimeter. That's sufficient for me. So the whatever extra thing is there, I will create a island.
Dr. Khan, why would you not prefer perichondrium instead of a cartilage attached with perichondrium?
Because my results with the temporalis fascia was not good.
Perichondrium.
It used to be very why only also perichondrium,
Why?
because I saw, because where I'm practicing, it's an area called Marvel, and a lot of allergy is there. So even if I used to do a nice, why the idea came with the cartilage, because I used to do nice job with the temporalis fascia initially, and then after 6 months, 1 year, I used to see again the patient whenever suffer with the recurrent attack, the same perforation has to be there. So I wanted some strong graft, so I started with the full thickness cartilage. And then when I visited the Germany for my fellowship, then I saw they are using like anything. And I met even Hutton Brink, and then idea of the slicing came, and then I designed this slicer. Because definitely that thin, and this taking out the perichondrium is absolutely our idea. And if you use like that, it's fantastic results, I'm telling you. And it over the period, it becomes very thin. I have a complete documentation of that after 1 year, after 2 years, how that graft looks.
When the patient develops an AOM, what's the criteria? How will you judge? Because he's putting cartilage,
And with the laser vibrometry in Germany, I have seen that that's how nicely it vibrates. Cartilage also vibrates very nicely. And at the same time, it's a strong material. So recurrent attacks are there, obviously, but it prevents a reperforation. Patient visits to you, takes the treatment, and again he is unhappy.
Dr. Khan, there's a question here.
Yes.
Suppose your patient whom you have operated today, she gets the successful graft and everything is fine, and next 6 months later she gets a ASM. How do you assess that? How do you assess the ASM? How do you understand? Because your graft will be absolutely opaque. How do you understand?
What?
The graft which you are using now, after it has healed, you will have an opaque TM, more or less opaque TM. And if this patient comes with an ASM later, after 6 months, CSM, then how do you go ahead with it? How do you understand?
Patient first comes. अरे थोडंसं जरा कमी मला I am not able to understand. जरा हळू बोल ना जरा. So the first thing, patient rushes to you because there is a fullness. Patient suffers with the AOM or whatever it is. Hearing loss is there, but first the complaint is fullness in the ear. Okay. And many of the time I have seen even this perforates, but where the perforation happens at the edges.
At the edges, yes.
But now, and now with the slice cartilage, even it's avoids the reperforation, and you can see what is happening in the middle ear if it's a very thin graft, 0.5 mm. Otherwise, with the temporalis fascia, the perforation is there completely. Patient visits with the perforation. Yes, that's for the notch for the malleus. But you have to craft your graft beautifully, then that good results are there. But definitely, I am against the full thickness graft. The whole world literature at present is telling about the full thickness graft. Okay. That definitely gives a problem. Because even I was doing the full thickness graft previously. Still, my patients are doing well. Few patients complained for the tinnitus and fullness. Clean. We will finish the grafting and we'll hand over.
Mubarak sir. Hello.
Yes.
Sir, there are certain questions regarding the thickness of the cartilage. So, how had been the study of the laser vibrometry which were done regarding the thickness of the cartilage regarding to the hearing gains postoperatively?
Yes, very good questions, and that is our next plan to do it in the middle area. But Attenbrink in his lab, he's done the laser vibrometry by taking the 1 mm thickness cartilage, 1.1, then 0.8, 0.7, 0.6, 0.5, and the best thickness was 0.5% for the perfect audiological outcome equivalent to that of temporalis fascia. That's why 0.5 to 0.6, this is a good thickness for the good audiological outcome. Otherwise, reperforation is not there with the cartilage at all. But audiologically,
One more point regarding the laser vibrometry study, which was done by Huttenbrink. They came to a conclusion that whenever the sliced cartilage or thickness of the cartilage is reduced to 0.5 or lesser, the results are similar to that of the tympanic membrane or of the T fascia, which is comparable to any size which is 0.1 thickness. So irrespective whether your cartilage is 0.5, 0.1, 0.3, the results are comparable and that does not interfere with the sound conduction. This was the study results of Professor Huttenbrink. I think this was the question which was asked.
हाँ बताइए बताइए मैं मीटिंग में हूँ बताओ बाहर हूँ मैं मंडे को आऊंगा मंडे को बात करें आराम से मंडे आऊंगा
Look at this cartilage, so thin.
मैं अभी मीटिंग में हूँ बाहर हूँ यूरोप आया हूँ
But you have to take out the perichondrium.
You should not say ना पहले गांव चला के समझेगा नहीं कहाँ गया गंडू कभी कहीं यूरोप बोले तो अंदर मरीज को लगेगा कि बड़ी जगह गया हुआ है And sir, another point is regarding the thickness and the fitment of the cartilage because it should not be onto the bone all around.
Yes, that's what I told you. That crafting is very important. Look at
Yes,
this.
sir. Yes, sir.
Vibrate this. That's a good point. So if it is touching to the bony ESC, then there is a little bit of hearing loss.
Yes, sir.
Ball point or someone, ball point. And it's very easy to adjust. The cartilage is very easy to adjust. And look at this. Okay, if it's the perfect size, and if you take that small time to craft your graft.
99 revisions.
So the perichondrium is here.
Tyagi is the biggest version. Then I met a person whose चूते के मुझे 3 days देखे 5 perforation. वो दोनों
this.
The biggest world.
Hello.
Yes, sir.
Hello.
Yes, sir. Yes, sir. Can you hear you?
Yes, we can hear you. We're talking something.
So some Abgel and now my PRF.
What is PRF, boss?
PRF is platelet-rich fibrin. Yesterday I discussed it too
Right.
in detail. Yeah, so in the next case, I think our Rafiq will show how to prepare that. That's a area I think will change lot many things. We are doing some studies on that. Let's see, but there is no harm. Ethically, there is no issue because it's a patient's own blood. You are preparing those sheets. Look at this skin. Skin is having a very nice function of migration. So whenever there is a ear discharge and all, this is diseased one. So you need to rejuvenate. This rejuvenation I learned from my derma friends because they do this facial rejuvenation. So they do what they do, dermabrasion and put lot of PRP over the face. तो अपना कान का स्किन तो उससे ज्यादा प्रेशियस है. So I think that's just philosophical statement. So why not to rejuvenate the skin? Because all the problems in the ear are related to this. And we are working on the theory of the cholesteatoma related to the skin, because it is a skin problem and there has to be some changes molecular level and in that basal lamina something happening. So we have to find it out. We are just working on that. Let some SEOCON, these things will come out. Give me the PR. So we need to rejuvenate the skin. Okay, this is a very functioning skin. If there are so many dermatological problems all across the skin, so this skin must have also got a lot many problems, and we must be missing. Again, a philosophical statement, need a study. देता का चला तितकड़ पेश केस केस. Any question?
Sir, any question from the house?
Any question, friends?
Sir, they all are enjoying. They're watching your surgery. They're mesmerized. No questions yet.
Oh, thank you so much.
Very well.
See, from this SEOCON, take this PRF as a new thing. Try in all our tough situations. You will see wonderful results. Although we don't have publications to this. Suction. Use very small suction. This idea came with Wurzburg's silicone sheets. I used to use that previously.
What is this, boss?
PRF.
How do you make it? People want to know.
Simple. Withdraw the 20 ml of blood, transfer it to the tubes, which is not having the anticoagulant. If you use the anticoagulant, it will not coagulate. We need a partial coagulation.
Can you have it?
And put it in the centrifuge, rotate it at the 3000 speed for 15 minutes. You have to immediately transfer those tubes because centrifuge is there in my OR. If you take a time more than 5 minutes, means more than bleeding time and clotting time, already the clot is formed there and you will not get this. So you have to immediately transfer. That's a crux here, that within the 2 minutes, you have to transfer it to the
Answer, Sapna here.
centrifuge.
Hello.
Yeah. Please.
So you have 2
elaborate
minutes.
little bit there.
Yes, sir. We'll give you 2 to 3 minutes more, then we'll shift to the other OT for stapes.
Absolutely. I have finished. Please shift it. Okay, no problem. Okay.
Okay. So meanwhile, I'll just brief the audience about how we do the PRF sheets. What we do is for a simple tympanoplasty, type 1 tympanoplasty, we take 20 cc of the venous blood in a glass tube, sterile glass tube, which is autoclaved. And the importance of the tube is that it's not with the anticoagulant, it's without any anticoagulant. So this is subjected by sterile technique into the centrifuge machine, in which we keep it at 3500 RPM for 10 minutes. So once the 10 minutes is done, you get a jelly-like substance in the tube. So basically it has 3 parts. That is, at times, it depends on the platelet count of the patient rather. The PRP, that is platelet-rich plasma, which you receive about 2 to 3 cc's. Then you get a middle portion, which is a thick jelly-like substance. That's the PRF. There's a platelet-rich fibrin. And the lower part is the RBCs, which are concentrated. So once this is being done, this is taken in the tube and taken to the nursing staff, who takes it up, who pulls it up with the help of a sterile forceps. And first, before taking that, the PRP, that's a plasma, it's aspirated with a sterile 2 cc syringe so that you can use it for other purposes in case if it's needed. Secondly, the PRF, that's a fibrin, is separated from the RBCs, which are there concentrated below with the help of a forceps. Then this is placed onto the ASM grid. ASM grid is the grid which we have designed, which is a measurement grid. We place onto it, and with the help of a sterile Microseal, that's a we press the jelly. So it's like a jelly what you have, and you press with the help of a Microseal and make the jelly into thin sheets. And then as it is placed onto the ASM grid, which is itself a marking system. So we make this into multiple sheets with the help of a 15 number surgical blade. We make it into multiple strips of about 5 mm breadth into 10 mm length. So these are used like similar to your elastic sheet, what you use for the tympanoplasties. So here we use it over here. What you can see, it has been used after the flap has been reposited. So advantages I would highlight over here is at times what happens here, tympanic membrane graft which you place, it may not be very much in contact with the TM flap and not in contact with the graft. So with the help of the suction, the anterior part of the flap is placed onto the graft. And if you place the PRF sheet over it, as it has been done, in this case, like your elastic sheet, it will help in the epithelialization and reduce the occurrence of recurrent perforations. And plus another hypothesis on our side, which we have read in the literature, is if you use this PRF or PRP, the release of the growth factors takes between 30 minutes to 300 minutes. So in specifically in cases of MRM, whenever you're preparing it, it should be freshly prepared, because once you place it over there, the release of the growth factors takes place between that time. So if you take it too much early, it wouldn't facilitate the release of the growth factors. And basically these PRF sheets, they get absorbed within about 5 or 7 days. So what has been read in the literature and what we are doing, we are basically trying to do a study and see whether it really is if there is quantification of any growth factors if they are released from these PRF sheets. So that would be our next study, because what we are hypothesizing, if it is true, then it's really going to be good, because when it releases the growth factors or the stem cells, basically it will make the tissue original to that site where it's been placed. Because we all know that in dermat and all other fields, PRP, that's platelet-rich plasma, has been extensively used, exploited. So that gives the tissue, when it's being placed into the, injected into the skin, it rejuvenates the skin. It gives the collagen where it is present for the hair transplant. So why not in otology? There has been a lot of studies done for TM reconstruction, obviously in traumatic perforations in T-plasty, but we are doing little bit in terms of MRM also. Yesterday you must have seen. So we place it over the ossicular erosions, micro erosions, over the promontory, over the carotid, which was eroded in 2-3 MRM case, mestoid cases. So definitely these patients are doing well. So it's a clinical study, but we want to really supplement it with solid evidence that is going to work well. I think it's.
Yes, thank you very much, dear audience.
Thank you.
I think, you can shift it to Satish. Some motor section. त्याची दुसरी केस इथे इंड्यूस करायची का बघा.
I think we should shift to the other OT.
Yes,
Dr.
please, please.
Anvita,
Then सांग त्यांना.
Dr. Shinde, sir. Is the OT ready on the other side?
Outside, it will come.
Hello?
So,
The students, PG students can just brief about the history of the other patient and give a PPT.
you can. ना इधर नहीं ठीक है ना, वो तो तब तक वो अगले पेशेंट का डिटेलिंग करने के लिए बोलो पीजी को. हाँ चलो.
Good morning, everyone. Satish.
Hello, yes, please speak. Hello.
Good morning, everyone. Satish
Yeah.
sir is going to start left stepidotomy, giving you the brief history of patient. Patient is having bilateral decreased hearing since 4 years, bilateral tinnitus since 4 years. On examination, bilateral tympanic membrane is normal. On tuning fork test, 512 is negative on left side, bilateral 512 is negative, and Weber's lateralized to left side. On audiogram, we could see bilateral moderate to moderately severe conductive hearing loss. On impedance audiometry, left sided there is AS curve and right there is B curve. HRCT seems normal. The plan is left stepidotomy.
Age of the patient?
30-year-old female.
Okay.
Hello.
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 Yes, sir. Yes, sir.
Good morning, sir ji.
Good morning. Hello. ये वॉल्यूम इधर का लाओ ना इधर.
Actually, the time.
Hello.
Precisely 12 o'clock and 2 minutes. Good afternoon.
Good afternoon. Hello. Am I audible there?
Very much. आपकी आवाज आए तो और सबकी बंद हो जाती है.
So you have known from the history the patient with a bilateral intact tympanic membrane having bilateral conductive hearing loss, 30-year-old female, conductive hearing loss confirmed on tuning fork testing, straightforward case for exploration. And we expect in such cases, most likely a diagnosis of otosclerosis, what we generally expect. So, the thing is, patient having bilateral conductive hearing loss, care for exploration, expecting otosclerosis. So, we have to explore the middle ear, and then what we believe is a need of a CT scan to give us more information rather than cutting a sorry figure or surprises
this surgery, if it turns out to be otosclerosis, is one of the most rewarding surgeries. We call it the all or none surgeries, where most of the time, if carried out diligently with the correct diagnosis, is something which give amazing results. At the same time, has a associated danger of giving hearing loss, further hearing loss, even profound hearing loss or dead ear as well. So CT scan is something which gives us more information. There's always a debate whether it is mandatory or not. There is no question whether it is mandatory or not. The question is what additional information which we can get, which can help our surgical course, which can prevent surprises, which can strengthen our diagnosis or rule out a misdiagnosis. So all this information is given best by a CT scan, a high resolution CT scan. And what you see here is a axial CT scan on the left down corner here, 0.6 mm sections. Means every point of time we are going to move by, with every movement we are going to move by 0.6 millimeters. This information can be gained better if we have a cone beam CT scan. Cone beam CT scan is a new revolution, which is basically, developed for the dental surgeons for implantation, but gives a better information as far as otosclerosis surgery is concerned, because it gives you even 0.05 mm sections as well. We have many times done cone beam CT scan. With that, you can even measure the thickness of the foot plate, which is a very, very useful thing once you think of doing otosclerotic surgery. So this is gaining additional information. So like yesterday, we went through the CT scan from cochlear implant perspective. We touched upon only those issues which have an impact on the cochlear implant surgery, which can give you something like preempt you with a difficulty one can encounter during surgery by means of giving preoperative anatomical details, any anatomical abnormality which can make your surgical course difficult. Similarly here, today we'll touch upon only those issues which are relevant to otosclerotic surgery, which are relevant to diagnosis, ruling out misdiagnosis, or something or some abnormality which can have a significant impact on the surgical outcome. So what all need to be seen on a CT scan from otosclerotic perspective? Number one, see, we are going from top to bottom again on axial sections. The first structure, what we see is what is this? Superior semicircular canal. Superior semicircular canal fistulas, though not very common, but not uncommon as well. You have encountered a couple of such cases, and that has a significant impact on the diagnosis of otosclerosis. Sometimes that semicircular canal fistula can mislead you to a diagnosis of otosclerosis, which actually is a different abnormality. So how can you best judge this superior semicircular canal fistula? Many times such fistulas, even fistulas which are existing, are asymptomatic. Many times they do not give either auditory or vestibular symptoms. Sometimes they give selective auditory or selective vestibular system. That depends upon the location of the fistula. So if we look at the coronal section, see here, this is vestibule, this is lateral canal, this is superior canal. And if we follow this superior canal, this is covered by the thick bone all the way. See this? On either side, that rules out completely the possibility of a superior canal fistula. But if fistula is existing, how can it confuse with the diagnosis of otosclerosis? Fistulas, we have in the inner ear 2 windows God has given us for the baffle effect. The one window, the foot plate goes in with the sound which comes preferentially through the ossicular chain. And that sound once comes to the whole window, it pushes the whole window in, which leads to vibration of the inner ear fluid. And the other window, the round window, comes out. So that baffle effect is very important for generation of action potential. And that's a closed space with only 2 windows. If there is another third window, what can happen?
it can lead to leakage of sound and can lead to a sort of conductive hearing loss. Inner ear conductive hearing loss. This third window could be anywhere in the labyrinth, could be even the dehiscent carotid canal leading to a third window which can dissipate the sound, anywhere fistula in the cochlea or labyrinth anywhere, or this commonly the superior semicircular canal fistula. There are cases reported asymptomatic third window giving you a perception of a conductive hearing loss on low frequency conductive hearing loss. Patient operated for otosclerotic surgery and become symptomatic. Earlier was a third window which was asymptomatic, and now you made it symptomatic after opening another window in the foot plate. So we have to be very cautious in terms of ruling out such misdiagnosis. You have to be careful at reading out the audiogram. This semicircular canal fistula gives particularly a low frequency hearing loss, low frequency mild to moderate conductive hearing loss. Even in the history, if it is symptomatic, you can make out by means of a diagnosis of vertigo, by means of oversensitive to the bone conduction sound. That is very, very important. It makes the bone conduction oversensitive, and even if you put a tuning fork anywhere on the body, the patient can easily appreciate. Even on the audiogram, you will find the bone conduction reading in minus, oversensitive bone conduction reading, and that can make the clinician suspicious of this kind of an abnormality. So we have to be, once you look at the CT scan from the otosclerosis perspective, we must look at the superior semicircular canal and rule out the superior semicircular canal fistula. So that was one important thing to be seen on CT scan to begin with. Now, that was superior canal. Going down, again, you have to look at all those things which can result into abnormal, or which gives you a suspicion of abnormal communication of the CSF space with the inner ear space, which can lead to a gusher. So, like yesterday we saw, we need to look at the dimension of the intra-auditory canal. If it is over-dilated, can give you a suspicion. Say this cochlear aperture modulus, it is intact. If it is deficient, cochlear aperture widened, can give you a suspicion of a gusher. Then the vestibule, if it is dilated, can lead to a gusher or a oozer. Then vestibular aqueduct. You saw in this section yesterday vestibular aqueduct. See where the vestibular aqueduct is. This is vestibule from where this thin, very thin aqueduct going, J-shaped aqueduct and opening as a sac at the posterior petrous ridge. This is endolymphatic duct system. If it is dilated, you have to be suspicious about it. It can, if not gusher, can lead to oozer. And here, this is looking absolutely normal. How can you suspect a dilatation of the endolymphatic sac? At this diameter, at the largest diameter, if it is more than 2.5 millimeter, you can be suspicious of this. Or in the anywhere in the diameter, if it is abnormally dilated, then the opposite side, you have to be suspicious about it. So this is another thing which we need to keep an eye on it. Then the facial nerve. This is very important. Many times in otosclerosis surgery, a facial overhang can make your life difficult. And the CT scan gives you a complete insight about the course of the facial nerve, or if any possibility of an dehiscent and overhanging facial nerve. See this. Follow the facial nerve from here, intra-auditory meatus, the facial nerve labyrinthine segment. This is the first genu. This is the first genu. This is the GSPN going anteriorly and the facial nerve going behind. That's the facial nerve horizontal course. Look at the entire horizontal course, which looks intact, covered by the bone. It is nowhere looking dilated or dehiscent. See, overhanging facial nerve has to be dehiscent. It cannot overhang with a canal, bony canal intact. It has to be dehiscent to become overhanging. So here, an intact canal rules out the possibility of being dehiscent. Then this facial nerve goes here. This is the second genu covered by the bone all the way.
to see the relationship of the facial nerve to the foot plate, we need to look at an upside down picture, that is coronal one. See in the coronal picture. That's the vestibule, that's the superior canal, that's the lateral canal, and in the anteromedial lap of the lateral canal is the facial nerve. Can you see the facial nerve?
Yes, sir.
Hello, auditorium?
Yes, sir. Yes,
The
sir.
picture going?
Yes, sir.
This is facial nerve. Now look at the ossicular chain. The malleus, incus, the stapedial crust, and this is the foot plate, and this is the facial nerve. Level of the foot plate, which is below the level of the facial nerve. Had this been an overhanging facial nerve, this facial nerve would have been situated over here, down right over the foot plate. So you can see the relationship with the foot plate and the facial nerve above. It could be little bit seen projecting on the CT scan, but it is not overhanging at all. See, the foot plate area is wide open with the crust going inside towards the foot plate, and the facial nerve level is above the upper level of the foot plate. Can you make out very clear?
Yes, sir.
Hello?
Sir, yes, sir.
Yes,
Can
sir.
you make out?
Yes, sir.
So see the foot plate and the level of the facial nerve, which is above the level of the upper border of the foot plate. You can see with little bit prominence you can see, but not overhanging. So this is the best view, and we must look at the CT scan in all sections to rule out this facial nerve prolapse or overhang. Otherwise, if you don't have a CT scan and find such kind of prolapse and overhang, either you need to abandon or counsel your patient, or if you are not aware of, not experienced, can even give rise to a facial nerve damage. So we have to be careful in assessing, and this way you can surely prevent, cutting a sorry figure to the patient. Now, this is facial nerve. Now, other things to be seen from cochlear implant perspective. See the ossicular chain. We have seen in our practice, see this is the malleus, this is the incus, this is the atic, this is anterior atic. Many a time anterior malleolar ligament become ossified and leads to fixation of the malleus anterior to the anterior atic wall. And this is can be very well ruled out by, this axial section with the malleus. See, the malleus is away from the anterior atic wall. There is no bony fixation of the anterior, malleus to the anterior atic wall. So no anterior malleolar ligament ossification. Similarly, the malleus can be fixed, the head can be fixed in the roof of the atic by means of ossified superior malleolar ligament, which can give rise to the same conductive hearing loss. Look at the malleus and see superiorly the wall of the atic, and there is no fixation of the malleus, bony fixation in the superior wall of the atic. In our practice, we have done almost 8 cases of pure conductive loss, suspecting otosclerosis, and no CT scan, and found this malleus fixation in the atic. And after CT scan, the 4 cases we diagnose and accordingly prepare to deal with that. So this is such an important finding. Though the incidences are not very common, but still every patient is important. And a CT scan can obviously rule out all these positive findings which you can see. Then see the ossicular chain, then the continuity of the ossicular chain, and how the ossicular chain is, look at the ossicular chain as a whole. See the malleus, incus, incudomalleal joint. This is incudomalleal joint. Incus, long process. This is long process of the incus. This is incudostapedial joint. And this is the stapedial crust going into it. So entire ossicular chain as a whole can be displayed on CT scan well. At the same time, as far as the diagnosis of the otosclerosis is concerned, this is almost always clinical. As I mentioned in the beginning, with the patient having intact drum,
conductive hearing loss confirmed on tuning fork, one should suspect otosclerosis until proved otherwise, being such a common entity. But there are certain times when there is gross otosclerosis involving the OT capsule, you can make out on CT scan as well. Normally what you find, see this density at the anterior edge of the foot plate, fistula antefenestrum. This is the site of the origin of otosclerosis, and you find this demineralization of the bone. See the bone of the aortic capsule so thick, and this is demineralization of the bone at the anterior edge of the foot plate, which is classically suggestive of otosclerosis. On the CT scan, you should rule out any extensive otosclerosis if ongoing there. Means if the otosclerosis involving the round window is a straightforward contraindication, what we believe. See this round window region, it is free of otosclerotic foci. Any otosclerosis involving the inner ear, gross destruction of the inner ear, you have to be careful in terms of prognostication. Though whatever conductive hearing loss, sensory neural hearing loss, mixed loss, even profound loss, profound otosclerosis involving the inner ear, the first treatment is stupidotomy, followed by the hearing aid. If it doesn't work, then you can think of cochlear implantation. And once you think of cochlear implantation, how much cochlea is destroyed, how much cochlea is demineralized is a very important finding on CT scan. Too much of demineralization of the cochlea. When the cochlea is destroyed too much, it is difficult to even carry out a cochlear implant because it is difficult to find a lumen. Everywhere you try to drill, you will find a lumen looking like a cochlear lumen, which may not actually be a cochlear lumen, but a destroyed bone lumen. So it is always difficult. So in those cases, a CT scan can really be very, very effective in terms of carrying out a cochlear implant safely. So these are important things. The jugular bulb we discussed yesterday, if it is too high. Here, see, yesterday you saw the jugular bulb when the round window was in picture. See, the round window is there is no jugular bulb behind. Now I am going down, even the entire cochlea is disappearing, no jugular bulb. Now the jugular bulb has started appearing when the cochlea has gone in picture. So you are too inferior below the level of the cochlea in the axial section when the jugular bulb has started appearing. So this is never a high jugular bulb. So all these are, the basic things which are to be seen on CT scan and are relevant to cochlear implantation. There is another entity, gross otosclerotic involvement of the foot plate, obliterative otosclerosis. If you know beforehand on the basis of CT scan, accordingly you can, counsel your patient. A grossly, involved foot plate by means of obliterative otosclerosis requires too much of efforts by means of drilling. It requires a very, very diligent drilling over the foot plate to prevent sudden movement and sensory hearing loss. And the results we all know, by and large, except in very, very experienced hands, the results are always inferior to the regular blue foot plate otosclerotic results. And in those situations, you can pick up the otosclerotic involvement here. Like here, the fistula antefenestrum is here demineralized. Had this been obliterated, this entire foot plate area would have been involved. And you can preempt that diagnosis on CT scan and accordingly counsel your patient. This thickness of the foot plate, see, this is a HRCT, high resolution CT scan. You cannot measure the thickness of the foot plate precisely. Had this been a cone beam CT, we can measure in fraction of millimeter. Normal thickness of the foot plate, once you contemplate otosclerosis surgery, if it is more than 0.3 millimeter, you can assume an obliterative otosclerosis, and then accordingly you have to be prepared. And this foot plate thickness can be measured in 0.05, 0.1 mm, dimension, millimeter thickness dimension on cone beam CT scan. And that is so useful in this surgery, in this particular surgery. So this is how you can look at the CT scan from otosclerotic perspective. Any questions? So there is a question, any finding on CT scan where you are biased to choose laser preferentially? See, laser has a useful role at only 2 steps in otosclerotic surgery, where a sudden movement can lead to a sensory hearing loss, disaster. One is at the time of carotid. If the foot plate is not adequately fixed, and if you try to do a carotid, either you can break the foot plate, you can bring the foot plate out, you can give a floater, whatsoever, you can even lead to a submerged foot plate. At the same time, during fenestration as well. But that happens only when the foot plate is not adequately fixed and your movement is not very, very diligent, not very precise. At these movements, laser being untouched technique, you can vaporize the foot plate, you can vaporize the foot plate crust, and you can avoid all these complications to almost certainty. I've been using laser for more than 15 years, the luminous laser, with the disadvantage of vaporizing the foot plate crura and vaporizing or making the fenestra with the laser without touching it so that you do not mobilize. There is no finding on CT scan which makes you bias particularly about using the laser in that situation. One finding that makes me, avoid using the laser is a prolapse facial nerve. When there is a prolapse facial nerve, we tend to avoid using laser because the heat of the laser in the vicinity can lead to facial nerve damage. So in one situation, I would say whether we refrain from using laser is the facial nerve prolapse. Any other question? Satish sir, would you talk about Malafronte classification? Pardon? Malafronte classification of stapes. Hello? Hello? Hello, Satish sir, can you talk about the Malafronte classification of stapes? Malafronte classification.
Yes, sir.
Oh, that's a very amazing, views proposed by Malafronte.
Yes, sir.
He was Italian ENT surgeon, and what he proposed a very, very clinical classification about the, appearance of the foot plate. So he categorized the foot plate into 3 categories. Number 1, the blue foot plate. Blue foot plate is ideal foot plate for the otosclerotic surgery, wherein the otosclerotic foci has not involved the foot plate per se, but has involved and anchored the foot plate, had involved the annular ligament and anchored the foot plate more strongly to the oval window margins. But the foot plate per se, the foot plate bone is not involved. Foot plate bone is as strong as normal, not a brittle bone like otosclerotic bone. But the foot plate is in those situations is adequately fixed to the oval window margins. So that is ideal foot plate for otosclerotic surgery. Ideal in terms of avoiding complication, where the foot plate mobilization of foot plate chances are minimal. So what he would do, such blue foot plate cases, he would always give to his residents, considering that that particular foot plate is unlikely to be easily mobilized, is likely to be adequately fixed to the oval window margins, and the chances of complications are less. Then the second category of foot plate is a partially or completely opaque or white foot plate. That foot plate means the otosclerotic bone, otosclerotic foci has spread and involved the foot plate bone per se. And that makes the foot plate very, very brittle. And in those situations, the otosclerosis doesn't adequately involve the annular ligament and fix the foot plate to the margin, but it spreads over the foot plate bone. And that's a dangerous foot plate he calls. Means the annular ligament is not adequately fixed to the margin. Foot plate bone is very brittle. If you try to make perforation, the foot plate is likely to be fractured easily. And foot plate is likely to be, become floater easily, likely to be submerged because it is not adequately fixed. And that is something he would never give it to residents. He would do other maneuvers to prevent that. He would do himself that time. He would suggest a reverse
a stepidotomy like Hugo Fish proposed, in which you keep the entire incudostapedial arch intact to prevent subluxation and make the fenestra first and then put a piston and then disarticulate the stapes. So he would do something else and do himself, considering that a risky foot plate, and being extra prepared with that, he would do himself. Third variety is a complete obliteration. No foot plate visualized and only the otosclerotic foci involving or filling the entire whole window and even the surroundings. That is the most difficult of the foot plate, that he would rather himself even not operate, or rather than giving anybody, he himself would not operate. Or nowadays we have been doing using a lot of drilling. I had seen in the last conference, I don't remember where it was, not in Jaipur, maybe in Mumbai, Dr. Ashim Bhumkar demonstrated one case with a...
Yeah. He pulled out the whole obliterative foci, made it blue, then he put the...
He drilled very gently, very diligently the entire otosclerotic foci. It took time and recovered a blue foot plate underneath. And then use your regular method to make a fenestra and do that. So, but that requires a lot of experience and, diligence, which only experienced people can do. So that is one foot plate, third category. He would rather not to operate or do with due exercise, due care and all that. So that was my Elefante proposed. So blue foot plate is a welcome sign, as simple as that.
Two questions.
Any other?
One is about the
Thank you, sir. Thank you.
persistent stapedial artery location, visualization on CT. And second is about the can we differentiate on CT scan between the congenital stapes fixation and otosclerosis?
Yes. So these are very important questions. Number one, coming to the persistent stapedial artery. What is persistent stapedial artery? Stapedial artery is a normal anatomy in fetus. But by the 6 to 10 weeks of embryo life, it disappears and the middle meningeal artery forms.
Satish, sir.
If this artery, pardon?
We have Morwani sir here. So he will be doing the talking now.
Welcome, sir.
Welcome, Dr. Morwani, sir.
So, if persistent stapedial artery, if that stapedial artery doesn't, the resolution doesn't happen, it doesn't absorb and lead to a middle meningeal artery, it remains there in life. And this stapedial artery in embryo, before 6 to 10 weeks of life, it comes from the carotid artery, traverses through the tympanic cavity, passes the stapedial crura, in between the stapedial crura, and then enters the facial canal, the horizontal facial canal, then continues to the first genu, and then goes intracranial and supply certain intracranial structures. That is what it is supposed to do. But it absorbs by the latest by the 10th week, and that function is taken over by middle meningeal artery, which goes intracranial and supplies certain areas. Now, if this artery persists, to us in the otosclerotic surgery, it gives problem because it passes through the stapedial crura. It is lying in the same field, and there is always a fear of giving hemorrhage if you happen to injure that vessel. That's artery, not a vein or not a capillary. So, what can you do? First of all, the diagnosis. So how can you diagnose? The artery cannot be picked up on CT scan. That's a very fine artery vessel. The CT cannot pick up such a small soft tissue. So how can you pick up? Number one, look at the foramen spinosum through with the meningeal artery traverse. If there is foramen spinosum, that means there is meningeal artery. There is no persistent stapedial artery. That means it has already absorbed and the middle meningeal artery is already there. That means there is no persistent stapedial artery. Look at this. Look at this. This is the pterygoid process. Behind the pterygoid process is foramen ovale. And behind the foramen ovale is foramen spinosum. leading to the middle pharyngeal artery. If foramen spinosum is intact, means there is no persistent stapedial artery indirectly. Number two, if there is persistent stapedial artery, it would pass through the horizontal facial nerve from here, from the passing to the stapedial crura, it would enter into the facial canal to co-intracranial. Had there been persistent stapedial artery, this facial canal would have been widened, dilated, more than double the size, and then you can be suspicious of something fishy. There could be a stapedial artery passing through it. With a normal, I mentioned in the beginning during CT scan, the normal dimension, not dehiscent anywhere, of the horizontal semicircular canal, this horizontal facial now rules out the possibility of any vessel entering through it. So these are two things on CT scan which rules out the possibility of a persistent stapedial artery. Your second question about the congenital otosclerotic focus or a congenital stapedial fixation or otosclerotic fixation. You know, during the development of the foot plate, how the foot plate develops? Foot plate develops from both sides. The endosteum develops from the inner ear side, and the arch develops from the middle ear side from the second arch. From the second branchial arch, the foot plate, crura develops, and the foot plate endosteum develops from the inner ear endosteum. And they fuse together to form the foot plate. This is during the 6th week of embryo. At the same time, the facial nerve develops. So if there is an abnormality, a congenital stapedial abnormality, there would always be associated facial nerve abnormality. Either facial nerve passing over the foot plate, preventing the crura to join the foot plate, or facial nerve prolapsing down, or anything related to the facial nerve. A sole congenital foot plate abnormality is extremely rare without a facial nerve abnormality. Looking at the normal facial canal all the way on CT scan, in the coronal section, I had shown you no prolapse. In the axial section, everywhere, it rules out a congenital stapedial fixation. Got my point?
Yes, sir.
Another Satish. If there's a
Yes, sir.
congenitality on one side of facial nerve, similar will be there on opposite side also.
Yeah, most of the time.
Symmetrical.
Yes. Symmetrical. Most of the time it is symmetrical. Yes, sir. That's important point. Any other thing to be discussed on CT scan, or do we get on to the case?
Please take up the case.
Get on,
Okay,
get on
and
the surgery.
so still we can continue our discussion. Feel free to interrupt me for anything. So this is left side we are going to operate.
The most important. And CT scan is all, and what he said, every case of CT congenital stapes will abnormality CT scan of a facial
Canal
nerve.
कैसी?
Had done many.
स्पेक्ट्रम साइज का लगा और सेक्शन का वॉश कर बिल्कुल
I
ट्रॉमा नहीं
done
करना
also. He is
सही
right.
साइज का फुट ये लगा
Let me get
टेल्ट
it.
कर तेरी तरफ ये कुर्सी लगा सब सेट कर दे पूरा वॉश कर दे
Yes. Bony mass. Can't make out crura, can't-
Dr. Satish, I'm RN Patil speaking. Hello.
Anomaly.
Hello.
And you can have-
Dr. Satish, I'm RN Patil speaking.
Hello.
Any way
Yes,
of
sir.
deciding about gusher on CT?
Yes, we discussed sir yesterday as well. I mentioned today also. Anywhere, if there is a defect or anomaly, pointing towards abnormal connection of the subarachnoid space to the inner ear, can lead to a gusher. That is suspicion of a gusher. Like I mentioned, any dilated interauditory meatus,
Okay.
broad dilated bulbous interauditory meatus, any dilated cochlear aperture,
Okay.
absent modulus,
Okay.
all or dilated endolymphatic duct, all these are signs which could point out to be towards a gusher. A dilated cochlear aqueduct per se has never given rise to gusher. It has been assumed that a dilated cochlear aqueduct can give rise to gusher, but not a single case has been reported in the literature so far.
Okay, sir.
Cochlear aqueduct, most of the time, even if it is dilated, is full of the fibrofatty mesh, fibrous mesh inside, and it doesn't give rise to excursion of the, CSF pressure directly to the inner ear.
Satish, your audibility is down. Hello. You're not able to hear.
It can be a conduit. This dilated cochlear aqueduct, what I was telling, it is filled with a fibrous mesh. It cannot give rise to the pressure excursion of the CSF fluid to the inner ear. It doesn't give rise to because of the fibrous mesh filled in. Yes, it can be a source of, or it can be a conduit to spread, for the spread of infection from the subarachnoid space to the inner ear, but not the pressure transfer to the level that it can give rise to a gusher.
Okay. Thank you.
Everybody is envious of residents.
See? बनाओ है? दिखाओ। लोकल किसने लगाया?
चालली का?
सर आपका नंबर दीजिए,
Yeah.
मैं आपको पेमेंट भेजता हूँ, वो आपका नेट से निकाल के देता हूँ, होता नहीं है काम। मणिपाल में कितना मणिपाल?
हाँ, 98200
98200 47256 एक बार सम्राट से लिया था, फिर आई लॉस्ट इट।
You're there on that Venta thing, yeah?
हाँ उसमें है, उसमें है, लेकिन ये डायरेक्ट होता तो अच्छा रहेगा। आई जस्ट गिव अ कॉल एंड मेरा नाम ध्रुव है।
I know, yeah.
तो वहाँ पेशेंट भेजते हैं, वो कहाँ पहुँच जाता है, पहुँचता है। वी डोंट डू इट, यू नो इट, वी डोंट डू इट।
Yeah.
यू आर द एक्सपर्ट। क्या नहीं मालूम है।
नहीं सर।
This is your number, no? It's right now.
9847256, yes.
कोई गड़बड़ होगा?
It's not going.
Connection नहीं होगा?
अभी जा नहीं रहा है, calling.
Please try later.
अच्छा, क्यों ऐसा हो रहा है? आपका दो सर?
983121 214266. Connectivity problem
हाँ
होता है कभी कभी। Right. ठीक है, मैं देता हूँ। You take the phones, ना इतने patient को।
Of course, yeah.
ना सर होता है ना secretary वगैरह।
नहीं।
चलिए तब ठीक। Thank you.
ग्लेयर तो बनती है यार. Hello.
Yeah, Satish. Yeah.
Yes, Ashish.
Yeah, Satish. We are with you.
Hello.
Yeah, Satish.
Ashish, I forgot to know where did you demonstrate the obliterative otosclerosis case? I forgot that in one of the
I think
workshop.
it is in Bombay, kya? Cooper. Yes, Surat, yeah, Nagpur.
Oh yes, Cooper Hospital.
Ah.
Probably Nagpur or Cooper. Yes.
Yeah.
That was a treat to watch how to drill over the foot plate, and you ultimately discovered the blue foot plate underneath.
Yeah.
So that obliterative foot plate management is a something challenging thing in otosclerosis surgery. Now, are you getting the picture?
Yes, very nice. Very nice. Yeah.
Okay. Now somebody had given the local and you can see the flaps.
Oh, it's okay.
Yeah.
It's okay.
This is something due to infiltration. We have to be careful not to infiltrate just underneath the epithelium. Anyway, we can overcome this.
Yeah.
So, as far as the incision is concerned, our technique is going to be transcanal most of the time, rarely in the narrow, lateral bony canal many a times, or sometimes we use the mini endoral like what Ashim Desai does. But most of the time, it is transcanal. So my incision again is a tailor-made incision. See, this is the level of the annulus.
Yeah.
Incision is roughly 5 to 6 millimeter lateral and a horizontal one. Simple horizontal one. See, this canal skin is not of same, texture at everywhere. Superiorly, it is quite thicker.
Yeah.
See this? And inferiorly, it is like a single layer of epithelium. So you have to be careful not to go in one go, but quickly, slowly, you can go bone deep. So as to avoid the tears. See now, I am bang on the bone.
Yeah.
This is simple horizontal incision. Now I am bone deep. And this is a curvilinear horizontal incision, I would say. As I am going anteriorly, I am going little medially. Section. People make this incision differently. Doesn't matter as long as they are used to.
The exposure.
Ashish, are you fine with this incision?
Yeah, absolutely. Yeah.
See, it is the exposure.
Satish, just a
The
minute.
final exposure, how you achieve is important.
Everybody, my teacher, doctor, I come with three people. My teacher, my first registrar, and my first houseman.
Welcome, ma'am. Welcome. Dr. Pilu Hakim, the lady, ENT. Most welcome. Yeah.
The amount of desire she has to learn today. You know what conference she's attends? Because she's Parsi, that is. Headache conference organized by neurologists. Whatever conference organized by physician. The things which, dry from our point of view, she still wants to go and learn. And she comes in my temporal bone dissection workshop to give one talk on basic otology. She travels for 3 hours. She has traveled for 3 hours, 1.5 hours, either way, but she enjoys it. It's a pleasure for her to come and join the work. So give a big hand to my lady.
Great, sir. Welcome, Pilu Hakim, madam.
Welcome, madam.
It was a fantastic.
Always blessed to have madam.
Great fun.
With us. She's always, the powerhouse of knowledge. And her blessings are important for everyone. See now what I have given. I have given a release incision inferiorly.
Inferiorly, yes, that incision is important. typically I tend to take
Just
that.
to avoid tears, because our area of interest is not inferior.
Correct, because the tympanomeatal.
We are not supposed to go far
Fold.
inferiorly.
Correct.
And see, keep raising the flap simultaneously at all levels until you reach the annulus.
Yeah.
Superiorly, I am not giving any release incision, keeping the option open to extend it far anteriorly in case I need to do something. Sometime I may need to do, depending upon the situation, a malleus trapezotomy. I may have to resect the anterior malleolar ligament if it is hyalinized or giving problems. So my anterior extension option is always open.
Open, yeah. So reach the annulus.
Anteriorly, I am not limiting.
Correct.
Look at the level of the annulus. Can you see?
Yes, yes.
Yes, yes.
Never do
Ashish, unfortunately, this microscope, this is the highest magnification in this microscope. I cannot increase more.
Okay. It's okay. We are doing good.
So simply I have entered the middle ear from here, just medial to the annulus. Can you
Annulus,
see?
yeah. Yeah, yeah. We can see now.
Inferiorly. My chorda I have left
Yes.
deeper.
There is a long
I
tunnel.
forgot to
goes
mention
bone-
on CT scan how to assess the overhang.
Oh, yes.
I will go back after the surgery to show you how to
Okay.
assess the overhang, how to predict the overhang before surgery.
Okay.
I forgot to mention. That is very important so that you are ready to or prepared to deal with that overhang.
Or if you are not competent, refer it to Satish Jain. Simple. If you think you can't have overhang, then Satish Jain is to look after it. This is his message actually.
Is
See
there
now the annulus?
situation where Satish, you would like to use endoscope for stapes?
People have described the endoscopic stepidotomy with various advantages, but to me, still to me, is not standard of care, what I believe. For the regions,
In this workshop, you use
Here-
it, make Mubarak Khan happy.
yes, Mubarak can show.
Now,
The problem, what I believe, number one, Mubarak uses the holder to keep the endoscope away. Otherwise, people who are using the endoscope in one hand can really give problem because of the heat it gives inside. Number two, the advantage of the endoscopy, what they quote, is the less and less removal of the overhang, good on-site brilliant view, magnified view they get with the endoscope. Picture is always, transmitted better with the endoscope than microscope, but that is not, binocular image.
And the
What
field
do
is
you believe?
bigger. They said they don't
Yes,
have to remove
so
all
it-
the overhang. Even in mastoid surgery, iticotomy, they don't have to remove overhang because field is much better.
Wide angle endoscope give panoramic view.
Ek minute, na, Satish, I'm just pointing out. Look,
Ashish,
color differentiation, you can actually see the otosclerotic focus. As soon as the flap is elevated, the color between
yes,
the
see, just underneath the malleus.
so this is a
Here it is the focus.
otosclerotic
Can
focus.
anybody what Ashish is saying? Can
Yeah.
you see this whitish focus?
Yeah, I'm pointing out with the laser pointer. So this is we are most likely to have
That
a
is
easy-
the otosclerotic.
This is the anterior fixation.
I have seen Ashish many a time pushing this chorda along with the flap.
Yes, there is always a mucosal band.
To me, it is not always possible. Sometimes it is possible,
Of course,
depending
not
upon the
yeah.
of
But when-
overhang. It is not always possible. What do you say?
Yes, I agreed, Satish. Not always possible. In this case, it would not have been because there's a big canal. For the chorda, there's a very big canal. So
yes,
I think that canal also, I think I
Now
did
this-
Cooper or something. Yeah.
And occasionally, as
Yeah.
you have to drill the canal to mobilize it
Mobilize,
better,
yes.
to avoid the damage
So
and stretching of
unroof-
the nerve.
yes.
Unroof that canal.
You can remove the bone from
That-
lateral side of the chorda and mobilize it.
Yeah.
Now see this overhang. This canal is too overhanging.
Yes.
You can see only the glimpse of the long process of the incus, nothing more than that.
Tiny, yes. Very, very, very little. Yeah.
And there are many ways to remove this. Ashish loves to use the micro mallet and the
Gouge and hammer, yeah.
Micro gouge in the hammer. There are many ways people use. We can use the micro drill. We can use the curate. This is my favorite Karlstorff curate, which I've been using for more than 15 years.
Oh.
Our own Dr. Rohil Weil has developed a micro punch, like Harrison punch.
Wilson sponge it is called. But
yeah.
honestly, when the overhang is too much, it's called as a Wilson sponge.
Yeah.
The blade is too, when you really need it badly, it doesn't work. I mean, you can't fit it, not that it doesn't work.
Yeah, so I haven't used much, but I once, and it looked promising.
Closer to the chorda, his strokes are becoming much smaller. When he's away from it, the
Yeah.
curate is moving more. Here it is only at the wrist level, so that he does not inadvertently damage the chorda.
In this scenario, your micro gauze would have been very, very useful.
Yeah.
When we damage the
Ashish?
CSOM cases or colostoma cases, very rarely patient has the symptoms. In stapes, always patient will be bothered. Always will have symptoms.
So typically in how many weeks?
Initially,
Yeah.
it resolved with time, sir.
Yeah.
It resolved with time because of the regions, but yes, initially, patients do appreciate the symptoms.
See, and if at all as a surgeon you think you straight the chorda, please give a steroids to the patient. Steroid will improve the taste buds. It's reduce the inflammation, nothing to do with taste bud. A steroid anywhere reduces swelling and inflammation, and thus the recovery of the taste is much
Yes,
faster.
so we've started routinely to apply. So we keep gel foam soaked in steroid solution on the chorda.
Microdrill, no?
Is on. One is to prevent it from getting dry, and then instead of saline, might as well we use a steroid.
Bhumkar,
Can you see the glimpse of the
now we can
glimpse of the body of the long process of the incus coming in the view?
Yes, we can see
This
it
exposure is very important to maneuver your instrument and piston in this region.
Absolutely.
So kind of exposure required is variable.
Yeah.
To me, I should be able to see the fallopian canal above my superior extent of exposure. I should be able to see the
Yes, this is
see
perfect.
micro drill is more elegant.
This is a case for
See
drilling.
now I'm using micro drill.
Correct. Yeah.
This looks more elegant, more controlled.
And most
More
important,
precise.
even laterally, the canal starts to flatten out. So your subsequent instrumentation
Yes.
to the foot plate becomes nice. You're not only removing the edge of the overhang, you're flattening the canal, so to speak. So
Yes,
your
so that I can
instrumentation.
punch out that later on.
Yeah, and he's thinning it. He's first of all thinning it, and then he will take it out. Closer to the chorda, again, he's being very careful.
And one thing I learned from Dr. Vishwanathan, when he does exploratory tympanotomy, when you're doing a stapes case, first thing you'll do, take a small gel foam, soaked in adrenaline, keep on the foot plate area. Before starting this curating. Okay?
Yeah.
So that can give some hemostasis when you're playing around the foot plate area.
Correct. Yes.
You'll
Because,
add a
because
small,
these are
small-
the guys when they were doing before, their stapes was before lasers. So any vascular, you have giving adrenaline, just like in FES surgery.
And today also number of the people using laser will be limited.
Yes, sure.
Most of
Yeah,
people
most of-
are
yeah.
still doing a conventional stapedectomy.
Yeah, yeah.
Whether they take a
Yeah. No,
big
I mean,
cup-
he changed it where
Yeah.
PGB is concerned. He
Yeah.
changed it after he got the laser here.
One more time.
So this is very important point. Do not drill at the edge of overhang. Make overhang overall thinner and
Thinner.
then take it out with curate.
Never use any pressure. Never use any pressure.
And
Yes,
If
that
your
even if
burr
you're
point slips down,
on burr point, unfortunately, in most of the medical college, burr points are not good. So we get addicted to giving pressure. So make sure that you don't give pressure, even if you're doing a mastoid surgery.
this is the first thing I learned from Morwani sir's courses about the drilling. Never use any force anywhere once you are drilling.
I tell you, first workshop Satish Jain did with me. Satish, when was it? About 30 years back?
No.
First workshop 25 years back?
He was in
Yes,
school
sir.
in 30 years back.
You know, what is
25
the
years
story?
back.
So he told me to come one day earlier and he showed me his surgeries.
Acha.
So first case, I was to do stapes
In his place.
in his place. Workshop was name of Dr. Morwani.
Okay.
I told Satish, no, you are going to do it. He said, no, people mere ko marenge, in the sense they come for you. But he did so beautifully. Because why would I allow him to do it? But he did so beautifully, as beautifully as anybody can do. So I done in many workshops, I allowed my juniors to operate,
To give them big
teaching
confidence.
theoretical is easy. You can read in the books. But practical teaching and standing there.
Yes, absolutely. So you are
Operating
a
this
very
particular bone there, very important. Look at that step.
Satish, you can talk. I can keep on talking.
Yes, sir. Please carry on, sir. So I just thinned out the overhang. You can
Yeah,
see
very
it was
nicely.
quite significant. Quite significant an overhang it was.
Yes.
And you can see the glimpse of the oval window
Could we focus,
coming in view.
please, Satish?
Focus.
Little bit more.
Better?
Okay, better.
Okay.
This is the best in this microscope I can do. See the glimpse of the fallopian canal, right angle. Glimpse of the fallopian canal. You can see, let me remove this mucosal tag.
Yes, now we can see. Yeah, we can see the fallopian canal. Yeah, a little bit.
See the foot plate.
Head of the stapes.
Fallopian canal.
Yeah.
With some angry vessels over the foot plate.
Yeah, and this head of the
Can
stape, if this is it, it's quite bulky.
Yes.
Junior audience point of view, you must see the base of the pyramid. For senior, tendon insertion is good enough. But if you can see the base of the pyramid, then you have a lot of space to put the Teflon.
Yeah.
See now, Ashish.
Yeah.
What I always suggest, where to stop superiorly.
Yes.
Can you see the long process of the incus?
Yes. As it starts to
Can you
broaden.
see it has started broadening?
Yes.
It has started broadening to the body.
Yes, that's the body.
And here, if you further remove,
Yes, we are going to-
you expose the includomalial joint.
Yes.
Which is something one is not supposed to.
Yes.
So this is where the incus body, the long process starts broadening to the body.
Yes.
Is your end of superior exposure. What do you believe?
Yes.
The second one, what you said better, the fallopian canal. Both are equally important.
Yes.
Fallopian canal, you're saying that's your enough space around.
Yes. Anything more you do, you are likely to make the incus unstable because the body is what is
Not
holding.
only unstable, you can make the includomalial joint unstable, and even your tympanic membrane, you repose it, can come in contact with the incus, can draw inside and can lead to adhesions as well.
Traction pocket.
So that is something not warranted.
Okay.
So in given case, if you have to remove excessively, incidentally you are removed excess, please reconstruct that atic defect after doing stapedectomy with the cartilage piece. That piece should not, too much bone should not be removed. That will create a retraction pocket in future.
Okay, so this I think is very important. What Satish is doing is exceptional. This degree of drilling there, one tends to be scared. But this overhang removal is what is going to make his subsequent steps.
Yeah.
You can already see the pyramid.
See, my fallopian canal is in view.
Yes. Fantastic.
I'm skeletonizing the chorda.
Yes, this is the chorda that is getting skeletonized. He's making sure the thin sleeve of bone is over it, which if need be, he'll remove with a right angle pick later if he needs to mobilize the chorda. Great, Satish. Superb. Intermittent irrigation. So, but the field is.
See the stapedial tendon and the pyramid very clear now.
Yes, now we can see.
Sir had just mentioned that he would like to expose the tendon thoroughly. Can you see the tendon?
Yes, we can see.
And how it is emerging from the
pyramidal.
fallopian canal. Can you see?
You can see the base of the
See
pyramid.
the,
also.
Yeah.
see the pyramid and the tendon.
Very nicely seen, Satish.
Pin drop silence in the auditorium.
Yes, we are being
Now
told.
what I am doing, I am drilling the caudal eminence.
Sorry, say it again. You are drilling the
Caudal eminence.
The bone lateral to the chorda tympani.
Yes.
Don't get, there's one thing bad the endoscopic surgeon has given. They've given so many names to different area of bloody ear, इतना साला confused करता है. मेरे को लगता है मेरे को otology नहीं आता साला.
ठोको मुबारक खान को पकड़ के ठोको.
Very painful people, just given after doing 50 years otology, fuck all about all these terminologies.
He actually read a paper circle. Talk दिया था उसने. किधर है? Where is Dr. Shriram? हाँ. Some F words he's using.
I tell you.
Now I'm keeping my chorda away from my area of interest. That's the goal.
Yeah.
I don't have to do too much to it.
Yeah. I think now the foot plate is nicely accessible to you, not just visible.
Yes. So I pushed it inferiorly.
Yeah.
Doesn't come in my way. See now?
Yes. Very nicely. Yeah.
It's still a thin bone. It is still a thin bone over it.
Yeah.
And what I will do, give me a gel foam or a cotton ball, gel foam piece.
And he has gently taken
Ashish,
it.
I would love to do under more magnification something.
Yeah.
Love to show you under more magnification. I'm surprised this microscope doesn't have more magnification. Huh?
अरे तू तो आंख बंद करके भी कर सकता है. तेरे को क्यों लगता है magnification?
To show you.
You are.
हम लोग भी आंख बंद करके देख लेंगे इसमें क्या?
Some more anatomy at the foot plate level. I could see the foot plate.
Conspiracy.
Whiter foot plate. We just discussed the Malafonte variety of foot plates.
You are pampered by all of us. That is what the problem.
It was a big day. Not
Yeah.
right angle.
You pamper people who deserve to be pampered. You can't pamper everybody.
They want to say even Satish Jain and Microscope is still inferior than. Very nice. Is that adrenaline gel foam or high gel foam? Yeah.
And then a simple gel foam.
Simple gel foam. Yeah.
I mentioned about the use of laser.
Yeah.
At two places, I'm so scared of, working without laser. I'm so used to now with the laser that without laser is always a, sort of lack of confidence sometimes.
Anxiety, yeah.
So what can we do? What can we do to avoid complication if you're not having the laser?
What is this
And
trick?
this is the situation. We don't have laser.
Gel foam to keep the chorda away?
A little bit here.
Yeah.
So that I can show you the foot plate area better.
Better. Okay. This is fantastic. So you have put it between the incus and the chorda.
Yeah. Now what I was trying to say, if you don't have a laser, how can you avoid a floater? How can you avoid a foot plate complication at the time of carotid and fenestration?
Yeah, drilling.
So this is where the Yugofish devised the reverse stepedotomy.
Correct. Yeah.
Reverse stepedotomy is what? Entire process is reverse. Reverse means in a regular stepedotomy, we cut the tendon, we disarticulate the enkidostapedial joint, then we cut the crura, then make the fenestration. If I have a laser, I would do like that.
Yes.
I would disarticulate the joint, I would vaporize the tendon, I would vaporize the crust, and then make a fenestration with the laser without mobilizing anything. In the reverse stepedotomy, what I will do, I will take the advantage of this entire intact enkidostapedial arch.
And the
So
fixed.
what I'll do, what I'll do, I'll first make the fenestra. I'll first make the fenestra with the intact arch, so I do not give a floater.
Floater. Yeah.
Number two,
I would put a piston so that my the job is done, and then I will start disarticulating the joint and the carotid so that my foot plate doesn't get out of the place. So
Yeah.
this is something. Now, adding on to this, I always mention everywhere, which I learned from Ashish. In removal of the crura, the most important is the posterior crus, which is responsible for most of the
Audio
damage while
mic has moved.
well, it is thick and stout as compared to the anterior crus, which is most likely very thin and fragile, and you can easily fracture in most of the time. So what you can do additionally to prevent complication even during this stepidotomy, adding to it, thin out the posterior crus with your drill. That serves two purposes. One is it prevents the possibility of a floater while doing a carotid. At the same time, it gives more space to deal at the foot plate level. More space for even the fenestration. Am I correct, Ashish?
Yes,
Yeah, you
absolutely
can
right.
thin out with the drill.
Satish,
You
your
can do
mic has moved down a little bit. Somebody pull his mask up.
You can use a drill, or you can use a laser also.
Yes.
To thin it out.
Yeah.
And Ashish here,
Yeah.
I cannot even do the thinning of the posterior crus. Can you see what is coming
Yes,
in the
it is.
way?
Yeah,
The
yeah.
thick tendon.
Yes.
The thick tendon is coming in the way.
Yes. So you'll have to drill a part of the pyramidal process to get an access to the.
So I have adequate access to the foot plate, what I believe.
Yes, yes, yes. A nice
Can you see?
wide foot plate. Yes, you can see.
Yeah. So fine.
Can
So
you-
what I will do,
Think a
I'll
bit-
make my fenestration
Satish, the focusing is not brilliant for us.
Yeah.
Just the tendon focus kar हमको tendon kar.
We are seeing like 4 pegs down. Thoda
Yeah,
blurry.
the other way around. Other way around.
Yeah.
My focus is on the foot plate now.
Yeah. Unfortunately,
Mubarak has particularly kept the microscope bad so that people have to use the endoscope.
yeah,
Can you
Satish.
show me the piston first? Can you show me the
Satish,
piston
sometimes
first?
in situations like this, I may cut
Yeah.
the stapedius and then weaken the crura because the stapedius is blocking
Yeah,
my.
I thought of the same.
Yeah.
But here I don't want to,
Yeah, because you have a good
cut
access.
this
Yeah.
tendon.
Yeah.
Yes. I have adequate access. Otherwise, I would not think twice before cutting this tendon.
Exactly. Yes.
This tendon is additionally giving me
Support.
stability.
Yeah. Yeah. Agreed.
इससे पतला दोनों एक size. And I am going to
Satish,
use my
Satish.
titanium piston for the advantages. Hello.
Satish, some people have come here to learn endoscopic surgery. Can you just show them a view of the endoscope at this stage? Some people have come just to learn the endoscopic surgery.
Patient
Yeah.
को दूसरे OT
Let them be happy. Let them be happy that it's how good it
Brilliant
looks.
high definition on-site magnification picture by the endoscope.
About
Only
30
thing
years back,
amazes
Pilu, you
the
had given us
endoscope is the
slides. One German fellow used to do all endoscopy ear surgery slides. Huh? What was the name of the German? The guy who gave us Digin. He had given us a beautiful 30 years back. Ear surgery pictures, only pictures. He was not doing anything with the pictures are beautiful, and we had copied and given to many teachers.
This is the piston measuring the telescopic.
Yeah.
Yeah.
So let me see how the 4.25. I don't see too much of distance here, but I can expect more distance after this foot plate drilling.
You go to the upper part of the.
It should coincide with the body of the incus.
On the superior surface or the under surface?
Parallel to it. See this now?
Acha.
Satish,
So that's the superior surface, is it?
Yes. So
we
this
need
is
a
4
bigger
and half.
focus.
Hello?
Our
Let's
picture
see,
is very bad, Satish. Sorry, excuse me. Our clarity is really not good. Audiovisual.
magnification which is not possible in this microscope.
No, tera microscope nahi. Something they should do with the camera. You can.
तेरे अभी अच्छा हुआ था बीच में.
बीच में अच्छा था, it again become very blurred.
Audiovisual people. In the last
Okay,
last
it's
case
better,
also-
better.
No, in the last case also towards the end you gave us good picture. So
Now
this
it's
is
good enough.
better.
Now it's good enough. No, don't. Let's
चलो
not.
थोड़ा
let's
सा
not
तो
bother.
yeah, we are in the yeah, okay.
How's
We
the
can't
picture
really
now?
appreciate the color of the footplate, but that's okay. We'll imagine a little bit.
Yeah, what can I do now? कितना पास लेके जाऊं यार?
Which microscope is this?
Oh,
you're
this is
using?
better.
Ah, this
This
is
is
much
best.
better.
Best.
Little better?
Better,
Much better.
much
Tendon is
better.
focused nicely.
Okay. So my site of fenestration is always the central part of the foot plate.
Yeah.
I am biased doing, towards doing inferiorly, which is not, in this case, I am not going to go very, very inferior as my crura are intact. See this, what I am using?
Yeah. Yeah, better without the gel foamy karo drilling. It's better for us to see.
Okay. Okay, the fallopian canal bone is intact, not dehiscent.
This is 0.6 diamond
See
skitter.
this? Yes.
You're making the fenestra, you're drilling the posterior crus.
He never used pressure.
Yes, just a touch.
This is expected. I could see the,
Vas-
the angry mucosa over the foot plate because looking like a whitish foot plate.
This is why you put it.
Yeah, adrenaline. Yes, yes. This is what Morwani sir is saying. This is why before you touch the foot plate.
Yeah, adrenaline would definitely help.
Yeah.
Moment you do
Adrenaline on the foot plate helps it.
put the gel form soaked in adrenaline there.
Yes, this is
Does
important.
it help all the time?
Sir,
No.
ABR sir also used to do it, sir,
Yeah,
routinely.
most often. ABR did not do too many workshops. Vishwanathan
But
used to
then he
lot
would
of
say that you have to wash away that adrenaline by at least 10 times you keep a dry gel foam and wash away all the adrenaline because it's a sort of a
As
bowl.
long as you are using before opening the vestibule, it is
Correct.
fine.
That's right. Right in the beginning, before you done a drilling of the posterior superior overhang.
One should keep that adrenaline. That is always a good practice. But this is very, very frustrating.
Yes, this is terrible. Now patience. It's a game of patience now.
This is not a blue foot plate. Everybody, this is not a blue foot plate. You have to be extra careful at every point.
91 and Madras. They wanted to
See, Ashish, after that gel form, my collar
Yeah.
is behaving so good.
So yes, Satish, we can appreciate that.
So, the audience objected. There was Dr. Ramdas, who was a senior.
You were a junior.
And he had a lot of stippies. So they came around, can we give him, please give him the senior person? No problem. Persistent stippial artery. Lassi is your problem. You are
See, there should be no pressure over the foot plate. Why I am, using the syncopal arch intact and making a fenestration so as to avoid a
Floater, yeah.
floater
Correct.
or a
Yeah.
submerged foot plate. So this arch is rock solid to prevent the foot plate getting down. This place.
बरस पहले workshop किया था 25-30 बरस हो गया 2001
Oda, this part of the overhang, see this bone? It is touching the shaft. If this goes away, his drill will be little. Lovely. Now he's got a very perpendicular vertical assembly. Now you have to start looking for.
I can
very-
have a feel of foot plate.
Yeah.
I can have a feel of contact of the drill with the foot plate.
And also the bone dust starts accumulating. Just like in a grinding of the fine bone dust starts
See
to
this?
accumulate.
See such a narrow space with the prurine place, white foot plate, little bit of the oozing because of the otosclerotic foci. So we have to have patience. And in this white foot plate, I don't have a laser. I don't want to take a chance of,
Yeah, doing the chlorotomy first. Yeah.
Yes.
Although it's a good anterior focus, but still he's being very careful.
No, the focus is over the foot plate as well.
Over the foot plate. That's why it is white. Correct.
That's why it is
Unfortunately,
white,
we are
yes.
not able to appreciate it. The picture is not so good for us.
I don't know if something can be done.
No, it's
Or can
okay.
we
It's
use
okay. No,
the
I'm just
microscope?
saying.
It's okay. Don't bother yourself.
No, you don't worry, Satish. Yeah.
No, I have a good picture microscopic. Even I have a habit of operating under higher magnification.
Yeah. थोड़ा चाहिए तो थोड़ा सा posterior crust को drill करो ना. Sometimes the head of the stapes is very bulky. I drill away the head also. So my definitions of overhang is anything that comes in the way of my foot plate. Of course, not the facial.
But I'm sure I'll be able to.
No, for
Through-
your information, you can even drill away fallopian canal. But you have to be very, very cautious. The bone on the fallopian canal, horizontal portion, is very, very thin. By removing the bone on the fallopian canal, you're not going to give facial nausea. Like he talked about overhanging facial now. If your facial nerve overhanging half, and you can see half the stapes, still he can do a stapedectomy before removing the corona. Moment you remove the corona, the facial nerve is going to come down. So do, as he says, reverse. Stapedectomy, Teflon, and then remove the corona. If the Teflon touches the facial nerve with an intake sheet, no paresis ever.
No problems, yeah.
My language is getting better. Otherwise, I've given a lot of dirty examples. As somebody told me, now you're too old to talk nonsense.
It is not working. आप कर रहा है, आप कर रहा है. Once you're through, you get a feeling of give way.
Yeah.
The skater is not working. The moment it comes in contact, stops moving.
Oh God. That's the terrible thing. Yeah. We are seeing some change of color, but on the foot plate, we are able to.
A bit of drilling is done.
नहीं है. Jomet का console नहीं है आपके पास?
Satish,
console नहीं है.
at my age, I would not mind in this case to do conventional.
To do conventional.
Conventional. Get a tendon out, get it out, because there's
Better exposure.
not enough. See, he is used to laser. Laser is a boom for the stapes is definitely possible.
The issue is my
T1 lesion.
skater stopped
These are
working.
two best pathologies which should be treated with laser.
By now, in his place, he would have finished 3 stapedectomies. Because the laser, it's a video game for him.
Yeah. Laser, I would have finished by now.
No, 3 surgeries, 3 stapedectomies.
Perforator there. Perforator there.
Yes.
Anyway, I'm using perforator. Skater is not working. Oh my God.
Arey.
Too big. Dangerous tool.
Arey yaar.
Too big to accommodate, boss.
Again, no pressure.
No.
No pressure. Just rotate. And you get a feeling of giving. You know you're going deeper and deeper.
Ashish.
Yeah.
Skater not working.
Oh man.
Diana,
So
perfect.
let's go.
Perforator se
Whether
Niकाल
I'm
दो. Okay. This is that.
Very good friend of yours.
Oh my God. Give me the scissors to cut the tendon and give me the micro drill then. Anyway, give me the micro drill.
Nanded, we did handbirth for 45 minutes.
Wow.
45 minutes. You know, he is there, was searching with that. You know, handbirth.
Maruti,
But
yeah.
important thing is be patient. Don't be impatient. Don't get, you know, itna time like that. Time doesn't make a difference. 10 minutes surgery, if it takes you 45 minutes, no problem. Okay. कोई लड़की 2 महीने में पड़ती है, कोई 6 महीने में पड़ती है. पटाना तो है ना. स्टेपिस तो करना ही है. बात खलास.
Hello, Ashish.
Yeah, Satish, it's back. You got a better. Oh, you got a regular drill.
Regular micro drill now.
Regular micro drill. Okay, I can see that. Okay. ना थोड़ा सा हाँ. Okay. Okay.
लाई मत यार. No movement, please.
Yeah. Okay. I think now it will be done.
ला मत दे दो.
Okay.
Doing a birth, 90 mm birth. And a regular drill with 200 speed.
Huh. So that's what is taken, micromotor, regular. You said Indianization, no? It is he's doing. Yes,
Ashish,
lovely, lovely. Yes,
I'm
yes.
through. Can you see the finestra?
Yes, yes, perfect, perfect. We could
Everybody,
see.
can you see the finestra?
Yes,
We are
Nice.
clapping. We are clapping.
See, once you create a finestra, you are not supposed to suck over it. That is the biggest problem and the commonest reason behind giving sensorineural hearing loss. Never ever suck directly over the finestra.
That
Let
is-
the labyrinth remain full of fluid. Even if there is bleeding, this is not going to go inside. The pressure inside the labyrinth is more than the pressure inside the middle ear. So no blood will creep inside if the labyrinth is full. The moment you suck over the labyrinth is a disaster.
And same thing is true
I'm
when
done.
petrosectomy semicircle, not
So I
fistula.
have done the finestra with a regular micro drill.
Respect.
Now, stapedius.
Now I think patient has started hearing. Let us all talk softly.
Dangerous seizures, what dangerous
Most
seizures?
important thing, a lot of people don't know. Patients
Jam hai yaar ye.
immediately better moment to finestra. You don't need to put Teflon. Patient will hear better. You ask them. Everybody tries after putting the Teflon. Try. Moment you did a finestra, he knows what you're talking about.
Really?
Yeah, yeah. It makes immediately on moment the finestra patient will hear better. And he'll hear better once you
Put
a
the piston.
Teflon. And example.
So we should talk softly. Otherwise, he'll say, "Put my."
I don't know.
plate
Much
part
using a
back."
local
Can you see the tendon cut?
Yes, yes, we can see the tendon.
Yes, yes,
cut.
very much.
tendon
And now can you see the stout posterior crest, Ashish?
Yes, Satish.
Can you see the stout posterior crest
Yes, we can see.
underneath?
Yes, yes. So you're going to drill that.
And this is what I call the Ashish Bhumkar technique.
Hmm.
This is something I love drilling the posterior crest. This prevents many of the problems, you know.
Zala. हो गया. No, he should put a piston now, yeah.
Yes. See
Great.
the posterior crest?
Yes, completely drilled.
Now you can put the
Now?
piston, then do the rest.
Piston, first piston.
Then the rest.
Placing the piston is like a video game, 4.5.
So now the incus is still very stable because the incudostapital joint is intact and the anterior crus is intact. So that is holding the that's like an assistant holding the long process of incus. So you know he
See,
can.
Ashish, the vestibule is full of fluid.
Yes, yes, we can see nice, beautiful rouse.
Yeah, never ever suck on the vestibule. It's a disaster.
Yeah. Now you did your measurement, it was 4.25 for your titanium. Now you're going to use the titanium clip?
Mubarak sir is very angry with you. You have devised so many new terminology. He is so confused. नया microscope है, लगाने का नहीं. हो गया आपका? So taking the advantage उसको local लगा दो उसके enter करवा दो local लगवा दो वो लगवा दो microscope. So taking the advantage of this intact incudostapedial arch, now I am going to place my piston. We have already seen I am going to place 4.5 clipped titanium piston. The advantage is it doesn't need crimping. Crimping is something I'm so, scared of. A perfect crimping is always required. So the piston, there should not be any, play between the piston and the incus. It should be tight enough to prevent any play between the incus and the piston. Number one, ideal crimping. Number two, it should not be too tight to give problems. This piston, see this?
See, this is also the reason. Now you know why he drilled this bone. I was wondering why he's doing that, but that's, I think, to help him introduce that clip piston because it has that little extra length.
Longer
Yes.
anteroposterior diameter.
Oh, yeah.
See
So
now,
this-
my piston is at the fenestra.
Yes, we can see down there. Yeah.
Now this is the end which is open end which is going to take the incus, long process of the incus. I am rotating.
Yeah. You
See
clip it
this?
and we'll clap it.
And this is the bar
Okay.
which I am going to push to take on the
Okay.
incus.
Okay.
Wow.
Abhinay.
Yes.
Yes. Okay.
That's it.
Oops.
No, I removed it.
Oh, you removed it.
I wanted to ensure that it is right within the fenestra. Titanium is extremely biocompatible, number one. Number two, this piston doesn't need any crimping.
Yeah, correct. I think now a little
See
bit
this?
lower on the long process here. Earlier it was up. Now it's perfect.
I
Okay.
can ride it up.
Yeah.
See
Okay.
this?
Fantastic. Lovely. Absolutely at right angles to the incus.
See this? The piston is absolutely at right angle.
Yeah.
Can you see very well?
Very nicely, Satish. Beautiful.
So this is reverse stepidotomy, and now I am going to complete my stepidotomy.
Yeah. This articulation, yeah. ये क्या हो रहा है?
That
अभी तेरे को
during
you'll
the
have to
initial piston application, I loosened it by
you
mistake.
you should crimp it now. Just joking.
During the initial,
He can
Concentrate,
look at the
concentrate.
corda there next to it.
See, whatever you talk about this, theoretically sounds good. You don't need to crimp. For 50 years, ABR decided with a Teflon piston. Where's the
Yes.
problem?
Yeah.
No,
I
And
agree.
he
It's
did
not
maximum
about-
stapes on the
Uh,
earth. So,
yeah.
what are you are used to it? What you're used to it is easy. What you're not used to it. And new technology, there's no harm in growing and doing new technology. What is-
Watch. Yes, sir. Yeah. Mm. See,
I
cantilever.
don't see, because there is no magnification, I don't see even the incudovestibedial joint properly.
Yeah. Lovely, brilliant idea he's got. Sometimes this because even the superior surface of the head of the stapes can be beautiful, Satish. Fantastic. He has created space. He has weakened that joint. अभी मिल गया उसको. Yeah. Okay. Now he's under the lenticular. Yes, sir.
It's out.
Got my suprastructure out. See this?
Yes.
See
Lovely.
the suprastructure out?
Yes. You can see the head also.
Yes.
Local में कर रहे हैं, GM में कर रहे हैं.
Local.
And I leave little bit of blood over the fenestra.
Yes.
The blood acts as a,
Sealant.
no, I'm already there. The blood acts as a fibrin. See, this is my chorda, which is undisturbed. Can you see?
Yeah.
Yes, yes.
My piston, it was a white foot plate, no laser.
Okay. Lovely. Great work, Satish. Our Seer Institute used to collect blood.
Yes, venous blood
And keep
foot.
it
Even
and
I
fill
do,
the
sir.
middle ear with the blood.
I do see the blood over the foot plate.
Yes, we can see. Already a
We
clot.
never try to suck it. This is good. It contains fibrin and it is a good sealant, and this is not going to creep inside as the vestibule is full of
Pressure.
fluid.
Hello.
Yeah,
Good.
subterosection.
Well done.
Vein graft.
Vein graft.
I think Dr.
Role of vein graft.
Dr. M.M. Patil had a presentation.
Role of the vein graft
paper
normally
where
comes in
such
if incidentally,
situations, he would
accidentally,
leave the
you remove the whole
stethoscope
foot
under
plate up more than venous has happened. Let's say half foot
Vein
plate comes
graft-
out. So you want to protect
Do you know
that.
what
Graft has a
And
big
some people
advantage.
like
Karan sir would know. Dr.
like
M.M.
Akeem
Patil
Desai
sir
use
had
it
a
for every
paper
case,
where
you know.
he used to keep
So
his
it's just a
suprastructure
method of doing
behind.
it, what you're used to it, you know.
Yeah, you don't know. Okay.
A great demonstration and nice interactive session.
Satish,
Sir,
somebody wants to know when would you be using vein graft?
yes. So my indications for vein graft is always good. So first of all, there is no harm in using that. But practically, if you are not using an overlong piston, vein graft is not always needed. Even the endosteal forms very quickly within couple of hours when you put the piston, if it is not overlong. But in certain situations, when the patients are demanding, in the sense, patients who are exposed to the pressure excursion more in their life, like who are frequent flyers, pilots, divers, or whatever reason, they are more demanding, it is always better to use a vein graft. And secondly, in revision situations, when you do a malleus we never do without a vein graft, because the range of excursion of the malleus is more than the range of movement of the incus. So these are few indications where we particularly use the vein graft. Otherwise, most of the time, the direct piston is equally good, as long as your length of the piston is not overlong. Length of the piston is the single most important factor. Second advantage of the vein graft is it prevents you from putting a long piston. If you try to put a long piston over the vein graft, the vein will invaginate. And that picture of the vein will warn you. That picture of the vein will warn you from using a long piston.
So Satish, there's a question. What is the normal length? Most of the cases, what Teflon do you put? 4.25, 4.5? What is the commonest Teflon length you use?
Depending upon the patient, not fixed one. We always check the required length.
But in your practice,
One
which
size cannot fit all. One size cannot fit all. But mostly 4.25 and 4.5 by and large.
yeah, this is the point I want to bring it about. Because when German used to come about 25, 30 years back, they used to talk about 5mm Teflon piston, which I had always objected. 5mm. And of course, they must be getting away with this. Maybe the German build is bigger. So maybe German population may be good. But if this guy is doing for an Indian population whose height is 5 feet 1 inch. Yeah, so
Sir,
this I'm
secondly-
saying Germans used to talk about 5mm.
We want piston not to project more than 0.3 millimeter in the vestibule, as this has been our standard teaching. The piston should not project more than 0.3 millimeter. But nowadays, I am biased towards using even a 0.1, 0.2 millimeter longer piston. The reason is, And this I started after going through a publication from Dr. Anand from Polechi. And that was very convincing. And we realized also after a couple of, years, the otosclerotic fixed foot plate tends to bring the incus little medial, a fraction of millimeter. Because of the fixed foot plate below and the stapes fixed over that, it tends to pull the incus a little medial. And once you do a stepidotomy, once you do a incudo, separate the incus from the foot plate, this incus tends to release, and over the period of time, it comes back in the original position, and it makes a difference of 0.1 to 0.2 millimeter. This has been proven and was a wonderful publication. And we realize there is no harm in putting a 0.1 or 0.2 longer piston. So nowadays, our piston is little longer than before. I am biased towards using a longer piston so that it should not come out. It should not fall short, because region is in conductive hearing loss, post-stepidotomy. Once you explore, 99% of the problems are because of the piston related. Either a long piston engaged at the side or the edge of the foot plate, short piston coming out, piston leading to necrosis, short piston hitting in again and again, loose piston hitting again and again in incus. All these are piston related problems. And one of the major problems out of them is a piston which is falling short and out of the vestibule. We have seen a lot of revisions. We have seen a lot of revisions from here and there, and many a times we have found the short piston is not uncombining. So we are nowadays little biased towards putting a pistol which is little longer than usually what we would put. Ashish, anything you want to say?
Yeah, no, I think I agree that once you disarticulate the joint, there's a slight spring action up, but I didn't know the measurements.
Yes.
I
And
haven't.
it comes, that spring is maintained over a couple of, days, and it brings back a little laterally.
Yes, Satish, when you allow this patient to travel by air?
By air? See, the idea is the endosteal should form. Ideally, they can fly after 48 hours, but still, to stay on the safer side, we always tell them to, fly after 7 to 10 days. More importantly, from your question, this situation is upfront asked to us by persons who come for recruitment in the Air Force or in professional pilots who aim to become professional pilot and all that, am I fit for, this situation after this surgery? So the test we recommend, if you really want to be fully satisfied, we recommend them to undergo a tympanogram test. Creates artificial a negative and a positive pressure inside the extraoratory canal. By means of the pump, manometer, you create artificial positive or negative pressure up to 400 millimeter. So what happens? If you create a 400 millimeter positive pressure, the tympanic membrane becomes taut. With the more and more pressure, it becomes rigid like a wall to prevent further pressure being transmitted inside the middle ear. So little bit of the pressure until the tympanic membrane is taut, it goes inside, because your mechanics is altogether changed after the stapes surgery. I'll come to that. So if the patient passes quietly without getting any symptoms, vomiting or anything, the tympanogram test is fit to do anything. That kind of pressure exertion, if he passes, is fit to do anything. Even that pressure is not developed in the fighter planes, in flying, diving, or anywhere. So anybody who passes the tympanogram test is fit to do anything. Number one. Number two, the mechanics of the hearing tremendously changes after the stapes surgery. For junior colleagues, normally, in a normal situation when we hear, the foot plate goes in and out because of the sound transmitted to the incus and then to the stapes. The movement of the foot plate which goes in and out is very, very minimal. It is in nanometers. In nanometers. Now, what happens after the piston? The size of the foot plate initially in a normal situation is almost more than 3 millimeter in a square dimension of the foot plate is more than 3 square millimeter. Now, what happens after the stapes surgery? The fenestra is a fraction of millimeter, but the length of excursion of the piston in and out is much more than the excursion of what the foot plate was. Now the dimension which goes in and out is less, but the length of the piston goes in and out is more. So the physiology altogether changes. The protection mechanism changes. You know, when the sound comes to the tympanic membrane, it passes to the malleus. From the malleus to the incus, to prevent excessive sound transmitted to the incus, there is malleoinguinal joint, which is still intact here. Then, at the level of the foot plate, to prevent excessive sound entering the cochlea, there are two mechanisms. One is the stapedius tendon, and another is the annular ligament. Both are lost after the stapes surgery. So, patient is more vulnerable to the, pressure excursion and sound trauma after the stapes surgery as compared to the normal individuals. So, to stay on the safer side in people who are exposed to the pressure excursion, exposed to the loud sounds and all that, we have to be very, very particular in counseling them. We have to be very particular in giving them a clean chit. I would always order a tympanogram and say, if you pass this, you can do anything in life. Simply like that.
Just one information. A lot of people come to you for, of course, now number of the people coming to stapes from outside Bombay are reducing. We have taught too many people unnecessarily, to do surgery. This is our mistake. The important thing is if patient has to travel early, I will put them before only on steroid and nasal spray. He's talking about endosteum. Endosteum is saying 1 to 2 days. Our friend MBR Desai used to say 1 week. So whether it's 2 days or 1 week, whether endosteum form or not, the important thing is negative pressure should not take the Teflon inside. So to prevent that, you start treating his station 2 earlier, whether he has got symptoms or no symptoms, and then allow them to travel within 48, 72 hours also. And most important, I'll tell you post-op. What do you mean post-op? If this patient has no vertigo, no nystagmus, means Teflon is not too long. So this patient can travel faster, okay? And precaution, nasal spray, steroid, you give them so that Teflon doesn't get inside if the pressure in that particular air flight changes.
Ashish.
What are you doing next, Satish?
Yeah, so we are moving to the next case. Any questions regarding this? We can continue later as well. And throw all questions to Ashish and Morwani sir meantime. The next case is a very interesting situation. Patient has been operated earlier bilaterally for chronic suppurative otitis media. Has cavities bilaterally, discharging cavity with profound hearing loss. One side he has already developed because of the ongoing infection, middle infection. One side already developed labyrinthine ossificans. On other side looks normal as far as the cochlea is concerned. So let's discuss what can be done in this situation. So I'll take you to the imaging findings first, and then we'll discuss the plan.
Dr. Jain sir, please give us 2 to 3 minutes for felicitation. It was a wonderful session. I call upon all the moderators, Dr. Vandana Joshi, Dr. Dhruvo Roy, Dr. Rashmi Prashant on the stage. And to felicitate them, I call upon Dr. R.N. Patil sir. Next session latte hain. I call upon Dr. S. Santosh to receive the certificate.
No CD. Oh, yeah, no CD. Oh. Hello.
Just 1 minute, Dr. Mubarak, give us 2 minutes for felicitation. Yes, sir. Dr. Rashmi, please come on the stage. Dr. Dhruvo Roy, please come on the stage. to receive the felicitation. Dr. S. Santosh from Bangalore. Yeah, please come.
Clap, clap, clap. जरूरत नहीं उसमें कोई चेंजेस ही नहीं है कुछ काय को करो
Dr. Rashmi.
Keep a close follow up. अपन ये इन्फेक्शन सोर्स हटा देंगे ना अनलाइकली टू गिव ओके हाँ तो फॉलो करते रहो जब इसको इम्प्लांट कराना हो तुरंत
ऑफिशियल फोटोग्राफ
और फिर चाहो फिर भी दिखाना है तो दिखा दूंगा हाँ
Dr. S. Santosh. Thank you, sir, for doing the honors. Now, for this session, I call upon Pilu Hakim, madam, Dr. Morwani, sir, Dr. Ashish Bhumkar, Dr. Gauri Belsare, and Dr. Man Prakash Sharma to moderate this session. Please come in the first row. Over to OT, please. Hello, Dr. Mubarak. OT.
Gauri good hai. I don't think Gauri आले. Gauri आलेगा?
She will be coming. She has confirmed she is coming.
MRI कौन सा था इसका
Hello,
दिया ना?
OT.
Hello, Satish, you can start. Huh?
Can you please brief about the patient?
Brief about the patient. No.
Dr. Pooja.
Fine. रैप करके लिया हो ना
Yeah, please go ahead with the history. Hello.
Complaint for bilateral ear discharge since childhood. This is the operated case of bilateral down mastoidectomy. Right was done in February 2024 and left December 2029. She's complaining of bilateral decrease.
बजे वाली हाँ मेरी और रमेश की
Finding we see the bilateral cavities with epithelial
Satish
plates
Kumar
and
Jain
star.
and Ramesh Chand.
Pure tone audiogram showing bilateral profound sensory neural hearing loss. Sir will elaborate the CT findings. The plan is
Canal wall mastoidectomy.
हाँ देवदास ठीक है इसको काट के छोड़ दो और क्या जरूरत पड़ेगी नहीं इसकी हेलो
Yeah,
Yes, Satish.
get on with it.
Yes.
Go on, Satish.
So, first of all, I am amazed to see my own teacher, Dr. Man Prakash Sharma, there in the auditorium, who has always been kind enough to encourage me and, has been a very, very important person in my life. Whatever I am today, he has a big role and I am always indebted to him. Thank you always, sir. Thank you so much.
He hasn't come so far. We'll send him a message.
He's
What's
there.
the message भेजेंगे?
I heard his name. I heard his name announced. He's there.
No, he said
I met him in the morning.
maybe he's gone for
So-
lunch. Not an auditorium, yeah. Yeah.
Maybe.
Send me a message भेज देंगे.
So you have known about this case who has been operated earlier bilaterally for chronic suppurative otitis media, unsafe disease. And because of the CSOM, he didn't have any meningitis or anything. Because of the CSOM, one of the complication is involving the infection spreading to the inner ear and giving labyrinthine ossificans. Labyrinthine ossificans is most commonly discussed post pneumococcal meningitis, but that's not the sole cause of labyrinthine ossificans. A CSOM can lead to labyrinthine ossificans commonly. A trauma can lead to labyrinthine ossificans. Otosclerosis can lead to labyrinthine ossificans. So any pathology, number of pathologies can give rise to. And see what happened to this poor man on this side. Are you getting the CT scan on the screen?
Yes,
Yes,
we
yes.
are.
See on the left side, he has a good cavity.
Right.
Looks like a good cavity on the CT scan. And what happened to the cochlea? This is intra-auditory meatus. This is the facial now. And see on this side, this is the vestibule. On the opposite side, the cochlea is completely ossified. No lumen at all. You see?
Yes, we can see it. Yes, yes.
No lumen at all. Had there been some partial lumen, we would definitely attempt to do something. Some drill out to push in some electrode to give him hearing. But
Right.
here it is completely ossified. There is no possibility of even thinking of cochlear implantation on this side.
Right.
Now on the opposite side, the same story of CSOM is going on. Operated earlier, you saw the picture of a cavity, infected cavity. And on CT scan, you can see the kind of osteitis going in the surrounding bone and the kind of cavity picture on this side. Can you see this?
Yes. Yes.
With a lot of cells remaining there. Can you see?
Yes, we can.
There's still a lot of cells remaining, giving rise to the ongoing infection. See this?
Yes.
Now this CT scan is very useful in deciding certain, issues. Number one, the cochlea. This cochlea looks normal on CT scan.
Yeah.
A CT picture of this kind of the cochlea doesn't tell us whether it is fluid filled or fibrosis. This is not ossified what you can see on CT scan. But you cannot differentiate whether it is fluid filled or fibrosis. Fibrosis will also give the same picture of the cochlea, and the fluid filled cochlea will also give the same picture on CT scan. Too much of noise. So to differentiate between the fibrosis and the fluid filled cochlea, the investigation which is important, which is deciding, is this heavily T2 weighted MRI. Can you see the cochlea on this side?
Yes, we can see it. We can see it.
See the cochlea, fluid filled cochlea on this side, and see on this side. These are the nerves going there. These are the nerves going, but the cochlea is no signal, no fluid signal.
Right.
Can you see how the ossified cochlea looks like?
Yeah.
And this is the fluid filled cochlea, which is very important, showing us a normal cochlea on this side. Had there been fibrosis, it would have been blackout as well. Try to understand what I'm trying to emphasize. MRI can differentiate between fibrosis and a fluid filled cochlea.
So one thing
CT scan
I
CT
would
scan
like to
cannot
ask you one
differentiate between fibrosis and fluid filled cochlea.
So
Yes,
when could you
it can rule out ossification.
Satish, I want to ask you one question. When would you advise, therefore, what is the indication to do an MRI? Only in such cases, or are there other instances too?
Yes. Let me tell you, in the commonest scenario, madam, and there is a protocol internationally. How much it is being followed in our country, you yourself assess. Any child, any adult who develops meningitis for any reason,
Yeah.
there should be a call to ENT surgeon. The first call should go to ENT surgeon beside neurologist to monitor the hearing. This is international protocol I am sharing with you.
Right.
Now for the ENT, he has to monitor the hearing. The moment he find a 30 decibel dip in the hearing is the straightforward indication for MRI. On MRI, if there is loss of fluid signal, there is an immediate indication to implant before the ossification happens to occur. Because initial loss of fluid signal is because of fibrosis, wherein still implant is very well possible.
How soon would you do
But
the
that is
audio?
possible only if it is closely monitored in the beginning. Yes, madam?
How soon would you advise the audio? After recovery from meningitis?
No. I told you for any unit, patient having meningitis should be a call to otolaryngologist.
From the
This
beginning.
is international protocol.
Okay.
And for the ENT, the first thing he has to monitor is the hearing. So
Right.
on a periodical basis, depending upon the course of the patient, he has to monitor the hearing. The moment the ENT surgeon finds a 30 decibel dip in hearing is the indication of MRI. As long as hearing is completely normal, you don't need to order an MRI unnecessarily.
I think this is a very
Number
important
one. Number
point.
two,
Most people
once the patient develops 30 decibel hearing loss, is the indication for MRI to see the loss of fluid signal. Initially, ossification doesn't happen. It's a chronic process. It takes time for the complete ossification to develop. Initially, the fibrosis develops and that gives loss of signal, fluid signal on MRI. On CT scan, loss of fluid signal will look like same.
Yeah.
The CT scan will detect only when there is complete ossification.
Yeah.
So MRI will earliest, recognize loss of fluid signal, and that is the indication for implantation. Now, internationally, out of the record, the youngest child was operated because of the, the fibrosis setting inside the cochlea is a 4-month-old. 4-month-old child implanted because of the meningitis led to fibrosis in the cochlea, which was imminent for the ossification to develop later on. And that 4-month-old child, that's the youngest child operated for the cochlear implant so far in the world, is 4 months because of this meningitis. This is fibrosis in the cochlea. Now, if the fibrosis develops and still you are not in a position to do cochlear implantation for various reasons, child may not be, financially sound. There are so many reasons for not doing implantation. The option for you to buy the time is to put a lumen keeper. Even if you don't implant, keep a lumen keeper, live inside so that the lumen is maintained. Even if the ossification involves the entire cochlea, the lumen will still remain intact for the future implantation.
Right.
So that is the indication for lumen keeper in those situations.
A lumen
Now,
keeper.
coming to this patient, does that answer your question, madam?
Beg your pardon?
Does it answer your question?
Yes, it does. Thank you.
So on MRI, let me show you again the MRI.
From me, did you see the
this
audiogram of this
signal.
patient?
Bilateral profound loss.
So one side the cochlea is ossified, other side is not ossified.
Bilateral
Of fluid. Listen to me. I saw the audiogram. Bilateral profound mixed loss. Okay.
Yeah.
One side with a calcification of the cochlea. Other side is a healthy cochlea according to you with a fluid. How do you explain the SN loss on the other side?
Yes. Yeah. So now what is to be done on the other side? Now this ossificans developed because of the chronic suppurative otitis media. It led to ossification on one side and still the CSOM is ongoing on the opposite side. Still the CSOM is going on. Yeah, no? Still see the osteitis in the bone, in the mastoid everywhere, and the inflammatory process is on, which has a potential to give the same picture of ossificans on the other side, which is not given so far. It is not essential to give that every CSOM will give labyrinthine ossificans.
So what
But
surgery
since
you are
this-
planning for this patient?
Yes, that's why. So now I have two options. First of all, we have to do something concrete to prevent this inflammation which is going on. We have to curb this inflammation. So my plan, since it's a discharging cavity, already patient is profound hearing loss, we have to do something concrete, and this is the ideal indication for a subtotal petrosectomy and obliteration to curb the inflammatory process. Now, second thing, the call regarding the lumen keeper in this case, it is not essential. If we curb the inflammation, this patient may not develop labyrinthine ossificans on this side. Since it is developed on the other side, we should do a subtotal petrosectomy and obliteration on this side, and we can do serial MRI. If any slightest doubt of a fibrosis, you see on any future MRI, just elevate the fat which we obliterate in the cavity, open the cochlea and put an implant. So that is one option. Second option, to stay on a very, very safe side with patient consent, at the time of subtotal petrosectomy, we can put a lumen keeper. But that will be too much for this patient, which may not develop this ossificans further once we arrest this or curb this inflammatory process. In spite of so much of inflammation, he has not developed on this side yet. So once we curb the inflammation, he is unlikely to develop further because we arrest the inflammatory process. So to me, honestly, this patient requires a subtotal petrosectomy and obliteration and serial MRI afterwards. In case any fluid signal loss you detect, there is always the option open for you. Just elevate the fat, do cochleostomy, put the implant and replace the fat back. The entire anatomy remains intact after the subtotal petrosectomy. So
Good.
this is my plan in this patient.
Very good.
So you think that there would be definite improvement after cochlear implant?
Oh yeah, cochlear implant is, but he cannot do a cochlear implant now because there's an infection. He cannot be doing cochlear implant today.
Sir.
For example, other side.
Sir,
Go on.
Movani sir, if you remember in one of your workshop,
yeah, I know,
there was a patient who had a history of meningitis, who had IP1.
Yes.
If you remember.
Yeah, I remember 5-6 years back, we done a
profound hearing loss.
We done a subtotal petrosectomy.
Had a profound
but you know
hearing loss.
infection.
The
And
patient was
cochlear
not
implant at the
affording
same time.
implant. Yes, we did a subtotal petrosectomy and implantation, if you remember.
Yeah, I remember. And that patient was Dr. Halale's patient. And I inquired from him, how is he doing? And patient was doing very well after that, But Halale was
That's a
following.
definitive solution.
Yeah.
That's a definitive solution to prevent further infection. That child had infection before surgery because he had IP1 and IP1 had a foot plate abnormality where the otitis media can lead to meningitis because there is a defect in the foot plate. So
See, Satish,
in that
now
scenario,
this patient, you want to do obliteration. For example, this patient has a profound mixed loss.
yes, profound hearing loss, complete hearing loss. He
Obliteration is
doesn't
one.
have any serviceable hearing.
Huh?
See this. See this. It's a complete loss.
This is not
No
a profound.
serviceable hearing.
This is not a mixed loss. You won't call it
This
mixed
is-
loss.
No, I already inquired. Nothing is possible with such a myotoplasty and wet ear, discharging cavity. You can't even, offer him a hearing aid.
No. He needs a
Since
surgery.
it is bilateral,
No dispute about
since it is bilateral, you can't afford to give him a Baha. So there is no other option.
No, Satish.
I
Look,
just
listen to me. What I'm trying to
If
tell
it's a
you.
dry ear, would a hearing aid help him at all? No, right?
How will you give a hearing
No,
aid?
no. So I'm saying
How
if
will you
it,
achieve the dry ear, number one?
no, if it was a dry
Dry ear
ear,
attempt has already been made by
No,
doing
no.
a canal down mastectomy.
She is asking a different question. With the same audiogram,
yeah,
with a cavity with dry ear, no infection at all,
Yeah.
would this patient be given a trial of a hearing aid?
that's all.
So that is clear. I always mention the indication of the implant. If the hearing aid doesn't work, is the indication for implant.
Right, fine.
Yeah,
That's
So
all
in
I
case
want.
that the hearing aid works, there is no need of implant.
So Satish,
Anybody in the
so
any
Satish, in
patient on
this
the planet,
situation, in the same
Yeah.
case, if you would do a mastectomy, do not obliterate, reduce the size of the cavity and do ossicoplasty, you may improve your hearing by 20-30 dB, where the hearing aid may help you much better. Did you get my point, Satish?
that would have been the situation when there was no cavity like this.
Cavity can be always reduced
Once
in size.
patient-
Cavity,
Huh?
yes, you can obliterate the cavity, you can reduce the cavity also.
So what are you going to achieve with that?
I want you to attempt ossicoplasty after clearing the infection
with-
and do
Sir.
reduction of the size of the cavity.
See,
So if his
here
hearing
the
improves by
question
20-30 dB, he may be good enough for hearing aid.
I don't think acycloplasty is going to help in such audiogram. Number one. Number two.
No, it's not going to make it normal.
Number two,
If improved by 20,
sir,
30 dB, then this becomes
sir,
ideal case for audiogram or for hearing it.
Our concern is to do something concrete to prevent inflammation, to prevent labyrinthine ossificans on this patient who has an only hearing ear now. Only, I would say reconstructible ear now. The other ear is gone. Totally no options left. So this is the only hearing ear, or the only reconstructible ear, I would say, not hearing ear. Other ear we cannot reconstruct by any means. And the reason behind that was CSOM. If the CSOM continues in this ear by any less than definite method you do, and if he develops labyrinthine ossificans, would be a disaster. So now the priority now is to arrest the inflammatory process, and you have to do something concrete. And there cannot be a better way than subtotal petrosectomy obliteration.
So do subtotal petrosectomy and then reduce the size of the cavity and attempt ossiculoplasty.
That
Clearance
doesn't
of
rule
infection.
out the inflammation, future inflammation.
You are going to do
That doesn't rule out.
Hello, subtotal petrosectomy तो करने वाला है ना?
हाँ.
तो वो look after the infection ना?
Sir, how will you line the cavity then? That will invite infection.
And yet do what you want. Tell. Okay.
No, it's not what I want. This is what should be given to this patient. This is the best
See,
option. to this patient.
Satish, see, you know what happens now? I'm not criticizing Satish or anybody. See, Satish is so used to doing cochlear implant with excellent results. Dr. Morwani is not used to doing cochlear implant with the results because he's not adequate. Dr. Morwani still want to find out the situation where, if at all, I can help the hearing aid. So what
We
you're
know
fond of
Dr.
doing, you find
Morwani is the
indication.
greatest otologist on the planet.
Thank
But
you very
look
much
at
for.
the audiogram.
Then ठीक है Satish, what
We
you're
know,
doing
there
is that two
needless
ways of
to
looking
say.
at the same thing. There's nothing wrong about your opinion. Every situation can have 2-3 different ways of looking at it. So relax. Not criticizing anybody, just difference of opinion.
Who in the audience can benefit him with osteoplasty? I ask everybody, look in the audiogram, who in the world can benefit with this patient with osteoplasty? With this kind of cavity, let me show you again. We have to be practical in approach. It's not about theoretical discussion. See this. This is the cavity and this is the audiogram. What method can improve the hearing in this patient? Let anybody come forward and tell me. What method can improve the hearing in this patient with the kind of cavity, the kind of the other ear situation, and kind of the audiogram? Be practical. Which ossiculoplasty can work in this patient?
Let's get on with what you're doing. You're right.
Only concrete way to make him infection free is a subtotal petrosectomy obliteration, and I can debate it anywhere in the world for this. This is ideal indication for that.
Will you be starting
So,
now?
now coming to the CT scan, in perspective of subtotal petrosectomy for this, what all we are going to achieve with the surgery from CT scan? What information does CT scan give us for this patient? Number one, see this. The cochlea looks good. The facial now. Let us see the facial now. See the horizontal facial now looks decent over here.
Please.
And look at the facial now. And this is the facial ridge over it. Can you see?
Dr.
There is a
Sat-
lot of bone over the facial now. We have to reduce the facial ridge.
Yes, sir. Dr.
Can
Satish.
you see?
Yes, sir.
Yes.
Just, I am Dr. Bharati Mohan from Chennai. Just, and I just come in and with a lot of heated discussions, sir. Just give a simple thing about what are you going to do. That's all I want. There are two.
Petrosectomy obliteration. That's it.
Which on the right.
Make him infection free.
Right side.
I want to make him infection free. I want to prevent this further infection. So this guy doesn't develop labyrinthine ossificans on this side. That's it. That's
Right
my
side.
goal.
Right. So you are planning for the right side.
Right side.
It's
Right
already,
side. That's it.
already there seems to be some promontory erosion is on the lateral basal turn erosion. promontory erosion, there seems to be an erosion of the promontory.
Yeah, looks like.
Looks,
There may not be through and through erosion. That we'll explore.
You will
That
explore.
we'll explore.
Okay.
That's what I'm showing on CT scan. That's what the positive finding I'm sharing with you on CT scan. Number one, the
Yes.
facial nerve which is decent. Number two, this is the facial ridge which is high. See the bone
Okay.
over the facial canal.
Okay.
Number three, there are lots of cells deep to the facial nerve.
Okay.
See the facial nerve?
Yes,
See,
yes,
once
yes,
you
yes.
do a subtotal petrosectomy, you are supposed to exenterate all cellular tracts. And this CT scan points out all possible cellular tracts. That's what I'm sharing with you. So here, there are a lot of cells deep to the facial now, which
Yes.
we have to exenterate. Number two, look at the petrous apex on both sides. Fortunately, this petrous apex is full of marrow, not cells. And see, we don't need to exenterate any cells, from the petrous apex in this patient. Number three, see this all osteitis. All osteitis. Can you see the shadow of the osteitis?
Yes,
This
yes, yes.
all underlying bone is inflamed. This is the source of infection. This is, I would say, the nidus of infection in this patient. Whatsoever antibiotic, whatsoever surgery reconstruction you do is not going to work unless you remove this source of infection. All this bone is the bank of infection in this patient. Thirdly, I am just following the cellular tracts, all this. Now coming to the coronal picture. See this. This is the cochlea. This is the cochlea. What I'm seeing in the hypotympanum. Sometimes there are lots of cell tracts in the hypotympanum which are unexplored and can be a source of problem. I mentioned in a morning lecture about the subtotal petrosectomy. It is the remaining mucosa, remaining cells, which are more problem giving than the epithelium. You can visibly remove the epithelium under vision. Removal of the epithelium is 1,000 times easier than removal of the mucosa from every nook and corner of the temporal bone. And here you have to assess on CT scan where all possible sites. See this? This is the round window. This is the vestibule. And see all this labyrinthine cellular mucosa, this osteitis, this is supralabyrinthine, all osteitis, all have to be completely drilled and to give a flush cavity without any mucosa and skin, and then we will obliterate this cavity with the fat.
Is there any
As far as the cochlea is concerned, you were showing about the erosion of the cochlea. See in the coronal picture. See in the coronal picture, this cochlea looks completely intact, except one place. What I find the bone is decent. This could be only bony dehiscence, which is not going to affect much. Though I will confirm it intraoperatively, if something is extending into the cochlea.
Is there any
Something is extending into the cochlea, this would not give a bright fluid signals all the way on MRI. Had there been something extending inside the cochlea, it would not give a bright signal on cochlea of the fluid on MRI. So I'm quite sure nothing is extending to cochlea. Cochlea is very well spared, clearly spared of disease, and this source of infection outside the cochlea has to be radically, dealt with to prevent ossificans on this side. And we can certainly avoid at this stage any lumen keeper or cochlear implant or anything on this side. Yes, this has a profound hearing loss. If the patient is willing to undergo cochlear implant, this is an ideal situation. Same stage cochlear implantation can be done in this patient to rehabilitate the hearing because he has a bilateral profound loss. Left side is not reconstructible. This side is, reconstructible with a cochlear implant. This is ideal candidate for a subtotal petrosectomy and implant at the same stage because it doesn't have active flourishing infection.
What about infracochlear area?
Yes.
Infracochlear.
Yeah, infracochlear area has a lot of, mucosa.
Yeah.
I can see this is cochlea. This infracochlear area has a lot of mucosa. This is your, jugular bulb. You can see very clear. This
There's
is
a,
your carotid canal. See the carotid canal? It is pretty intact. See the carotid. This is carotid canal.
yes.
Let me show you the carotid artery coming from here.
There's a very thin bone, isn't it?
Yeah, thin bone, but it is intact. Everywhere it is intact. See the carotid artery going towards the clivus. So the carotid canal is all the way intact. See the thin bone, which is always there all around the carotid artery. It is intact. It is not dehiscent anywhere. So this is intracochlear area.
There
This
is
a
one
lot of
Sunday,
mucosa.
there is one cochlear carotid interval that should be more than 1.2, isn't it? Can you show it in your
Cochlear
data?
carotid?
Cochlear carotid
Can you
interval,
repeat your question?
bony interval, bony thickness between
Okay, if
cochlear.
it is dehiscent.
Yeah.
If it is dehiscent.
If it is not dehiscent,
If
it
the
should be more than 1.2
if the
millimeter.
cochleocarotid partition is dehiscent, you have to be careful during implantation. If this partition is dehiscent, one may pass the implant into the carotid canal accidentally. So you have to be very careful during implantation. You can take the help of fluoroscopy and push the implant under guidance to ensure that it is not going into the carotid canal. But as far as subtotal petrosectomy is concerned, you have to be little careful around the carotid artery. That's it. Anything more?
We can start, sir, surgery. And one question before that, if you plan for any cochlear implantation, there should be same kind of. There is an audiology report. There is an audiology report. We have to do a hearing aid trial, and the results has to be there. If you consider anything.
Hearing aid trial on this patient.
If you plan anything.
How will you give hearing aid trial to this patient?
Can a bone conduction?
How can one give hearing aid?
Bone conduction.
I want to know how will you give hearing aid trial to this patient with a cavity?
Still bone
With that
conduction.
cavity.
Hearing aids are there now.
With this kind of audiogram, profound hearing loss.
Yes.
With this kind of osteitis and inflammation going on, what do you think the hearing will remain as such if you don't treat it radically?
Well, the only concern was there was a airborne gap. No, that's what. The both are. If both air conduction, bone conduction.
Look at the bone conduction, which has gone. Try to understand, if you don't arrest this inflammation, this infection effectively, whatever residual, whatever you expect, suppose you are right, there could be some residual hearing. If you don't arrest this infection, if you don't do something concrete, this is going to take away everything like the way it has already taken away. So the first goal, try to understand, we should not deviate from our aim. First goal is to make him infection free. Otherwise, this ongoing infection will take away whatever residual hearing you think of. So we should not deviate.
Point taken. Point taken. You can, sir.
Sir, we can start the case.
This side is a better microscope.
Cameraman can focus on the CT scan.
I expected you. They gave only today.
Hello?
Sir.
Yes, sir.
We are with you.
Hello, can you hear me, Pakana?
Yes, sir. We can.
So let me show you what has been done. This case was started, the post-oral incision was given. Still the cul-de-sac closure is not done as I wanted to show you, because cul-de-sac closure after a myoplasty is obviously difficult, and you have to do something more to give a good cul-de-sac closure. For those who think of doing osteoplasty in such a bad, rotten year, I will call it like this. This is such a rotten situation. Any osteoplasty, for any osteoplasty to be optimally effective, there has to be a good dry middle ear along with a functioning eustachian tube. Whatsoever osteoplasty you do, without a good middle ear, aerated middle ear, without a good eustachian tube function, cannot last. You do 100 times, it cannot work. So the primary thing which is required for osteoplasty to be functional is the aeration, aeration, aeration. And nobody can guarantee the optimum executive function in this case, at this stage. Who is, because of the ongoing inflammation, at the verge of developing labyrinthine ossificans on the other side as well, which would be a disaster if we keep waiting.
Satish sir, does this
and do
microscope
not do anything
white
concrete for
balancing?
the infection.
Sir,
Pardon?
microscope might need white balancing.
Okay, white balance, no, there is no option, huh? मना किया था उन्होंने. So there is no white balance option, we told in
Okay,
the
okay, sir. Too
morning
much of
as
red
well.
there.
Yeah. Can we take other microscope?
Sir, with the same post-oral incision, we can do.
Anyway, meantime, if they arrange other microscope, let me show you. I had a discussion with Dr. Hetal regarding the, cul-de-sac closure in such challenging patients with myotoplasty. You have to go in the same way like do in a primary patient. See this. First of all,
Yes, sir.
I am removing this inflamed tissue. See the underlying skin of the canal?
Yes, sir.
We have to bring out this skin of the canal circumferentially. This is a very, very important step in this surgery. See, the sleeve of the skin is being elevated of the cartilage. फाड़ देगा गुरु. See the tear. See the sleeve of the skin, a small buttonhole, doesn't matter. See, I am separating from the tragal cartilage. Can you see? This is tragal cartilage, this is conchal cartilage. Can you see both?
Yes.
And that is a very useful, these cartilages we can use for a second layer. So this skin is elevated of the cartilage. You can pull this skin out. Can you see this? Scissors. And put another stitch for the buttonhole. I told you we had a buttonhole. Doesn't matter, you can overcome that. This is inflamed margin which I am excising until we have a healthy margin. Yes. Give me suture. See, I pulled the canal out. थोड़ा दूर से पकड़ो. Everted the canal and using absorbable suture. So you don't need to remove the suture. Removal of the suture sometimes can be problem inviting.
Is Hetal there in the auditorium?
Oh, yes, ma'am. Yes, yes, she's there.
Hetal, let me know any concerns after completing this cul-de-sac closure. You had a question, so that's why.
Welcome,
And that is a
Dr.
valid question.
Patel.
I know doing this cul-de-sac closure after myoplasty is a challenge. Though this is a straightforward situation, not a challenging one, I tell you. In challenging one, you don't get any tissue around, and then you have to derive a flap from the flap from surroundings. So I will tell you what flaps can be taken to reinforce this suturing in case you don't have any other tissue. The evert, bring the skin out so it doesn't ingrow. That is important.
Dr. Satish, will you also undermine the edges where the buttonhole has occurred? You will detach it from the
Yeah,
cut,
I will.
or you will be able to just close it.
I'll just put an extra stitch, that's it.
Okay.
Because I will make another layer reinforcing this closure underneath. I will show you.
Yeah.
Always we do a second layer. The skin is friable that led to buttonholing.
Yeah. No, it is always a
Primary cul-de-sac closure are so straightforward.
Here, though, only one surgery is done. There are cases where 3-4 times surgery is done.
ये करना, इधर दिखाओ. This is the buttonhole.
Yeah.
So we'll address this with the additional layer underneath. We'll show you. See this buttonhole is closed. Can you see?
Yeah.
And another one behind.
See, you can appreciate that he has kept one stitch long so that he can give a retraction.
Yeah, that is very important. You have to keep everything pulled out so everything remains everted. Skin should not ingrow. See now, this canal is everted.
Yes.
And I always keep it pushed inside so it gives you a feeling of a canal from outside. Now see the inside picture. Can you see?
Yes.
Now we'll give reinforcement with another layer. So it doesn't break and ingrow the outer layer. Can you see this
Cartilage?
tragal cartilage?
Yeah.
This is tragal cartilage. See what I'm doing. This is the best reinforcement for everybody. Simplest way. Your cul-de-sac will never break. We have done hundreds and hundreds. See, I am releasing this tragal cartilage. And see, I will close this box forever by suturing this tragal to conchal cartilage. Can you see now?
Yeah.
नीचे दा हाथ लगा. See now. Now, give me your verdict. See the canal which I am burying from both sides. With this tragal to conchal cartilage suturing, this is the best of the reinforcement one can think of to the cul-de-sac. This is the second layer reinforcement. To the cul-de-sac closer, tragal to conchal cartilage. Hetal,
Yeah.
are you happy with the cul-de-sac now?
Yeah. Very happy.
Give your verdict. Can this cul-de-sac closure ever break? This is so solid now. The outside and inside layers have been. I'll put one or two more sutures. See this? What a solid reinforcement from below. Hetal?
Yeah. You will bury the cartilage?
No.
Yeah,
Cartilage is not, anywhere exposed to the, infected area will obliterate the entire cavity.
Yeah.
See, this second layer is very, very important for the cul-de-sac. Now your skin, can the skin ingrow now?
No.
No way.
More than ingrowing, also the closure cannot give way.
It cannot give way. That's why I always emphasize your cul-de-sac should be solid. If this cul-de-sac gives way, your subtotal petrosectomy is ruined.
बाजू का है.
That's it. चलो इसको यूं कर दो. Now, Hetal, in case, because of the previous multiple mastoid surgeries and meatoplasty, had we not been having this cartilage even, what would we do as a second layer? I have many options. I would rotate a sleeve of temporalis muscle and suture over it completely through and through from underside. Okay?
Okay.
Or I could have elevated the temporoparietal fascian, covered from inside thoroughly, everything. So you have many vascular tissues around the ear to serve this purpose. Okay?
Yeah.
वो दे, monopolar there. Now, in this surgery, you have to exenterate all mucosa and
Epithelium.
epithelium. See now, at the lateral end, this is very important, where one is likely to leave the epithelium behind. See, this is the canal cartilage. And I am using monopolar. Monopolar is like deadly to the, I don't want to leave any possibility of any micro epithelium filament left behind. This is like burning everything at the lateral end, which is very, very safe zone. But see, at this lateral end, no skin is supposed to be left at this edge of the canal cut. This is very important. If you're not careful and if you leave even a cleave of skin, is a disaster. That can grow to a bigger cholesteatoma. So this has to be thoroughly. This is what I'm doing at the lateral end. Thorough. Here is thorough. At the lateral end, thorough cautery. Burning any possible skin at the lateral end to be staying over safe. That's it. At the just immediately lateral to the canal edge. No skin is left behind. Lateral to it. That's it. Wonderful. Very awesome layer. This is the tip area. And there are, I mentioned yesterday, the layers of muscles attached on the mastoid tip. Layers of muscles attached on the mastoid tip, which I am separating and making the tip skeletonized. This is zygomatic root. And this is the anterior canal. So we can define our limits all around. Retractor there. Conical burr.
Satish, we are out of field.
Yeah. Just a minute, putting up the retractors.
Yeah.
Anybody, any doubts about this procedure? Believe me, I want from my heart for everybody to understand this if you are not doing and can use this procedure in your practice for many indications. This is simply amazing. Feel free to interrupt me at any point of time. Conical. Conical they were. Give me conical burr. So this is the initial exposure. My cul-de-sac is very well secure. The cortex, the outside lateral part of the temporal bone is fully exposed. जब तक ये दे. See until he देना यार. Yes. Drill किधर है? Veneer. So this is now the initial ये क्या उल्टा है क्या? हाँ करिए। अरे यार यो वो भाई 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 ये तो बंद नहीं किया हुआ क्या? करो। ओके। अरे यार no, this is not fitting. See, this is osteotic bone. Can you see this?
Yeah.
Can you appreciate this osteotic bone?
Yes.
Look at the osteotic bone. ये bar इसमें fit नहीं
Is it a sigmoid?
No, no. This is not sigmoid. पानी ऊपर डालो आ जाओ You know what is osteotic bone? Can you appreciate?
Yeah.
This is depot of infection. See this? No antibiotic can control this infection. Now I am reaching toward the sinus. One doll, one doll. See, all this is osteotic bone, bad bone. This is osteotic bone. You can see the change.
Yeah.
See this?
Satish? Satish?
Yes, please.
Hi, Dr. Hakim
Yeah.
here. I just want you to know that in a case like
Yes,
this,
madam.
so bad, is there anything that will help you to find landmarks?
Pardon?
How do you find the landmarks in an infected bad case like this?
Yeah, sometimes very challenge, but I am using the, traditional landmarks. I am
Right.
using the sinus plates. Can you see the change of colors?
Yeah.
Can you see the sinus
Correct.
plate?
Yes.
This terminology, I have, in the beginning, Mohavani sir would always tell, change of colors,
Right.
play of colors, you should be able to know to prevent complications.
Yeah.
See the dural plate, sinus plate.
Yes, you're coming to that now. There.
Yes, the change of colors.
Yeah.
And this all bone was bad bone.
Yeah, I can see that.
No antibiotic can penetrate into it to cure this infection. So that's why I'm again and again emphasizing, you have to do something concrete to this patient to prevent labyrinthine ossificans on this side. No conservative method would clear this infection. You have to bring in the new bone. All osteitis. This osteitis we saw on CT scan as well.
It's a surgery. Really fantastic.
All this is osteitis. And this is my favorite drill bit to deal with such situation. Faster, robust. Anterior wall bone all around until you reach the new bone, other clear bone. You have to eradicate this. Now give me bipolar. See the surrounding bone?
Yeah.
There. See the entire temporal bone is affected by osteitis. The
Satish.
CT was grossly showing the osteitis.
When you're doing canal wall down technique, you must get rid of each and every cell, which a lot of people don't believe in at all. This is how the bone works. So your bone should be milky white at the end of the day. And your cavity should be smooth and circular, not kidney-shaped cavity. He's going to
I
operate it.
remember, sir, in your courses of temporal bone dissection, you would give candidate 3 days to dissect it.
Yeah. We do for 3 days. Of course, we give a lot of lectures and all that also.
People think that a temporal bone dissection can be done in 3 hours.
That Satish Jain can do it, not the juniors, yeah. Yeah, but Satish, we done 5 courses this year, and we're going to do 3 more courses.
Opening legs. See the underlying bones?
Yeah, yeah.
Can you see the difference between the normal bone and the osteitis bone now?
Yeah, yeah. Very clearly.
Bipolar. I'll take you back to the CT scan and show you again the difference between the normal bone and the osteitis bone. It's so obvious. See, skin mucosa, you can bipolarize and remove it thoroughly. Circular.
Once you want to obliterate the cavity, get rid of all the mucosa, all the epithelium from the external canal, from the drum, from the promontory, part of the eustachian tube also strip it out. Make it, no mucosa should be left anywhere.
See this epithelium. There is lateral canal fistula.
Yeah.
I was in doubt and see it is. See that blue lining?
Yes. Scan. Where it is
Like blue line के पीछे fistula है ना?
Sir, blue lining. ये blue lining है ये.
Ah, there's a
The
fistula.
outside is the bone.
The bone is so eroded
Yeah.
all around. You see?
Yeah, bone is eroded.
And you can
And
see
this is the facial nerve.
and there's a bit of sheet is damaged. That's why it's popping it out.
See, I'm elevating the skin from the retrotympanum grossly. We'll do fine work later. I separated from the facial nerve here. This is the facial nerve. This is the facial nerve.
Don't do the
This
separate
dehiscence, which I
professional
was-
the way Satish did it. You have to take
I
your
was
own time.
expecting this dehiscent facial nerve.
He is too good. So
Pardon,
he's
sir?
too fast. Okay. Now there's a dehiscent facial nerve over there. And there's no sheet on it. So you have to be cautious. Don't go at his speed.
Yeah, this
You
is
can-
dehiscent. It is dehiscent here.
Yeah. See, there are two things. Can you make out there's a dehiscent and there's sheet is damaged? That also you can make out.
See, I have removed this gross bad tissue. There is a lot of fine work required to be done.
Get rid of all
This
the
is
tip-
gross work.
जो भी म्यूकोजा पड़ा है ना अभी भी आगे पड़ा है बहुत म्यूकोजा.
Yeah, everything, everything. I will remove everything, not leave anything.
If you want, you can use a diamond burr. You can use a
give me
copy
that.
it, you get rid of everything. If you want to do obliteration. No. He is going to do obliteration now. And once everything settles down, then he want to do implant it. You can't do implant when patient is infected.
Because the opposite side is completely out there.
See, I told you on CT scan, there's a lot of osteotic bone above the fallopian canal. Can you see?
Yeah.
I am removing this bone from lateral to the fallopian canal. So now I am skeletonizing the fallopian canal here.
What Satish is doing with the cutting burr, junior boys are going to do diamond burr. This area where he went anteriorly.
I am using with utmost care not to use any pressure. See what I am removing now, I mentioned yesterday in dissection as well. I am removing this tympanic bone to marsupialize the hypotympanum to the cavity.
Not only tympanic bone, you drill the floor of the canal also. The tympanic bone is a part of floor of canal is the tympanic bone only anyway.
Yes. During canal down mastectomy, if you don't drill this part of the hypotympanic floor, your hypotympanum doesn't drain into the cavity and it's a
Satish, I'm
problem-giving cavity then.
some information. What kidney-shaped cavities are shown in Scott Brown are rubbish. That's not cavity cannot be kidney-shaped at all. It has to be smooth circular cavity. Drill the floor of the canal to meet the floor of the mastoid. And the mastoid tip is too low down. Exercise the mastoid tip. Obliterate that area. The
right.
whole cavity has to be smooth
That's
and
why
circular. Smooth and
this tympanic bone has to go. Diamond. What sir is saying is drilling of this tympanic bone to flush the floor of the canal with the floor of the cavity. This is exactly what I'm doing. What sir is saying is a very, very important part. Now, anybody, this is a theoretical question I have mentioned.
Can you leave the cholesteatoma behind? I would like your verdict at the end of the surgery. With this exposure, can anybody leave the epithelium behind?
Forget about
It is
epithelium.
not the epithelium,
Cavity,
it
you
is the
don't.
mucosa which is a problem.
This is important. Not even mucosa. Forget about epithelium. Epithelium is like malignant tissue.
Yes. See the facial now, fallopian canal.
उनको दिखा किधर डाइसेंट है किधर शीट नहीं है दिखा दोनों चीज
या ये डाइसेंट अभी दिखाऊंगा मैं. See the fallopian canal I am skeletonizing. And now what I am doing, anterior thinning of the canal to uncover the retrotympanum.
this is
See, this is my fallopian canal.
tympanic recess.
The fistula.
Yeah, see now I am filling the bone anterior to the facial now.
Yeah.
Uncovering the retrotympanum. This is very important.
Because there will be some mucosa there.
Deep to facial now. Deep to facial now. My facial now I have skeletonized.
This is the fistula. And facial is here.
Hello, Satish.
Is there a promontory fistula?
Yeah, promontory fistula as well?
Yeah, I will have a look at it. I have not seen thoroughly. I can see the glimpse of that. The endosteum looks like endosteum. Let me thoroughly assess that and I'll.
Yeah, look.
Yeah,
This
because
is the
we
blue
can
lining
see
of
blue
the
lining.
fistula.
Yeah.
Can you see the facial now?
Yeah.
Yes, Satish.
Decent facial now. That I could make out on CT scan as well.
Hello, Satish. Dr. Belsare here. Gauri.
Doctor?
Gauri Belsare.
Gauri.
Yes.
See now how I'm dealing the retrotympanum now with the drill. See this? Keeping the facial now at the edge. And there is the dehiscence, a small area of dehiscence on the
Promontory.
promontory you can see now. In any crevices, if you are not able to remove the mucosa, you are not able to ensure complete removal, you can make the mucosa dysfunctional. Devitalize the mucosa by means of bipolar. See this?
Is there the oval window area opened up?
Yeah, oval window. I cauterize the foot plate completely. I cauterize the stapes if there are suprastructure. See this? The mucosa is completely devitalized in the retrotympanum. Can you see?
Yeah.
This is my round window area. This is the promontory which is thinned out, not through and through.
See when
See
the
the supralabyrinthine area completely cleared off.
Satish, when there's a fistula on the cochlea, that case is mostly Cox. Cholestoma does not do so much of it.
And fistula is different thing. Dehiscence is different thing.
Letters of the canal is different
This
thing.
is just dehiscence.
This is not a fistula.
This is just
When you get
dehiscence.
when you get a typical fistula of the cochlea, the way vestibule fistula, that is Cox. Whether histopathological it comes positive or negative, I will give at least nothing, and if not anti-Cox, I'll give them a Ciplox for 3 to 6 months. And if
We
you
are
get a
removing this hypotympanic
the bone
ledge.
lying in this, there's a Cox. Of course, not very common in pathology, but wherever you may see, you must remember this.
Now the anterior wall. This is the region of the tensor tympani. See the cochlea completely denuded. Now see a lot of mucosa, and that is the key area. I will ensure complete removal of the peritubal and pericarotid cells. Will skeletonize will not leave the cells there. If you leave those cells behind, that remains the source of problem. Even if you obliterate the eustachian tube, they can open distant into the distal part of the bony tube and can become a source of problem again and again. Now,
We got one branch. It is a mucosal disease.
TM elevator, patla section. See the cavity coming in the shape?
Bony, milky, white cavity. This is what it should be. Even canal
Still
wall.
a lot of work is left. Still a lot of work is left behind towards the anterior part. This is my round window zone. See all these mucosa which I burnt.
Satish,
What your bone is coming out easily is osteotic bone.
See this, all this is bad. My round window is, see this is oval window, this is promontory, this is the, overhang, the round window overhang. And this is round window, forceps. I will drill this round window niche. After this exposure, imagine how easy the cochlear implant is. So in any given situation, I mentioned in the morning lecture, any given anatomical distortion, difficulty, challenge. Anatomical means anatomy of the facial nerve, anatomy of the semicircular canal, anatomy of the inner ear, anatomy of the jugular bulb, carotid, any anatomical abnormality, the savior is subtotal petrosectomy.
There's still
Let
few
me
cells
show you the
anterior
round
inferiorly.
window.
There are few cells anterior inferiorly. still.
This
This is
a lot of anterior work
these
is
are
left behind.
infracochlear
I
cells.
will remove the
These are
I will remove
infracochlear
the
cells.
complete bony eustachian tube laterally. Let me show you the round window properly after removing the round window niche. Having completely, done the subtotal petrosectomy, after that, conch or patla. Cochlear implantation is the cakewalk. Just open the round window and push your implant. That's it. Look at the exposure, what we are achieving. So no question regarding epithelium leaving behind. That's a theoretical question. After this kind of a one cannot, leave the epithelium behind. The challenge is the mucosa.
Satish, show us a facial no anatomy properly.
Yeah, I will, sir.
You finish your cochlear part, just
Definitely.
round window.
Yeah. Let me drill this round window niche
Yeah.
to show you the proper round window.
So he's drilling
There
the
are
film of the round window.
9 varieties of round window Proctor has described. 9 means absolutely different from each other, having enormous clinical significance. And this was described by Bruce Proctor 70 years back. If anybody is interested in knowing the temporal bone anatomy in detail, in depth, go to the Bruce Proctor's book. Sickle, go the right angle. Bruce Proctor is one who extensively described the anatomy and the variations of anatomy of the temporal bone in depth. See the round window membrane, can you?
Yeah. Can you give some hydrocortisone wash?
No, I am outside. I am not going inside. Just showing the membrane. See this. This is round window membrane.
Yeah.
I am removing this all mucosa. See this?
Now you can see the membrane much better. Once the mucosa stripped. Yeah. What looks like a blue line is a membrane.
Take size body dev. Bar.
And this is
See, the challenge in removal of the mucosa. See this? Hypotympanic cells.
Dr. Satish,
Yes, please.
if we had to do cochlear implantation or put electrode in this round window, will that blue
simple.
lining of the cochlea in the around middle turn will be
That is
significant?
not going to affect.
Will that affect?
That happened because of the infection. Now we are treating the infection radically. There will not be any infection.
No, but because of the thinning, will there will be any problem with the electrodes?
No, 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 no.
Patient can get possibility.
No way.
He has to put a bone cement. Because there's a labyrinthine. Very thin.
My question is, if later on we put cochlear implant in this case, because of the bone thinning and because of dehiscence of facial nerve, will it give rise to facial twitches or stimulation? Is there a possibility?
Facial nerve is outside the cochlea. Our electrodes are not stimulating outside the cochlea. Ready?
Yes.
Electrodes are going to be inside the cochlea. Only the cable will remain outside.
Right.
So forget about this facial nerve stimulation. Facial nerve stimulation is a problem when inside the cochlea where the electrodes are, in the descending portion of the basal turn of the cochlea, where the labyrinthine portion is in closest proximity. There, if the bone is dehiscent, can lead to stimulation. This outside here, there will be no electrodes at all.
I know, but the bone which
See
is...
how the round window niche is completely cleared off. Can you see?
Yeah.
So for future, anybody wants to implant now or anytime ever, after the obliteration, remove the fat, go here, open an implant and come out in 10 minutes. That's it. See how difficult was to remove the mucosa from the niche. And see this hypotympanic region. Thoroughly study the CT scan to know the cellular tracts and then follow them.
They want to know the relation to the ICA.
I will show you ICA.
Take the all. See, remember one thing. Wherever there are cells, there's no important structure. As simple as that. Whether you're on a fallopian canal, whether you're on tegment plate, whether you're sigmoid. Moment the cell population disappear, the important structure are going to come. For example, these cells, if it takes away, you will see the ICA canal.
I will show you ICA proper. ICA is in my field now. I told you, I will remove all pericarotid and peritubal cells. That's a very important part of this surgery. Because of the fear, whoever is doing subtotal petrosectomy, if that part is not removed, it's utter failure.
Yeah.
Microscope.
The bone, moment the bone in this area becomes smooth like this, then you know you have come close to the carotid canal.
See, I have skeletonized the jugular bulb region. Can you see no more cells now in the hypotympanum? Completely skeletonized. Can you see?
सतीश, तेरे को याद है तेरे
Yes,
यहाँ
sir.
15 बरस पहले एक अपन वो पेट्रोसेप्टेक्सिस किया था मैंने
इंफ्राकॉक्लियर आपने किया था इधर
Cochlear
लोकल एनेस्थीसिया में
anesthesia.
under
Under
local anesthesia.
we diagnosed the patient at 5:30. We
Can you
confirmed
see the skeletonized carotid canal?
8:30 she was operated. Next day morning she was woke.
Everybody, can you see the carotid canal which is skeletonized? Gauri, Ethel,
Yeah.
this is carotid canal. Can you see? Change in color. Yes or no?
Yes, yes, yes.
Now, this is the eustachian tube, the biggest problem.
The mucosa was the
Biggest source of infection. Biggest source of infection, and how to deal with it? Widen it laterally. Remove the bone thoroughly from the lateral aspect. Widen it.
You can put the drill inside also without pressure.
See, my carotid is in my floor of the drilling. Under
Yeah.
vision. This is a very important part of this surgery to deal with the cells in this region. Pericarotid and peritubal cells are important to dealt with effectively. All this is mucosa.
You can put a cautery also inside. There's no harm in putting a cautery and buzzing on everything.
A lot of work is, a lot of mucosa
And
is there.
see, in this, sometimes your bipolar cautery may not go it. You can do indirectly low current unipolar cautery. Put a ball probe and least current damage this. Okay.
Can you see all this mucosa? I am
Test karna.
skeletonizing.
Cautery machine is different setting. Minimal current, which is good enough.
Team elevator. Pitega.
Status होला पाहिजे. When you do subtotal, see, this is a carotid canal. Under
Can you
this
see the eustachian tube mucosa and the carotid artery underneath?
carotid.
Yes, we can see it very clearly.
Getting clearer and clearer.
See how much of the cells and mucosa are there. Bunch of.
You should remove this bone also. This is osteotic.
See the carotid canal in the middle of the shield. This is all carotid canal.
Yes, sir.
Drill.
These are still cells here. Come out, but he's trying to remove the mucosa of the station.
I am completely eliminating the lateral part of the eustachian tube. These are pericarotid cells.
Osteomyelitis disease goes along the eustachian tube, sometimes goes inferior to eustachian tube, sometimes goes to the chorda tympani. So skull-based osteomyelitis, which people think surgery is not a treatment, any osteomyelitis should be ideally treated with antibiotics. Whatever osteomyelitis, anyway. So if doesn't respond due course or the symptom gets worse, then the surgery comes into picture. What is surgery? Debridement. Whenever there is osteomyelitis, any part of bone, what do? You're just curating the disease out.
Now I am working anterior to the carotid artery in the eustachian tube.
कोई
What
अच्छी
is
लग
eustachian tube? See this?
नहीं जब
See,
भी
my
तक
carotid is now in the middle of the field and I am working anterior to it.
every cell, there's no limit. The disease decides the limit.
Hello, Satish. Can you point out
Yeah.
the chorda canal?
If wherever disease can take you, go as far as possible.
Chorda.
Chorda
No, we
canal.
don't go, I never got
Canal
that far.
for,
Where is Koida now?
no,
Koida,
chorda,
all gone.
the canal.
Where is Koida now?
हाँ वही था.
What a tympani. Can you see the bony eustachian tube better now? Can you see the bony eustachian tube better now?
Yes,
Hello?
yes, yes, yes.
See, my carotid is here and I have gone more than 1 centimeter anterior to it. This is cartilaginous eustachian tube now.
Wow.
Which I am going to obliterate along with the bony. Hear this. Drill.
Tensor tympani.
Anybody? Can you see any mucosa here?
हा. पण मग कॉर्डाचा कुठे असेल कॅनल त्याच्यात म्हणजे आता नाही दिसणार.
आता नाही दिसणार, काटा तर कुठे एंटर झाले.
पण त्याच्या वर असणार ना ते जे टेन्सरचा आहे त्याच्या सुपिरियरली असणार ना.
पण ते tunnel is so small.
You have to ensure each and every mucosa to be thoroughly eradicated around the eustachian tube, carotid artery. If any doubt of the mucosa, you devitalize with the bipolar. This is my work on the peritubal and pericarotid cells. And this is cartilaginous tube, no more bony tube. Carotid, pericarotid region, everything under vision. I have gone more than 1 centimeter anterior to it. Is that clear to everybody?
Yes, Satish, when you are drilling around the peritubal area, finding out the cartilaginous part of eustachian tube, is that the end point of the dissection?
Yeah, that is the end point. Exactly. See that? Which is, I'm closing. See, what I'm doing. I'm closing the cartilaginous eustachian tube by bipolar. And now I will obliterate. No mucosa here, all around, anywhere. I always reiterate the same thing. Remove the cells from the temporal bone. Anybody has any doubts? Please come forward. Diamond. This is complete subtotal petrosectomy. Diamond.
Satish, really beautifully done, huh? Can you hear a round of applause?
Satish, your flight at 5 o'clock. Satish?
Mubarak ne kill kar diya. I am going midnight flight now.
Okay, ठीक है, because 3:30 बज रहे थे अभी.
No, he wants me to do a glomus case also. He has posted.
वो कभी कर रहे हैं?
इसके बाद.
Must be staying overnight.
हाँ तो मैं थोड़ा सो के आ जाता हूँ.
This is my subtotal petrosectomy. Anybody has any question, doubts? And now we'll start obliterating it. Everything is skeletonized. You have to.
How are you going to obliterate?
Yes, obliteration is simple, boss. Yeah, bharna hi to hai.
No,
I will obliterate my.
Obliterated, you have
I
to
will
do.
show you. I will show you, sir.
Fat.
I mean to say, I will show you.
Section
First,
muscle.
I will obliterate the eustachian tube with the muscle. What's up there?
See, now this cavity is as good as not infected at all. So whether you use a fat or a muscle.
Now, what we have achieved with this, once we obliterate, our option for the cochlear implant is always viable. Now or even in the future, we can do implant in 1 minute. Just open it and do the implant. If we are not able to do right now because of the other constraints, ye kya hai? Huh? If you are not able to do right now, obliterate and you can come back later on any point of time.
Camera picture of Dr. Satish Jain. This is the other OT picture we are getting. Someone is trying to do tympanoplasty, I think.
If we can have a better focus.
How much look at उसको time लगेगा?
कंट्रोल कर लेना गुरु। This is one thing. I preferentially block the eustachian tube with a muscle because this invites a good fibrosis and which I want forever. Cavity, we don't want too much of fibrosis. The fat doesn't adhere too much all around, doesn't give that kind of fibrosis. And in any given situation, if you want to go back, just elevate the fat, put the implant or do anything and come back.
Satish, will you be putting a depth gauge?
Not required. Hetal, this
Yeah.
patient will not have any infection, number one. I
Uh,
don't think after this much of, you know.
Okay.
Secondly, more importantly, in any, future requirement, just follow with the MRI. In case required, just remove the fat and put an implant. That's it. This is eustachian tube region. I purposely block it separately. Rest is round window region and rest of the cavity fat. Fat doesn't adhere to the surrounding like the muscle. We want a thick fibrosis here for the eustachian tube, not anywhere in around the other areas of the temporal bone.
Is it possible for you to put a small sheet of silastic near the round window?
No need. Fat will not obliterate that area. I mean,
No, not
will
obliterate.
not make identification difficult in future.
Okay.
So we are just in 5 minutes, you can go to Mubarak. We are just harvesting the fat and then I'll come back to show you the final obliteration. It won't take more than 2 minutes.
Dr. Satish,
We
and
have
you
already done cul-de-sac.
fistula also, no? Labyrinth and fistula?
Huh?
You'll be closing the labyrinth and fistula also, no?
It is not fistula, it is blue lining. Why are you calling fistula? It is just blue lining, dehiscent. It is not through and through.
Okay.
Doesn't need anything.
Even on the lateral semicircular canal?
Yeah, it is blue lining.
Okay.
Fistula means by definition, it
Endoscopic.
opens on either side in cavity. Should be through and through on both surfaces, which is not in this case. This was the ideal situation to do the implant at the same stage. So for all the chronic years, difficult year, bad discharging cavities, operated multiple times, profound loss, this technique gives you opportunity to rehabilitate with the hearing like a normal ear. This is simply amazing.
Hello. Can we go to Dr. Khan's OT? We can see the other OT then. Hello. It's the other one. Because he's not doing anything now. Hello. Can we go back to Dr. Khan's OT? Make it bigger.
जल्दी ले यार रमेश वहां भी मंगा लिया ना
Nobody is listening.
Hello.
Hello.
Can you? Hey, चालू करो इसको
इसके बाद में.
Hello.
Thank you.
Yeah.
We can see, yeah. Yes,
Hello?
Dr. Khan.
इसका आवाज. Yeah, can you hear me?
Yeah, we can hear you.
Hello.
We can hear you.
Yeah, okay. So this is a pediatric. Yes, this is the pediatric cholesteatoma. Patient's age is 8-year-old. You can see the middle ear picture. There is malleus is completely ballpoint. Malleus is completely retracted. There is a polypoidal mucosa on promontory, and then there is a polyp coming from the anterior isthmus, and the posterior isthmus incus has gone.
Stapes might be there. I don't know because it's completely the polyp is surrounding the stapes. Tough situation there to take out, free the stapes from there. And pediatric cholesteatomas are aggressive. I have already taken a mini end oral incision. I have harvested the tragal cartilage. I have harvested the temporalis fascia too.
Okay.
So the plan is.
Sir, can we have the pure tone audiogram findings and the nasal endoscopy findings?
Yes.
And if you have a CT also.
Residents?
And the CT.
CT scan also.
Yes. Residents. So the plan is to go end orally, mini end orally, and endoscopic inside out, mastectomy, and then ossiculoplasty. Let's see. Section please. अरे section को धक्का लगा रहे आप. बंद हो गया वो. No, बंद हो गया उधर से बटन. नहीं लाइट उसका उधर किधर से बंद हो गया. हाँ
मुझे करना ही है सबने भेज दिया.
बुलाओ उसको. कौन लगा के दे मेरे को इधर.
कौन सा कैमरा यूज कर रहे हैं? मैं कैमरा कौन करता मैं माइक्रोस्कोप से करता हूँ.
Sir.
Bilateral disease.
Yeah, other side also.
Bilateral disease.
Sir. The audiogram?
Can anybody present the case?
No hearing loss.
8-year-old child.
The loss is not much.
So hearing loss is minimal.
Once again,
Audiogram is showing left side mild conductive
looks
hearing loss.
minimal, but
Bilateral mild conductive.
aticoantrostomy will be needed because it's completely blocked and the patient is having the discharge since 4 years. Child is 8-year-old. So if it is only a polyp in the attic and antrum, better. Yeah. Yeah. Yes, please go ahead.
Go back to the CT image.
512 is negative bilaterally.
CT image, please.
The endoscope is showing bilateral grade 4 pars tensor retraction. On the right side, we could see the eustachian tube opening and attic retraction.
धीरे से बात करो.
Discharge in the hypotympanum.
Huh?
On pure tone audiogram, showing bilateral mild conductive hearing
काय
loss.
प्लॉट व्हायला तुम्ही घेतलंय का हे?
But 512 is negative both the sides.
CT is not very contributed. Not understood.
Section. Xylocaine adrenaline pack. थोड़ा सा ब्लड प्रेशर कितना है? हाँ, पल्स थोड़ा ज्यादा है. So reduce the pulse because exactly that's what it is, because it's reflecting here. Yeah, no problem. So I applied the 2x2 and inside out. Area of interest is this McEwan's triangle, spine of Henle. I will harvest some bone paste before going for the inside out.
whether you use it, not use it, but keep it ready.
Okay. Dr. Mubarak, color is little vivid. Can it be adjusted?
Can it be adjusted? Oh, they are, it's something different color. थोड़ा सा वो white balance के ना हाँ बाकीचं स्क्रीनचं आउटपुट घेतले त्यांनी कॅमेराचं घेतलंय आउटपुट कुठलं घेतलेलं आहे नाही पण कॅमेरामधून घेतलंय कुठनं घेतलंय कॅमेऱ्यातनं घेतलंय ठीक just some flash. अजून काही ऑफ करायचंय बघा त्याच्यातलं हा करू थोडं ते स्क्रीन तो हाफ ऑफ करतो ना ऐसा ऑडिओ से
Okay, okay.
Hello.
Okay, okay.
Yes.
Yeah, yeah.
Hello.
Hello.
Yes, yes, sir.
We can hear you.
Hear me?
Yeah, we can hear you.
Are you getting the picture?
Yeah, yeah.
Yeah.
Pachari boss.
Sir, where did you harvest the
Hello?
fat from? Where did you get the fat from? Is
Fat?
it from the abdomen? The fat?
Thigh.
Thigh.
Yes.
Okay. Thigh.
Below the umbilicus, but the amount you get in thigh is much more easier also. Much easier. You can get the partial out also from there. The same sitting if you want.
It's easy to reflect the flat.
Simply obliterating the cavities in all surroundings, corners.
That's what I was saying. I asked you the same.
No. And see, this is the final.
No.
Other. This will obliterate everything from outside. Can you see now?
Yes.
Yeah.
Yes.
And we'll suture it. That's it. So this will press upon everything to keep in place other suture. Thank you very much for your attention.
Thank you,
You
sir.
can still take any questions if anybody has in mind.
Okay. I think you could hear the applause here. Yeah. Great case.
Thank you.
Satish, thank you very much. Excellent.
Thank you, Hetal.
Can we go to the next roti? Dr. Khan's roti, can we go to the next roti?
Long press. Long press. नाही तू वरचं नका दाव इकडे वरचं दाव हे दाबूच नका खालचं
long press.
long press. आता डाऊन एरो ते खाली ह्याला जाईल व्हिडिओ फॉर्मॅटला जाईल डाऊन एरो परत ते डाऊन किंवा खालचं इकडचं दाबा हे दाबा आता ते व्हिडिओ
I think brightness and rate control needs to be less. कम करना है. Low करना है, low.
आता परत इकडचं डाऊन एरो
सर रेड कंट्रोल है ना मीडियम से यू मेक इट लो वीडियो फॉर्मेट इज 3G SDI that is an output it's an output from the this thing which is SDI There are different types of outputs. Sir, red control.
डाउन एरो के वहां पे
Up. Some more.
परत एकदा परत एकदा परत एकदा परत एकदा परत एकदा हा आणि आता एंटर
Okay, let's. White balance. Monday. आप नहीं.
Sir ji.
कल.
3 mm और
सपना मैडम को फोन करो. बीच में ये करते वक्त एक कुछ तो फिनिश करने के लिए बताओ, एक ओरेशन आधा घंटा में जो मम ड्रिल करने के लिए मेरे को फोन करत लगन. झालं का व्हाइट बॅलन्स?
Hello. Hello. Hello, sir. Khan, sir.
Hello.
Yes, sir. We'll take
Hello.
Can you hear me, sir?
Hello. Yes, Dr. Parab, can you hear me?
Yes, sir. Loud and clear.
I think while harvesting the bone paste, I will take half an hour. You can finish one oration till that time.
Yes. We'll take one lecture by Dr. Shailen Modi, sir, and one oration which is left by Dr. Patil, sir.
Yes, better, because I will be harvesting just as a bone. Okay? नाही तरी अजूनही काय मजा नाही. रेडनेस जो आहे तो कमी करायचे फारच जास्त.
I invite Dr. Shailen Modi to deliver his lecture on single-handed endoscopic tympanoplasty, open book, inside-out technique. Dr. Shailen, please.
मला बोन हे दे नाही दिलंस तू अल्युमिनियम फॉइल. I don't know about this camera. The boss is here. He will decide. इसका आवाज बंद कर रहा है. इसका आवाज बंद करो.
त्यांना सांगितलंय मी, ते म्हणाले
हे बदलून सगळे
नहीं पाँच में इधर वीडियो
Good evening, friends, and I am very thankful to Dr. Khan sir and Dr. Sabnaman for giving me the opportunity. I am Dr. Shailen Modi from Ahmedabad. After viewing this Olympic champion, it is very difficult for you to examine or listen the Ranji Trophy player. I started my endoscopic journey since 6 years, and how I prepared the ear for endoscopic tympanoplasty and how I do the normal surgery differently. I want to talk regarding that. For any endoscopic tympanoplasty, preparation is essential. How to remove the hair from the external canal, how to clean the ear, and how to prepare the OT setup. It is very important. Normally, I remove the hair from external canal before 2 days, so we can get the antiseptic effect and we can start the antibiotic dose prior to the surgery. Normally, I prefer a wide canal and the dry ear, minimum 6 months dry ear mandatory. I use 3 centimeter and the 11 centimeter endoscope with 0 degree, 30 degree and 45 degree. and I prefer Storz as well as the Smith and Nephew scope. I do single-handed endoscopy. For that, some special instrument is required. I have some penalty set, and this penalty set have a different angle instrument with suction. When suction tip, it is a 360-degree rotatable. So it is a very useful instrument, and many times the doctor does not require the two-handed endoscopic surgery. The single-handed can do the work. How I prepare the ear? This is this OT setup, and this is a terabichi. We prefer the sickle knife. I do with the coblation wand. When there is a for sub-channel, it is a special coblation wand. Normally we use for snoring, and I can trimming the margin without any blood. And I also do the trimming with the penalty set. This is a special instrument with a sickle knife with suction. So I can remove the margin very well. Now I am doing this tympanometer flap elevation. It is an open book technique. I put an incision at 12 o'clock and 6 o'clock, and I remove the tympanometer flap from lateral, medial to lateral. Normally, we do with 360 elevation, but this is a new technique with a single-handed scope and with penalty set. I put an incision at 6 o'clock, and I am elevating the tympanometer flap on both the sides. Why I am using this open book technique? Because many times when I require only type 1 tympanoplasty, it is very useful. This is an anterior flap, this one is a posterior flap, and we can see the middle ear very well after elevating the both flap. Now we can see the annulus, we can see the eustachian tube opening and the IS joint. This is a 360-degree view of the middle ear. I have a 30-degree endoscope, so we can see the eustachian opening, sinus tympani, and the many hidden area. How I do the syringing of the eustachian tube? I have two curved cannula. So one is for syringing and one is for suctioning. Many times in 30% patient having a eustachian tube infection, hidden pathology. So my endoscope is going inside the middle ear. We can see the eustachian tube opening. Now I am syringing, and you can see the pus is coming from the eustachian tube. For getting a better result, this hidden pathology should be removed. How I prepare the cartilage? I normally do the cartilage tympanoplasty. Already we examine or we view the how to prepare the cartilage, so I am not repeating it. After harvesting the tragal cartilage, suppose the patient having a very hard cartilage, I do the slicing of the cartilage. If the cartilage is thinner one, then I remove the perichondrium from one side, and I have a special instrument to measure the size of the cartilage. This one is small, so this angle forceps, it measures from umbo to annulus, and I have this special titanium chamber, so I can measure and I can do the Modi sponge technique. I am pushing the cartilage after removing, and I can see the exact annulus measurement. I am making a malleus nib for a better placement. I am keeping the perichondrium on the margin of the perforation, margin of the graft, so I can easily put, and the post-operatively I can get better result. After preparing the cartilage, now the placing of the cartilage. Already we measured the annulus measurement, so there is no hesitation to put the tracheal cartilage inside the repositioning. After placing the cartilage, I will put both the flap back, and we can get the good result. I am not putting any gel foam inside the middle ear. This is a type 1 tympanoplasty, so there is no need to do any ossicular chain reconstruction. I am putting this posterior flap back. And the final result should be like this. After putting the cartilage here on the malleus, and we are anterior and posterior flap, we are making, and there is a good sealing, so the result is good. And this is a post-op finding of the cartilage tympanoplasty, and we are getting the good result post-operatively. In cricket, suppose we are using the red ball or white ball, the rules remain the same. Like the microscopic, endoscopic, or single-handed or double-handed endoscopy, our aim is to give the better result. I train with Dr. Prayer and Dr. Paniti sir, and I'm making a big hospital in Ahmedabad, and this is a comparative trial of the cartilage tympanoplasty versus temporal fascia grafting. Thank you.
Hello, any questions? Question.
Two things you are open book you are doing. Is it for subtotal or it is for even central perforations? One, how are you going to elevate the what do you call as annulus?
Annulus, yeah.
One, inside, if you are doing inside out, are you going to cut the tympanic membrane and then you get the thing book open, or how are you going to open the book?
Yeah.
When you have if it is a subtotal or total perforation, the way technique you have described is really relevant. But for perforations which are only just central, if you are going to open that way, how are you going to keep the fibrous layer of the tympanic membrane intact, which has the intrinsic property of keeping the thing in? So, is there any study comparatively which you have done, or there is anything else?
In subtotal perforation, I do the inside out, this type of open book technique. But in routine mild to moderate perforation with a good drum, I do the 360-degree elevation with single-handed endoscopic tympanoplasty.
That is it. If you are doing a subtotal, this technique really works well.
Yeah.
Because within 1 week, you will see the results. They are excellent.
Yeah.
But with when you have a small perforations, you are not supposed to.
No.
We are doing also. We are also doing the same thing at what you have done.
Okay.
Do you have any experience with the general instruments of ENT for single-handed? You're talking
Yeah.
about penalty.
Yeah.
Did you find any great difference in both?
This is a single-handed endoscopic tympanoplasty, and with a penalty set, I don't think a two-handed endoscopy is needed. Only
What I'm saying, with the traditional ENT instruments, with a single-handed, which I do, and I have done with penalty also, I didn't find any great difference.
Sir, there is no difference, sir.
Do you feel the same way? Do you feel penalty gives you a big advantage? They are very bulky. They are very bulky and they are not very.
suppose we have some hand support, then I think a penalty set is very useful.
Yes.
Sir, routine surgical, this thing is sufficient for doing a single-handed.
Many Indian company came with this penalty set duplication, but the
Santosh has developed a suction this thing.
Suction.
Suction.
He made a
No,
circular
the
knife.
problem there is
Circular knife.
the round knife doesn't project beyond your suction.
True.
True. If you are using that, can you see that the round knife doesn't project beyond the suction? And the amount of cut you are going to get is very less when you are doing with the suction. So that we have abandoned. Routine
instruments.
Round instruments with a good hemostasis by cotton and adrenaline is the gold standard when you are elevating your flaps. Rest of the things, you have to bend some of your instruments to reach the epitympanum or hypotympanum. But that is only when you are working or you're doing a epitympanotomy or a mastoidectomy with the sets. So, Pinati doesn't give you, sir. We are all, that's what I was about to say. Why not Indianize the surgical this thing where a junior, when he has, sir had a problem, he is using a simple burr. How many of my PGs can afford a microscope? How many of my PGs can afford a laser to do this thing? He can use a simple instrument which is very cheap so that we can all start doing surgeries at a peripheral center also.
I am using microscope along with the endoscope. When I'm harvesting the thecal cartilage, I am very easy and I am very comfortable with microscope.
Sir, there is no question of quantitating between penalty and routine equipment.
It is
basically whatever is
technique.
good for you, that is more important, and you should give the results. That's all. Penalty is a good set. I am also using penalty, but they're good. Not to contradict for that. Whosoever is comfortable with what, that is more important. Yeah.
Yeah. Thank you very much.
Thank you. Thank you, Dr. Shailen, and thanks for the healthy discussion which followed. Wait. I request Dr. Hetal Marfatia to felicitate Dr. Shailen and give a certificate. Okay. Yes, sir. I request moderators for the previous session. I request the moderators of the previous session, Dr. Pilu Hakim, madam, please come on the stage. We would like to felicitate you. Dr. Hetal Marfatia, Dr. Gauri Belsare, Dr. Ashish Bhumkar, Dr. Man Prakash Sharma. I request President Dr. R.N. Patil, sir, to felicitate all of them.
Yeah, Glomus will start panel of the okay, the next second over.
Okay. Thank you, sir. Thank you for doing the honors. Okay, thank you. Now we'll be going for Master of Ceremony, Dr. Khan's creation oration, DKC oration. The oration will be delivered by our President, Dr. R.N. Patil sir, on the subject, a journey from microscope to endoscope, what we learned. For this session, I call upon Dr. Gangadhar Somayaji, Dr. Rajeshwari, Dr. Kameshwar Rao, Dr. Jivan Vedi, and Dr. Sachin Patel, sorry, as chairpersons. Sachin Patel, sorry. Now, to elaborate about this particular oration, I request Dr. Sapna to say a few words about this oration. Dr. Sapna.
Hello, good afternoon all. DKC oration, DKC, that is Dr. Khan's creations. As the name indicates, it's a brainchild of Dr. Mubarak Khan sir, and he's the founder, member, and the director, along with Dr. Shirin Mubarak Khan and me, Dr. Sapna Parab. Dr. Khan's creations, that is DKC, is visionary in the field of medical innovation and has one of the groundbreaking partnership firm that is reshaping the landscape of surgical instrumentation. As I already said, it is formed by three of us, and it is at the forefront of developing the instruments. This firm, born from the collective expertise of three of us, has quickly distinguished itself in focusing on innovations and quality. Our pioneering work in creative specialized patented instruments. And I'm proud to say that we own two patents, one Indian patent on Justach, which is a attachment to an already existing microscope so as to convert it into an endoscope holder. And the second, we have got an US patent for EndoHold, which is a portable endoscope holder for doing endoscopic ENT surgeries, which are done by the two-handed technique. At present, the firm has 20 innovative surgical instruments and has trademarked 24 instruments. This oration is an attempt to focus on delivering cutting-edge technology and innovations in the field of EES and minimal invasive surgeries through invited lectures from eminent surgeons, speakers, and scientists. I call upon Professor R.N. Patil, sir, who is the pioneer of single-handed endoscopic ear surgery in India, to do the honors and start the oration.
ऑडियो को लगाया है ना ये थोड़ा वरती कर एक व्हिडिओ चेक करता काय परत मध्ये कर नाही व्हिडिओ चालणार ओके At the outset, I would like to thank Dr. Mubarak Khan, Dr. Sapna Parab, and other organizers in the SEO for inviting me for this oration. And I also thank them for making me the president of the society for the last 2 years. And I have been given the oration on endoscopic ear surgery, how I started and how I progressed in the last 23 years. So regarding DKC, DKC is Dr. Khan's creations, and my mouse one. See, we first mouse is not moving correct.
I don't know.
Though I'll have to see here rather than there. Okay, this is I met Mubarak Khan in 2005 when the first endoscopic ear workshop was being done there, and after that time he was still a microscopic surgeon, and in 2005 and between 5 and 10, he experimented with endoscope. Sorry, I'm having a difficulty with this mouse. Something is in place. Can you shift? Sorry. नहीं थोड़ा जगह चाहिए इधर. This mic also can go behind. Okay. So I'm routinely accustomed to my mouse for presenting my things, but here I'm finding this difficult. See, it's moving like anything. Okay, I'll use this mouse here, and between 2005 and 10, he experimented with endoscope and published an atlas of endoscopic ear surgery. So the 2010 onwards, by trials, he invented Justach, and just later the multi-action self-retaining rotatory endoscope holder and many instruments. Have seen today, whatever the discussion about Fenety instruments, so many angled instruments he has made, and he has used yesterday during surgery. They were very good, and definitely they will help in surgery. Then he was instrumental along with me and Virender Gaisas. We did the first endoscopic cadaver dissection workshop in Talegaon here only. And then at Navi Mumbai, we had a workshop both together where he operated 3 cases two-handed, I operated 3 cases one-handed. So endoscope is like a shift. A paradigm shift has occurred in endoscope. Previously, microscope has taken for last 102 years, it was microscope. But the last 3 decades, it is endoscope slowly coming into the picture. And Tarabichi, Badiraldine, and so many others in other countries have developed. And here, Mohan Reddy's, Jason Sundarkrishnan, Muthu Kumar are all before me starting the endoscopic year. I started in 2001. And in 2001, I started because Dr. Virender Gaisas was a PG with us, and he said, we'll read an article. Dr. Mubarak Sarabichi's article he read, and we started endoscopic surgery next week. I'm grateful to Dr. Gaisas for organizing 3 endo-ear workshops in Talegaon and also 2 cadaver dissection workshops. I operated solely with microscope for 23 years from 1978 to 2001. But last 23 years, from 2001 to 2004, I have found it very advantageous. Initially, there were a lot of resistance. The first thing was again in Pune. I was invited to Pune for an oration on rhinoplasty. I told I will present on endo ear, but they didn't agree. So then after the oration, last session was a ear panel. And uninvited, I was called as a panelist there. I was not prepared with anything. And everything when they asked, I said endoscopic. But then Dr. Pusalkar was the moderator. People started asking me directly questions. He says, I'm the moderator, you ask me. So in a jovial way. Then afterwards, when I went on telling more things, he asked, Professor Tipan was in the audience, sir, can anybody do with this endoscopic? How, Dr. Tipan was saying, how through a small keyhole somebody can operate endo ear? So then, and I was encouraged by Madam Pilu Hakim. She came to the audience stage and told, somebody is doing something new. Let us encourage him. So that's why I'm lucky that she's there in the audience today also with us. Then came in Madras, 2004, there was a otology conference, and I was struggling to show a second look mastodoscopy, and I was not given the opportunity. Sundar Krishnan was presenting in the morning breakfast session. He presented on endo ear, and the whole audience was full, and the audience were against him. And then he told somebody else in the audience doing that. Then I told that I'm doing that. Then they gave me the opportunity to show in the second look video. Then after that, everything has been good. There were 16 panels, which have all been encouraging after that. And the encouragement was so much that the hosts of my 10 workshops from 2004 to August 2005, 20 months, I did 10 workshops on endo ear. And I thank Dr. Rakesh Gupta to give me an opportunity to demonstrate live ear and cadaver dissection in Raipur National Conference. And then I thank Dr. Girtane for giving me an opportunity to go to Kenya for the workshop. Then I can thank Dr. Khaja Nadudini three places he was the HOD. He made my endoscopic ear workshops. Dr. Dhakeshwar in Manipur called me for 3 workshops in 3 institutions of Impal. And then I had 3 instructional courses in IOHNS Calcutta, ISOCON Calicut, and ISOCON Calcutta. So because of this, it has progressed. My fractional role in this shift of paradigm from microscope to endoscope is because of the hosts and delegates of my 46 live surgical workshops, my PGs who struggled with me for their thesis, 7 PGs, and then the hosts and attendees of all my lectures and panels, and the chapter on endoscopic colostoma, which was published in the Atlas of Head and Neck Surgery by Bachchi Hathiram and Vicky Katar. So because of this, it progressed. These are the theses which our PGs did, and everything was on endoscope. Then the hosts and delegate of my 46 live surgical workshops have become panelists, faculty, have conducted live surgical workshops. These following Mubarak, Sapna Parab, Dhakeshwar, Ranjit Peter, Gadag, and Chetna Nayak and Kageshwar Raut. They all have conducted workshops. There are other people who have been faculty in the other workshops. And books have been written on Endo Year by Mubarak, Sapna Parab, Hazarika, and Arulanand Das. He has written on stapes. They are delegates. These people's workshops, their delegates have given rise to further followers in Endo Year. So it has been advanced by the people. Like Mubarak has given birth to many. So that way, many of these 5 people who have 5 workshops, they have all progressed and helped me in. My shift to endoscope is not total. I use endoscope for majority of the tympanic work in the ear surgery. I still prefer microscope for the mastoid part, for clearance of colostoma from the stapes footplate, only if it becomes mobile, and difficult reverse epidotomies and vascular tumors. Otherwise, most of the time, I do it endoscopic. I'm going to talk on these aspects, advantages, disadvantages, preparation, instruments, and various surgeries. We can shift to any field easily. The cine or movie effect of the camera, it's a movie camera. So it goes to any spot where you want to see. No repeated focus adjustment. Just pull the scope away, you got a wide angle vision. And angled vision by the scope helps in going around the corners. Angling of the scope and angled scopes help. And vision is possible beyond the shaft of the instruments. Magnification by the TV monitor is high. There's no neck strain, no bending. Assistants can see and coordinate the needs. Recording can be done. It is the same field as the surgeon. Teaching is very good, so you can direct the PGs what you should do, what should not do. Publicity is good. Investment for a beginner. Just now somebody was telling we can't buy many things. So at least endoscope and camera they can buy and they can start ear surgery. Basic ear surgery, not the big things. One eye and one hand is adjusted by practice. Microscopic stapes and FES is all one hand and one eye. Advantages of bleeding and drilling, I'm going to show here. I make the ear dry by using vinegar. One part of vinegar and 5 parts of saline. I mix and wash the ear and make it dry, and then put a wick containing antibiotic, photobiotic, antibiotic, anything of this sort, and that cleans the ear, and ear becomes dry, and we can operate afterwards in a dry ear. This is the way a tubotomy area has been dried, and this is the area. You can see the posterior superior pocket, which is very clean because it is made dry by wash. And then I use local adhesion adrenaline. 1, 2, 3, 4 is the rule. 1 ampoule in 2% xylocaine, 3 ampoules in 4% xylocaine. Use 1 in 30,000 for surface and 1 in 10,000 adrenaline for infiltration. 1 in 10,000 for surface, 1 in 30,000 for infiltration. And then this is the way we can drill
Per meatal drilling overhang for stapedectomy. Per meatal drilling of the mastoid tip and the facial.
So per meter. Then I'll come to instruments. We routinely use only the nasal endoscope, 4 mm scope, 18 centimeters, 0 degree. For corners, we use 30 and 45 degree scope. I don't use a short scope for anything at all. Thin scope, maybe for stapes, when a 3 mm wide angle thin scope can be used. 1.5 mm I have never used. It is used for transtympanic endoscopy. We prefer a HD monitor and a 3-chip camera, and cold light source. Xenon produces more heat, LED is superior. Then chair, sitting comfortable chair. There are people who are operating standing, Dr. Mohan Reddy and my son, they all operate sitting. They all operate standing. Elbow support, if it is possible, you can have. And the scope always rests on the external canal. If you hold the scope in the mastoid, it will be starting wobbling. Whereas keeping it supported somewhere, it will not shake. Routine instruments, circular knife, side knife, sickle knife, all the routine instruments which we use in here are used. And Mubarak has modified some of these, and they may be much better useful for things which you saw yesterday. And also angled elevators, hockey sticks, and then fine angled picks, micro crocodile forceps which are turned up, down, and side, and house suction tip, the terminal part bent and curved are available also, which can be used. There are modifications of Ben's instruments have been made by Tarabichi, Faneti, and Mubarak Khan. I feel we should be Indian, try Mubarak's instruments. Faneti's are good, I agree, but I have not tried. Stands, Mubarak stand, Hazarika stand, and then store stands are available. How I wish I was 20 years younger when this double-handed technique came. I would have tried, but now I find it difficult to adjust to two-handed technique. I'm still continuing with one-handed technique. Cartilage slicer will give us thin slices of cartilage. These are all available with Mubarak. Now I go to various surgeries. Laryngotomy, grommet insertion is very easy with endoscope because you get a direct view and no need of speculum, no need repeated adjustments of the microscope, no bending, no struggling for field and focus. From that I go to endoscopic tympanoplasty. Endoscopic tympanoplasty, the first in 78 to 81 when I was doing a PG, my teacher, Professor Kakka, was doing permeatal and microscopic overlay technique, superior base flap, Lester's flap. But then I couldn't repeat the same with other teachers and with other workshops. From 81 to 2001, I was doing the classical microscopic post-oral underlay technique with an anterior base flap. I'm repeating, underlay technique with an anterior base flap with a wide canaloplasty. This is what is classically being done by everybody, and I was doing that for almost 20 years. But then in 2001, when I started endoscopic, I started the anterior base flap. I found it very difficult. A lot of shredding was there anteriorly. So I shifted to superior base flap, and I'm doing well after that. Then regarding overlay was over. Interlay is the best technique. Dr. A.B.R. Desai has promoted endoscopic interlay microscopic, and Dr. Satish Jain, Dr. Prabhu Kannur, and so many others in the audience are all doing post-oral interlay technique with an anterior base flap. The next generation who are from this interlay, they have shifted to endoscopic permeatal interlay technique are Dr. Hazarika, my son, Dr. Santosh, Dr. Rizwan, and many others are doing endoscopic interlay. So interlay is the best technique available. And here in an overhang.
And there was anterior overhang, so we can't see the anterior proportion. This is the microscopic view.
You can see right inside the anterior edge, in spite of the overhang, we can see that.
And there's a tympanostotic plaque.
The other varieties of flaps are there by other people. Katie Patel's no base flap, double toe technique by Dr. Sanjeev, and three base flap by Rai Chaudhary. Anterior base flap is being done by majority. Overlay technique, I will show the. Here we got a supero-inferiorly wider canal, anteroposteriorly narrower canal, and there's a good space for parking the flap superiorly. So we do a superior base flap. We give an incision all anterior, posterior, and inferior from 11 o'clock to 1 o'clock, 11 o'clock anteriorly to 1 o'clock posteriorly. And here we elevate the flap with a circular knife. We elevate from the canal wall. And for a circumferential elevation, we use a side knife. And with this, we reach the drum area and elevate the fibrous layer from the drum. And we go to the interlay plane or the overlay plane, or depending upon that. And we elevate the whole flap off from the sputum. And here we see the ossicular. So I like a superior base flap, and this superior base flap, because canal is old shaped supero-inferiorly, it is narrow anteroposteriorly, it's wider superior concave area, is good parking place for the flap while putting the graft. Full elevations of the sputum are possible, good all-round bony support for graft, and if you can hug the handle of the malleus also easily. So definitely superior base flap is advantageous. And this is the overlay plane, elevated the superior base flap. And we are elevating in the overlay plane because this is a tympanostosis. We are able to elevate properly. This is the anterior recess elevation using a side knife. We are able to elevate from the anterior recess The view so deep inside is so good. There are so many advantages of overlay, but there are disadvantages of residual colostoma. I'm not going through details of that. This is the interlay elevation. From the fibrous annulus from the sulcus tympanicus, and we're getting the interlay plane. So we elevate the fibrous annulus from the sulcus all over, and then we get a plane of cleavage between that and grip the fibrous annulus. You can see the mucosa remaining behind there. So it's an interlay plane. Interlay has got definitely advantages, is the best, but still I'm not able to repeat. This video is my son's video, not mine. And the flap elevation, there's no fear of residual colostoma in an interlay plane. The ossicular inspection and reconstruction is possible, and no burying of the mucosa, so no weeping. This is what Dr. A.B.R. Desai has taught many years ago. So interlay is, according to me, the best technique. And underlay, I go and lift. Underlay, I don't have a video of underlay, but I'm showing a cadaver dissection. In Kenya, I had a fresh cadaver, and in that cadaver dissection, I'm showing the three planes. Sorry. And go and lift the tympanic membrane. This is the underlay plane. The mucosa is being cut off. This is the underlay plane. So we can put a graph just one minute. In the underlay. I should go back. And go and lift the tympanic membrane. This is the underlay plane. The mucosa is being cut off. This is the underlay plane. So we can put a graph even in the underlay plane. And as we go here, attic, we are able to elevate the flap of the attic from the malleus, and then we are able to pull the tympanometric flap off from the area of the anterior part of the trunk, and the whole tympanic ring, sulcus tympanicus and tympanic ring is all clean, and the ossicles are seen. This is a fresh cadaver. Peel graft as a practice for putting graft over that area. Potato peel is being used for and putting a graft for practice. And then we make them put back the tympanometric flap, as we see here. So this is what we make the dissection delegates do it. Underlay has some disadvantages. There's a poor anterior support. So it is made either you elevate it fully anteriorly from everywhere and place the graft, or you make an anterior window and pull it on the anterior wall so that there's no anterior loss of support. Then it can medialize if it is not hugging the handle of the malleus. Either placing the graft on the handle of the malleus or hugging the handle of the malleus will prevent this. Overlap with the bed. You don't want to bury mucosa, so you can use a circular knife with ridges on the surface to remove the undersurface mucosa. So our advantages of endoscope in tympanoplasty, permeatal has been made possible. Even in anterior overhangs, you can do permeatally. Good support for the graft with all the three planes. Out of them, the three techniques out interlay is the best. No visible scar, only a high temporal incision for the graft, and patient can join the army. Many patients come who want to join the army. No mustard bandage, no scar anywhere. And patient sees the procedure, and it's a day care procedure. So now I go to ossiculoplasty. I will not be able to deal much because of shortage of time, but definitely ossiculoplasty is advantageous to shelling out the incus and correcting it and putting it there. I'm not going to detail. All varieties of ossiculoplasty are possible with endoscope. Next is stapes has been discussed already today. Dr. Mubarak Satish Jain showed video, but endoscope, with endoscope, it avoids the speculum and the stand, but you are doing one-handed, avoids adjustments of the microscope, avoids an external erendoral incision by some people, tympanometric flap elevation is easier, better vision of the stapes parts and otociliary focus, even permeatal microscopic stepidotomy is a one-handed technique. I will not show the video, but I will say that in Goa Medical College, when I did the workshop, 3 stapes were there. Morning, the first case I did was my endoscopic. Second, I did microscopic. Then third, what you want? I said everybody in the audience wanted endoscopic, so I did the endoscopic third case. So that shows the vision with endoscope is superior. Then I go to the colostoma. Colostoma, the birthplace of the colostoma is the yellow triangles you see here. Sorry. My mouse. Yellow triangles in the picture, those are the birthplace, that is the attic and the mesotympanum. Posterior mesotympanum and attic are the birthplace of colostoma. So from there, with the angled endoscope, it's visualized, it is possible to visualize these areas. The upper blue arrow is showing from attic inside. You can see from below the attic and the sinus tympani. You can see the lower blue arrow. You can see the sinus tympani properly. And if you do a cortical mastoidectomy and do an epitympanotomy from behind and a posterior tympanotomy from behind, all these, I got small videos showing all these. Endoscopic vision should change our attitude to cholestoma. With the HRCT, we are able to know whether the cholestoma is confined to attic mesotympanum or whether it's going only in the center part of the mastoid. On the basis of this, we can think of doing endoscopic approach first, because we want to catch in the birthplace. Majority of the colostomas are in the initial phase only. So we will be able to sort them out with endoscope. So with which work is first, mastoid work or tympanic work? With microscope, transcanal work into the attic and sinus tympani was difficult. So all of us started with mastoid work. Till 2001, I was just doing the same. With endoscope, transcanal work into the corners of the tympanum is possible. So we all endoscopic ear surgeons start with the tympanic work first. What is the advantage of starting with the tympanic work first? Risky landmarks, ossicles, facial nerve, lateral central canal, everything is when we are fresh. Who is fresh? Surgeon is fresh, local anesthetic action is fresh, adrenaline is there, field is dry. And early incus separation prevents acoustic trauma. Angled vision helps to clear the sinus tympani, hypotympanum, protympanum, all the areas are seen, and which helps you. We start with the easily elevatable area, the posterior inferior area first. In localized cholestoma, we totally avoid entering into the mastoid. 40% of our cases, we don't enter the mastoid. Even in extensive cases, if you do this work, you have a safe MRM because all the landmarks are shown above are at the beginning of the surgery itself. So these are the views I'm going to show you in the videos. I have classified cholestoma. I attended a Japan cholestoma conference where there was a discussion whole morning on cholestoma classification. I couldn't come to any conclusion, but I came back and thought of this classification, and one thesis was there on this. And here I would like to show you the blue is lower blue is stage 1 mesotympanic cholestoma. The upper blue is the stage 2 attic cholestoma. The green is in the adductus central mastoid or a sac which is elevatable from the mastoid, that is stage 3. It is going to the periphery of the mastoid, like the orange one, yellow one. So it is sending tentacles into the cells of the mastoid. For such a thing, it is stage 4. But it has gone beyond the boundaries of the mastoid. The red one is stage 5. Complications. So for stage 1, when it is a sinus cholestoma, sinus tympanic cholestoma, I'm seeing the all made dry by wash. And tympani area and posterior area. I'm elevating it from the area of the round window and I'm further elevating it from the sinus tympani. And you can see the adductus is patent there, fluid came out from that area. Further, I'm elevating from the incus and further down, I'm elevating it off from the stapes. And after elevating from the stapes, I've got. So this is how sinus tympani could be cleared. So this area, left one is a picture showing the pocket which is made dry, and right is the post-op result of the same patient. And then this is a stage 2 cholestoma, attic cholestoma, wherein we are showing how the attic is elevated. Retraction, and here we are seeing the tympanometrial flap being elevated from the surface tympanicus, and here we are seeing the press space. There's a fold of Von Trolch actually. Pouch of Von Trolch, the fold of Von Trolch, we're elevating, and further we're elevating it from the incus, separating the chorda and the fold, and we are elevating it from the malleus, incus and the malleus. We are elevated from the top of the incus, and it's the anterior malleolar ligament. I cut off the ligament, I cut the anterobuttrus and then put a graft. So this is an attic cholestoma which have elevated, keeping the ossicular chain intact. And then the third picture is showing the adductus I'm seeing clean, and the fourth picture is showing a cartilage. This is a no chip camera, so the color quality is bad. Many years ago. So stage 3, what you have seen Dr. Mubarak do yesterday, I don't have a video, but after initially mesotympanic work, permeatal inside out curating and drilling is done. No need to sauterize the outer canal wall, so lesser drilling and soft tissue reconstruction with fascia and cartilage. This is what majority of the endoscopic ear surgeons do a soft tissue reconstruction inside out. But me and Dr. Taravici, and I don't know who else does, but we would prefer for this stage 3 colostoma. You see the colostoma is in the address. So for this colostoma, I would like to prefer a CAT. So view of CAT.
This is the area of the mastoid cavity. Now, even with a 0-degree scope, if I'm going straight here, this much is the view the microscope will give me. Now, because of the endoscope, I'm able to go deep inside here and see. Still, I'm not able to see the area of the adductus properly or the middle ear properly. But so I'll be shifting to a 45-degree scope to show you that area.
Now we are using the 45 degrees endoscope. And we are elevating from the facial now. We are elevating from the upper attic. So we are able to clear the disease from the adductus. Now I would like to show how epitympanotomy and CAT can be done with endoscope.
We see the here we see the colostoma being elevated from the tensor fold, and posterior to that you can see the area of the notch of the ravenous has been totally cleared, and the undersurface of the scrotum is also very clear. Now we are doing the posterior tympanotomy and trying to open up the
whole attic is completely clean.
Using a diamond burr and with endoscopic control, and here we see the
notch of ravenous is preserved.
The sulcus tympanicus artery is preserved. We see the here we see the colostoma being elevated from the tensor fold, and the notch of the ravenous. We see the here we see the colostoma being elevated from the tensor. Now control, and here we see the notch of the ravenous and the sulcus tympanicus artery preserved.
So we are able to elevate, we are able to preserve the structure of the sulcus tympanicus and the notch of ravenous, and we are not curating much. So even posterior tympanotomy is easier, and a smaller posterior tympanotomy can be done. Epitympanic view I have shown. Under surface of the attic can be seen, and adductus and attic, everything can be seen with endoscope. So it's advantageous to do for stage 3 and stage 3. For stage 4, when the ossicles, when the colostoma is going to the periphery of the mastoid, it has to be MRM. For stage 5, it is a radical mastoidectomy. There's no change about them. So conclusion, for all tympanic work, hypotympanic, mesotympanic, attic, epitympanic, posterior tympanotomy, all work is done endoscopic, either microscope or headlight, only for cortical mastoidectomy. And here I'm having a how hearing can be.
We have placed the socket on the head of the stapes, and you can see the round window.
You can see the simultaneously, you can see the round.
Seeing
the upper 1/3 of the eustachian tube. The discussion was on eustachian tube yesterday. Upper 1/3 of the protympanum is seen, and just now the doctor showed the wash of that area. We do all that, clear that area, and we can see the whole mucosa and the eustachian tube. We will place Vicryl to prevent adhesions. 1-0 Vicryl. And then in MRM revisions, if somebody has a problem, smoothen, we helps in smoothening cavities, lowering facial ridges, removing recurrent granulations, removing residual and recurrent colostoma. We can regraft in failures. We can improve hearing by ossiculoplasty, and no external incision. So it is easy to convince the patient for the revision. Now, this is a patient where an attic colostoma was there. I have done a CAT and reconstructed with cortical bone graft with the hope that he can join the army, but the color is different and he couldn't join. Color of the bone is different. So here is the video showing the CAT. Here is the same patient with attic colostoma. We have removed the flap and removed the colostoma from the attic and from the mesotympanum, and we have put a cartilage graft on the attic, and we have put an incus between the malleus and the stapes, and we put a graft on that area. 6 months later, we are entering from the same area, entering the mastoid, and there's a mucosal fold between the attic and the mesotympanum, and we are breaking open that mucosal fold, and we are seeing the malleus neck and malleus head. We are able to see, and under the malleus, we are seeing the incus sitting on the head of the stapes. We are seeing the tensor tympanic tendon, and there is no colostoma anywhere inside there. So here is a. So thus our views on any any colostoma, if you have hidden it by CAT or by closed technique, you better to have a second look. When to do, why to do, what to do, I will not be able to talk here. It will take more time. I'll now go to endoscopic cadaver dissection. The endoscopic cadaver dissection, important for beginners. Mubarak and Virender Gaisas, we started the endoscopic cadaver dissection first time in Myanmar in 2014. And some Mubarak's and Sapna's sheep head dissection workshops have motivated many people to start endo here. And I was lucky to get in guiding the hands-on cadaver dissection in my 4 foreign workshops, Nepal, Bangladesh, Kenya, and Malaysia. At Kenya, Professor Taravici and me demonstrated cadaver. He was first, he got a dry bone like yesterday. I was the second person doing, so I was lucky to get a fresh cadaver where there was bleeding. Last 2-3 minutes. Doing a dissection, 2-3 minutes in Kenya. Making the superior base flap, cutting all around the canal wall, elevating the flap superiorly. It was a fresh cadaver. You can see bleeding coming everywhere. And as I reach the middle ear, I reach the tympanic membrane. I'm getting a plane of cleavage from the epithelium. So this is the overlay plane. I'm elevating the epithelium from the overlay plane. Now I'm further lifting the annulus fibrosus from the mucosal layer. So that is the interlay plane. So we can put a graft in the interlay or in the overlay plane. But we'll now go and lift the tympanic membrane. This is the underlay plane because I have already shown you that remaining part of the video. Yes. So our steps which they do with the cadaver dissection people. Now I would like to conclude my talk by saying for beginners, be ready, keep some time, be ready for initial struggles, keep sufficient time without pressures. Microscope is kept standby, but don't give away easily. Rome was not built in a day. We all have struggled. I'm still struggling to do two-handed technique. I'm unable to do it. But we should start in the OPDs doing diagnostic otoendoscopy, later wax cleaning, meryngotomy first and meryngotomy with grommet insertion later, then a meryngoplasty in a wide canal, then is checking colostoma from sinus tympani and attic for after microscopic work, then shift over to CAT, second look, MRM, stapes. So that order. So path for the engagement. For those already adjusted to the microscope, switch over to the endoscope may be a struggle. However, beginners have an advantage. Also, teaching and learning are better and cheaper. So endoscopic ear surgery may be a better path for younger generation. However, I feel beginners must practice both microscopic and endoscopic cadaver dissection before venturing on endo ear. I would like to say that Amitabh Bachchan's song, Kal aur aayenge mujhse behtar kehne wale, that song, true, as many endo ear surgeons mujhse behtar ban chuke hain. In the audience have seen so many good videos last time and this time, and so many people. Kyun koi mujhko yaad kare? That also is not true because Mubarak and others have invited me and evoked nostalgic memories of my last 46 years. Thank you all. Okay.
Thank you, sir. Your journey has been really illustrious and inspiration to all of us. We would like to felicitate sir, and for that I call upon Dr. Mrs. Khan. I would like to call up on stage all the chairpersons, Dr. Gangadhar Somayaji, Dr. Rajeshwari, Dr. Kameshwar Rao, Dr. Jivan Vedi, and Dr. Sachin Patel. To do the honors, I call upon Dr. Deepak Chandra Lehua from Gujarat. सर वहां देखिए
हॅलो चालू राहू दे ना ते हा ते हो ते चालू राहू दे तुम्ही माझा व्हिडिओ
सर्वांचे झाले सर्वांचे झाले सर्वांचे झाले
हेलो हेलो उधर से बंद किया है क्या
Hello?
हाँ हेलो कैन यू हियर मी
Hello? You're not audible, sir.
नॉट ऑडिबल हेलो
Yeah, now you're audible. Yeah.
Okay, so this was a pediatric cholesteatoma I have done inside out, and there was a lot of granulation surrounding the stapes. I have meticulously cleared that. Facially is little bit exposed, and you can see the mastoid. I will just take it out. I hope the picture is good there. Just 15 minutes you take and then again carry out the things. So Satish will be taking his jugular there, but you can finish your panels or whatever, all other things. Huh? Dr. Sapna.
Yeah. It is audible.
Hello.
Yes, sir. Yes, sir. Yes, sir.
Yeah. So now just want to show you what I have done. Can you see that inside out?
Yeah, very clear.
Hello.
Hello.
There is no one to. Hello. Hello. Hello.
Hello, Mubarak.
Yeah, hello, sir.
Hello.
Hello, sir.
Hello. Can
Yes,
you hear
sir.
me?
We can hear you.
Yeah, you can see that I have cleared everything. Hey, just give me the ballpoint. Just I will show you the anatomy. This whole of incus was eroded. I have taken it out, and the stapes was completely surrounded by granulations. So I meticulously taken it out. So this is the inside out. This was an adductus ad antrum. This is antrum. This is a mastoid. So it's completely clear. Some polypoidal mucosa. Can you give me the good suction, small suction?
Can you give a good wash to the cavity, sir, so that we can see the structures around the
Yes, because this is a lot of granulations and polyp was there. So that's why this is hyperemic and
okay.
bleeding. So, yeah. So, but still we will give the wash. Lot of granulations were there, and it was very difficult to find out the stapes. Later on, you can see this same video on my YouTube channel. We will upload it. Take it for ballpoint, because you must have missed many steps there. Ballpoint, be fast. Even I have prepared my cartilage, that is a whole cartilage, to fit over the stapes. So I have taken out the head of the malleus.
Audience wants to see stapes in a much clearer way. If you can suck out, or if there is some hyperemic
Yes,
mucosa.
ते जरा मेरे को इधर दिखाना वो कैसे दिख रहा है उधर से
If you put it, it will come up. Gelform or Merosil with an adrenaline, that will really reduce the size of the granulations, so you can remove them.
ठीक है I will point it out.
Sir, everyone wants to see the facial as well.
Yes, now the anatomy. Can you see the facial?
Okay.
The white thing? So
Yes,
that
yes,
is
we can.
almost canal is gone. Huh? I have
Yeah.
meticulously taken out the all properly. Here is a step piece. Still some granulations are there, but I'm not going to touch because the facial is exposed there. I don't
Okay.
want to, because I have removed lot of polyp over this. It was completely surrounded by the lot of granulations. So I will keep these small granulations. I'm not going to touch the facial there. And the step is I have freed it. Now it's mobile. And this is a facial chorda. This one is chorda. And then we will go from here. Anterior tympanum. Let's go inside. From here, I will show you the tensor fold. So this is a part of the malleus which is remaining. So this area is nothing but a tensor fold. It's a block. So I will open it from here. See this. Okay. Just opposite this will be this is a cog. This is a hypertrophied mucosa. I open this fold here. See this. We can cut now the tensor tendon and I will then see. Give me the Caesar. Can you see that? This is the area of the tensor fold. Okay, I have opened that already. And now this will go to the supratubal races here. And this is a processus cochlear. This is a tendon. So the processus cochleiform is here. This is all hypertrophied mucosa. When such type of mucosa is there, what we are finding is that PRF are working very nicely to restore back the function. So let's go a little bit in. We'll put the suction. So this is the area of tensor fold, just in front of the tendon. Okay, appreciable?
Yes, yes, we can see that.
Yeah, this one, but this is a hypertrophied. So I don't want to take out some mucosa I have to preserve that will return back to the function and it will cover. So PRF will take care.
Can we trace the supratubal recess towards the eustachian tube opening?
Why not?
Yeah. So
Let's give me the. I'm sorry because I can see your picture must be very red. Hmm?
yes, sir. Yes, sir.
Yeah, that is some problem with the what you can call the file selection. I think. Yeah. Give me the circular. So this is the remaining part of the TM.
Okay.
Anterior wall, posterior wall. So this is the remaining part. So elevate this. We'll take out the malleus. It's of no use.
Yes, exactly.
Yeah.
So I
This
think
bleeding is
mucosa is still
very much lot of mucosa, you know, lot of hypertrophied
hypertrophied
mucosa.
at the
Yes.
eustachian tube opening as well.
Yes. So let's first take it out the malleus portion. Caesar. ही नको.
Okay. So people are observing over here that the margin of the perforation are 80 meters. Would you like to trim that further or?
Come again?
People over here observe that the margin of the perforations are 80 meters. And
Yes.
you like to further trim them or you just elevate
No,
them? Or
I'm not going to trim that.
Okay.
Because I need something, because he's a pediatric child. This is an 8-year-old
Okay.
child. I
Okay.
want something, some squamous epithelium to grow over my graft.
Okay.
And,
Okay.
and then I will request to or pray to near nature and my PRF that he let it help this child.
Okay.
Just that is on a lighter note, but that's what I can do.
Still, we are not able to appreciate the eustachian tube niche because
Yes,
kindly
exactly.
probably will have to rotate the head interiorly.
No,
or
I will show you, but just I will control that small bleeding. This is from the mucosa. Give me the abgel. Eustachian tube is here. My suction is there.
Yes, yes.
Okay.
Okay.
But I will show you. From xylocaine adrenaline pack, abgil. We will wait for some time by putting xylocaine adrenaline pack. That's my flap. Give me this. We will wait for. अरे उगाच टाकू नकोस काढ ना ते कशाला टाकते We'll wait for 2 minutes. Until that time, I will show you how I have prepared that grafts. So give me the forceps. So around 6 millimeter here and on 10 millimeter there. Give me the cartilage and my that whole cartilage. Already hole has been made. This is for the head of the stapes. Okay? Hello? Hello?
Yes, yes, we can hear you, sir.
See this is the whole of the stapes.
Okay.
For the stapes. So I will be putting this over the stapes head. Rest will be resting on a promontory.
Would you not prefer using a pop kind of prosthesis in such case and covering with the cartilage?
I have used a lot. I have still am using for certain times, but this is a pediatric age group. How much it is
Okay.
going to work? I don't want to give much pressure by putting the cartilage over the PORP also. Okay.
Okay.
So later on, we can revise if the patient becomes completely dry and all. Later on, we can revise. Till that time, type 3, it will work. Myringostapedopexy with this
Okay.
whole cartilage.
Whole cartilage. Okay.
Yeah, give me the blade. This is for 1, 2, 3, 4, 5, 6. So I think this will work. We'll just assess. Give me the forceps. Okay. I am just assessing whether it is fitting. Cecal. Yes, it will fit. This will go like this. Okay.
Better. This will go like this. So let's see whether the bleeding has stopped. Give me the forceps. Fast. Better. Forceps.
Would you consider using a bipolar cautery that the mucosa?
No.
Okay. Because we saw.
Because facial is exposed there, huh? Yeah.
In that part, it's pretty anterior to that supratubular recess area.
That's not that much bleeding. So
Okay.
Okay. We can keep a Abgel there, and then just to show you, I am just making those. Yeah.
Okay.
Okay. Just we'll keep the suction there. Let's go near. Can you appreciate?
Yes, we can appreciate.
yes,
the
yes.
Can
niche.
you appreciate?
Yes,
See that?
We're
It
seeing.
still seems to be
Okay.
edematous, right?
Now I am absolutely in the eustachian tube. Serious.
Yes.
But that's an edematous. So in
Exactly.
such situation, I will give an antihistaminic for at least for 1 month, and then the nasal steroid.
So what
Because
we
the
have been
pediatric-
doing since last
Yes.
week. Please
Abgel.
hold.
Dr. Mubarak, sir.
Yes.
The cartilage that you are using for reconstruction of the canal wall, as this is a pediatric patient with age, will that be sufficient or that will fall in the mastoid cavity?
Come again? I didn't have.
Sir, the patient is a pediatric one. The cartilage that is being used for reconstruction of the canal wall or to cover the mastoid cavity, will that be sufficient when the child grows? Because the mastoid will grow.
That's very good question. But as the child grows, even the mastoid grows. Okay.
Yes.
Yeah. And then there is a lot of bone in and around what we have seen. I'm going to put some bone paste in and around. So that forms a nice bone later on. So it also is growing. Okay.
Okay.
Yeah. But I will keep following this child because pediatric patients has to be followed. Yeah. And whenever in a private also they come, I always tell them that you will need a revision, might be now or after 10 years, if everything goes well. I counsel all the patients. For pediatric, 100% that consent has been taken. That definitely will be revision is a possibility. Ballpoint. So I think I will put a cartilage and type 3 I will do, and let's then Dr. Parab carry out the remaining sessions. Huh? And the next case is induced there, glomas. In between, you can just go there. Okay, any suggestion, any other different thing you will do here? Hello? Hello?
Yeah.
Everything is good.
Yeah, any
It looks
different
good.
thing
It
anybody
looks
will
good.
do?
What I was just talking about, the addressing eustachian tube in such patients would be, I usually pass on an epidural catheter out of 418 number and apply a
Yes, that's
negative
good.
suction at the proximal end and suck out whatever mucus plus you are expected to have, because this kind of mucosa, it's angry looking, it's absolutely because of eustachian tube dysfunction. And we need to address a eustachian tube in this kind of patients at the time when we are doing the procedure. That's what I think.
That's a good suggestion. Okay.
Yeah.
Let's do that.
in some cases. But I try to see inside the eustachian tube.
Yes,
Yeah,
sir, but that's
even,
the only a
yeah.
proximal part of the bony canal that you
Yes,
see,
and
and
then
it's pretty much edematous. Even just
yes, and
to catheterize, you will have to decongest opening just by putting a xylometazole in F-gel for a few minutes.
yeah.
That will give you some decongestion, and then actually you can pass on the catheter. That will give you the catheterization of the bony canal.
Right. Fecal. PRF, you keep the PRF ready. See this?
Yes,
So
yes, we
this has
can
been,
see it so
this,
well. Yeah.
so this has been created with that, this punches and all along
Okay,
with that
okay.
slicer, it's there. So it conveys maximum vibration to that stapes. That's an idea behind that.
Okay.
Here there is no perichondrium on, perichondrium has been removed on both the sides.
Both the
So
sides,
over the
yeah.
period, over the period it dissolves. So you can plan for the next, by following the patient, you can opt for the PORP and all later on. Okay. Once the
Okay.
child does well
So
for
this is
2
a
years, 3 years.
temporary arrangement that you have planned, right?
Absolutely. Yes, for this
Okay.
child, it's temporary. Now, PRF. For this diseased mucosa, this will help. And we are having a strong hypothesis that this works. And wherever the bare promontory is there, bare part is there, helpful. See how transparent it is. You can see the hole through that.
Yes, sir, we can see that.
Yes. Now, something for the deceased mastoid, which was having the absolutely loss of ventilation for so many years. Let another piece. SEOCON.
Mubarak, have you measured the PPF? It is sitting exact size.
So that is what my ASM grid, you are right. So I means now my assistant does all these things perfectly. They know what sizes I know, and that is, they do it on a ASM grid. That's just a simple grid where you can measure it.
Good.
Yes, that looks nice. And now my cartilage.
What about you have
First,
kept gel foam
temporalis
in the?
fascia.
Have you kept gel foam in the eustachian tube, or you want to put PF?
Yes, I'm going to take it out. Because I don't like that gel foam in the middle ear.
Yes.
It is better to put PRF there.
Yes.
Yes, the bleeding has stopped. So some PRF there. Yes. So circular.
The edema of the flap edges come down with your adrenaline pack.
Yes, yes.
Yeah. The flap edge is looking better now.
Better, yes. For fascia. Fascia is very thin because he's a child. Abgel. This the fascia is harvested through the same incision. Now let's go. Very thin.
Yesterday's facial art was very thick and good.
Absolutely. I like the consistency of that. But he's a child, just and because the cartilage is also, you see, it's very developing cartilage. Huh? 8-year-old. One more, Abjel. But the beauty of enteral is that now that flap will come over that nicely.
Oh.
And that's like cake. सुरू करा तिथं हो बिलकुल हा हो थोडं तिथं घेतलंय का त्या
Satish sir is going to start right.
Hello.
Can you hear me?
Yes,
Hello?
yes.
Yes,
Yes, you can. Thank you, Mubarak sir. Myself, Hardik, and everyone over here. Thanks a lot for a wonderful demonstration.
Very good.
Thank you very much. Thank you. Hello.
Good afternoon, everyone.
Yes.
Satish sir is going to start a right glomus excision, giving you brief history about the patient. 60-year-old female complaining of right side tinnitus since 5 years, right ear discharge since 5 years, right earache since 5 years, and right ear discharge